मैं बोलूँ कंटिन्यू तक ते पहुंचे माइक इथे इन तो सामने क्लियर आ इनू किदां होना है
Hello. Please attention everyone. We are starting this session, so kindly be seated. Hello. The speed of your success is limited only by your dedication and what you are willing to sacrifice. Good morning, Excellency, distinguished guests, senior authorities, and delegates. I am Gursimranpreet Kaur.
And I am Sukhmanjot Kaur.
So we are profoundly delighted to welcome you on behalf of SGRD University of Health Sciences on this 4th International and 20th National Oncology Conference. So we appreciate you taking your time off from your busy schedules to join us today. So Oncology Nursing.
So, oncology nursing is defined as meeting the various needs of oncology patients during the time of their disease, including appropriate screening and other preventive practices, symptoms management, and supportive measures upon end of life.
The aim of this conference is to bring oncology concerned nurses under one roof to enhance and update oncology related knowledge. So, cancer is not a death sentence, but rather it is a life sentence. It pushes one to live.
Cancer is a disease caused when cell divide uncontrollable and spread into surrounding tissues.
So, to begin this conference, we would like to invite our very first speaker, Dr. Sushma Saini, to open this session.
Dr. Sushma Kumar Saini, lecturer 9 PGIMER Chandigarh. She completed PhD from PU Chandigarh, MSc in Community Health Nursing, and has 24 years of teaching experience. Member of 13 national scientific bodies, joint editor of Nursing and Midwifery Research Journal, and member of editorial board of many reputed journals. Presented many papers and is the invited guest faculty at local, national, and international conferences. Has 80 publications in reputed journals and is the author of many chapters in various books. She has special interest in reproductive and child health. She is guide for PhD students enrolled in INC Consortium and PGMR Chandigarh. Project Director of Composite Direct Interventions, Target Interventions project run by Indian Public Health Association in collaboration with State AIDS Control Society, Chandigarh.
Good morning, one and all. I'm thankful to organizers for um, for inviting me to be here. Not delaying the session much. I think we need to start. So good morning, everyone. So today I'm going to talk about tobacco, carcinogens, their biomarkers, and aspects of prevention. So we all know about Indian scenario. The smoking is not started now. It is the ages old when the smoking started in India, but it is accounting for so many deaths, like maybe 7 lakh deaths per year, 22 deaths per day, and 3 people every 2 minutes is dying due to the problems related to smoking. 4 lakh cases of cancer and 13 lakh cases of heart problem and 80 to 90% of lung cancer cases and many morbidities due to that is for that the smoking is responsible, and it is second leading factor for disability and single most preventable cause of premature death. And we can, I think this is something which is preventable and we can prevent it. If we talk about India, what kind of smoking material is available? These kind of shops are not very uncommon. You can see these shops everywhere with smoking and smokeless form of tobacco is freely available for use, and anybody can come and buy such kind of tobacco products. And content of cigarette, if I talk about, you can talk hours together about what all kind of carcinogens are present in the cigarette, and there are about 18 to 20 chemicals which are present in the cigarette, and which is, and each product is very harmful. To talk about few is nicotine, which is an addictive substance which does not let the people to quit smoking. Tar, which fixes to our lung. The person who smokes, it gets absorbed and deposit into the lung tissues. And ammonia, it speeds up the rate of absorption of nicotine. And tar is the substance which is the most dangerous for the smokers, and which deposits in the lungs of smoker. And we can see this kind of picture, a healthy lung and the lung of a person who smokes for very long time. So this is what the tar does to the that changes the condition of our lungs. And another important chemical is the radioactive polonium 210. These chemicals are absorbed into blood, reaches every organ system in the body, and cancer causing, mutagenic, and tumor causing. So no system in our body is that which can from which the tobacco does not harm the system. So the smoking impacts every system, and some problems are immediate problem due to smoking, intermediate and long term problems caused by smoking. Immediate problem, like the respiratory symptoms, are the first symptoms which appear to any smoker, which include coughing, wheezing, dyspnea. Then the person gets nicotine addiction, increase oxidative stress, depleting the selected bioavailable antioxidant and micronutrients. It increases impaired immune and alter the lipoprofiles and poorer self-rated health status. And the short-term physiological outcome, it impairs the overall health status, which is in turn rendered the smoking more susceptible for various adverse outcomes such as developing acute illness, respiratory symptoms, and it reduces the capacity to heal the wounds. And depletion of circulating antidoxicant and nutrients concentration, um, because it exposes the smoker to potential oxidative damage. There is a depletion of body's defense against oxidative stress, and 25% less circulating concentration of ascorbic acid, provitamin A, and carotenoids such as A carotene and B carotene, and cryptoxanthin in the smoker as compared to non-smoker. And if we talk about the systematic effect or systemic effect of smoking, it affects all the system. And the cardiovascular system, we can see nicotine, it increases the heart rate, elevate blood pressure, increase peripheral vascular resistance, myocardial oxygen demand, and hypoxia. And while there is a greater demand for oxygen, carbon monoxide, because the carbon monoxide, it mixes with the hemoglobin and produces carboxyhemoglobin. the supply of oxygen by up to 15. Then it increases plasma viscosity, elevated total cholesterol and LDL levels, and in fibrolytic platelet activity. Then it further increases the coronary heart disease risk 4 times greater in the smoker as compared to non-smoker. And smoking is the major risk factor for heart attack and sudden cardiac death. And smoking is the dominant cause of heart disease. Then smoking is again related to the brain stroke. The brain stroke is much higher in the smoker as compared to non-smoker. Pulmonary diseases related tobacco use, there is a deleterious effect on the respiratory system, paralysis of mucociliary transport, that is one cigarette is for more than 20 minutes of paralysis. The restriction of cilia leads increased mucosal production, small airway narrowing, reduced pulmonary surfactant, less oxygen exchange, and tendency for ventilating perfusion and mismatch. Smoking also depresses the body's immune system and other defense mechanism, and smokers are at increased risk of respiratory infections as compared to non-smoker, and smoking accounts for 80 to 90% of all COPD deaths. Then immune system is also affected by the smokers. It decreases the neutrophil activity, impair immunity, and increase the risk for lung infection, impairs wound healing, and attribute to toxin in smoke, which is the result of poor oxygen perfusion throughout the body. Rheumatoid arthritis is another problem which is more prevalent in the cigarette smokers as compared to non-smokers. Then musculoskeletal, there is increased risk of osteoporosis, increased risk of fracture with impairment of fracture healing, and smoking may impair osteoblast function, and non-smoker may they produce approximately 1 centimeter of bone in 2 months, while it takes approximately 3 months for the smoker to make the same amount of bone. So we can think the impact on musculoskeletal system. And then there is the increased risk of herniation of an intervertebral disc. Then all type of cancers, like smoking is responsible for lung cancer, head neck cancer, kidney, bladder, cervical, and gastric, liver, breast. So all sort of cancers, they are much higher in the smokers as compared to non-smoker. And cigarette smoke, it contains 11 chemical compounds that are known to cause cancer and which can expose the passive smokers all the time. Then eye-related macular degeneration and nuclear cataract, that also increases in the cigarette smokers. And any person, if the person is sick, even it delays the recovery. The smoking can affect the recovery from illness and surgery. It increases recovery every time the patient who smokes. Smoking increase the risk of recurrence of person who have survived a heart attack. There are more chances that person will again have heart attack if the person is smoker. Ulcers heal less readily, and there is more likely that they will occur again and again. Then there is a effect on the male fertility and erectile functions. It can harm, the smoking can harm men's sexuality, erectile dysfunction, because it decreases the amount of blood flowing into the penis, impairs sperm motility, reduces sperm lifespan, and may cause genetic changes into the cell, and there may be fetal malformation and infertility. Mental health, the smoking negatively influence the brain development and memory, and smoking is a risk factor for Alzheimer's disease. There are poorer self-rated health status, and there is adverse effect of smoking health status that has been directly measured by comparing self-rated health in smoker versus non-smoker. Smoker will always rate the health status lower as compared to non-smoker. Then the absenteeism increases among the smokers, and there is a increased utilization of medical services because the problems are more. So medical services utilization is more among smokers. Then pregnancy, newborn, breastfeeding, they are all these are also not away from the smoker. The smoking has impact on it. There is bleeding during pregnancy, ectopic pregnancy, miscarriage, premature delivery, stillbirth, and abnormalities of placenta may occur among the women who smoke during pregnancy. Babies born with low birth weight, babies receive nicotine and carbon monoxide from mother's blood. It may contribute to sudden infant death syndrome, and nicotine and other chemicals get into breast milk, and it may decrease the quantity of milk. The mothers who smoke, they may have more miscarriages, perinatal death, and premature birth as compared to non-smoker. And passive smoker to fetus, to this active maternal smoking also causes around 19,000 babies to born with low birth weight. And maternal passive smoking may reduce fertility, increase fetal perinatal mortality, and increase the risk of some congenital abnormalities. Then early childhood, there may be high risk of allergies. The children who are exposed to the passive smoking, high blood pressure in the childhood, increased likelihood of obesity, stunted growth, poor lung function, and increased likelihood of asthma. So there are other health risks. Every system is affected by the smoking. It may be gastrointestinal system leading to ulcers, chronic bowel disease, rheumatic conditions, orthopedic conditions, kidney damage, type 2 diabetics. There are 50% increased likelihood of getting type 2 diabetics among the smokers. Then cataract, skin conditions, tooth and gum problem leading to oral cancer, tooth loss, decay, and periodontal diseases. So the smoking is responsible for all these problems. And I said in the beginning that this is the only preventable cause of mortality and morbidity. And we all know that prevention is better than cure. So it is better to focus on prevention. And we know if the young people, they don't start using tobacco by the age of 25, 26, then they almost certainly will not start. So these are the first 25 years of life which are more prone to start smoking. So we have to emphasize these years of life, and more emphasis why people smoke. Is it due to peer pressure, especially among the young children? They think it is cool because their parents smoke, their siblings smoke, because they want to be skinny, it's a fashion, and they find it very relaxing and rebellion, so they start smoking. So we have to see that where all these factors are working, and then start talking to the children and helping the children not to start at these stages. And the teen smoking decision to start smoking, it always made in the teen years. And this smoking is one preventable cause for premature death, we all know. So these are the teen years where we should focus, because 90% of adults, they smoke, smokers, they are addicted to tobacco before they reach to the age of 18 years. And then they may start at the age of 14, and currently the start of the children start smoking as young as 11 years. So we know that which children we have to focus. Maybe in the primary school itself, we have to be very vigilant and talking about the harmful effect of the smoking, and there only start counseling and seeing that the children, they are not influenced with the people who smoke. So there are the cigarette, there are regulation in India. If I talk about, there are cigarette act regulation which passed long back in 1974, and it was prescribed that all the cigarette packets should get the warning, and then it was prohibition of advertisement. The famous people, they should not advertise cigarettes. It is banned as per this act, and the warning should be a pictorial form, so that looking at the packet, the one gets threatened that what will happen to the person if he smokes. And these kind of warnings, these kind of pictures are recommended to be on the packets of this pan prag and cigarette packets, so that by look at the packet, just saying that smoking is harmful to health is not enough, but looking at the pictorial form, that what kind of harm it can give to health is more that will have more impact. So these kind of pictures are recommended, or these kind of pictures, these are all recommended on the packets of the cigarettes. And then no public activity should be promoted by the tobacco companies, like no sports, no dance, no competition. These all activities should not be sponsored by the smoker companies, because otherwise the children participating in that, they may get influenced by the uh, this cigarette company and all, and they may start smoking. So it should not be. Then Indian law related to tobacco, this ban, this was in it started long back in 74 5, but in 2000 again 5, and the ban on smoking in public places or workplace, ban on direct advertisement of tobacco products, sale to the minors, that no tobacco product should be sold to less than 18 years, and it should not be sold in the radius of 100 yard of any education. Pictorial health warning should be there on every packet, and it should not be only in one language, English as well as in regional language, so that everyone can test, that everyone can read that what is the warning. And this implementation of this law came in force in 2004, and this was implemented, that there is a prohibition of smoking in all the public places, and it's a mandate display of board containing warning, no smoking area smoking here is an offense, these kind of warning. Hotel and restaurant should also ensure that physical uh, segregation of smoking and non-smoking areas, and there need to be labeled as smoking area or non-smoking. Proper location area is also important. Prohibition of advertisement of cigarette and other tobacco products, and prohibition of sales to the minors. So this was in the enforcement, and it was further revised into 2nd October 2008. The ban on no smoking at public places continued, and the person caught smoking must pay a fine of rupees 200. And law pertaining to pictorial warning on tobacco packet was implemented with effect from 31st May 2009. Ban on sale to minors and no tobacco products sold within 100 yard of educational. Then Ministry of Health and Family Welfare, they started helpline for reporting the law violation if the people found smoking in the uh, no smoking areas. People can dial the national toll-free number helpline 1800110556 and register their complaint against the police constables. They are authorized to collect penalty. They can find that they are accompanied by the officers above the rank of inspector and police. So then they can collect the penalty. And then there is further prohibition of Electronic Cigarette Act 2019, because these they may not produce the smoke, but they are equally harmful. So there was a ban on prohibition of this electronic cigarette, its production, manufacture, import, export, transport, sale, distribution, storage, and advertisement. And enforcing the law, it is required for the owner or in charge of the place where cigarette is or tobacco products are sold, that they display a board which contains the warning. And the warnings are like sale of tobacco product to a person under 18 is punishable offense, and that board should not be small, it should be 60 by 30 centimeter minimum, and it should be put on a visible place, and the warning should be applicable in the Indian language, so that all the people can read it. And educational institutes should also display at a prominent place a board containing the warning. And sale of cigarette and other tobacco products within the radius of 100 yards from educational institute is strictly prohibited, and it is offense and punishable with fine, which may be extended to INR 200. So such kind of board should be displayed everywhere in the educational institute. And the second hand smoke, which is equally harmful for the children, for the pregnant women, and everyone whosoever comes in contact with the second hand smoke, because it has the combination of side stream smoke comes from burning tobacco and mainstream smoke which comes from exhaled smoke, and it is also known as environmental tobacco smoke, and it contains more than 4000 chemicals which can be carcinogen, and they are cancer causing, and it can affect any age. So that should also be taken care that the smoker should not expose the people for second hand smoke. To conclude, the cigarette is a unique killing by its both ends, extensive burden of disease because of smoking, damage of various systems of body, impairs quality of life of individual, and the most important preventable factor, need to help and implement the different strategies to prevent smoking, and a policy change that reduces the prevalence of cigarette smoking will result in a commensurate reduction in the population burden of disease and death caused by cigarette smoking. And the take home message is that smoking in any form is bad, maybe smoke form, maybe smokeless form. It is bad and it should not be inhaled. And be smart, don't start. Thank you very much.
So thank you so much, ma'am, for such an informative session.
As ma'am has told us, smoking is an accounting for 7 lakh death per year, 2200 death every day, and 3 people every 2 minutes.
So as we all know that tobacco is one of the leading cause of lung cancer, as tobacco smoke is made up of 7,000 chemicals and 11 of which are known to cause cancer. And tar is the substance among all which is more dangerous. So harmful chemicals in cigarette smoke affect the entire body, not just our lungs. So smoking causes at least 15 different types of cancer.
Remember, so the sooner you stop, the lower your risk of cancer is. Now we would like to hand over this dice to Mrs. Kulwinder Kaur and Mrs. Pooja Joshi to continue.
Ladies and gentlemen, moving further, it's time for us to begin with the inaugural session. Though we are waiting for our honorable chief guest to join us here, she shall be here any moment. We shall be ready with our inaugural session. Kindly have your seats. We are going to begin with our inaugural session within few moments. Kindly occupy your seats. We are going to play a video on SGRD University. As our chief guest and guest of honor, they will be joining us soon. Please switch off your mobile phones. You will be getting selfie time and photograph time when outside the hall. Beautiful audience we have. We want your patience listening. Please save your energies. It is long way to go. We have 3 days to share our words, to share our feelings, our emotions. You will be getting enough time. But for now, we require your patience listening, please.
Hello, hello. Hello, hello. Hello. Hello.
Dr. Manjeet Singh, Director, Principal of the Guru Ramdas Institute. Dr. A.P.
Ladies and gentlemen, let's now please pay your attention. We have a message by Honorable Mrs. Pratibha Jagdish, President ONAI. Ma'am is not able to join us because she was having some health issues. So kindly play this video. So please attentively listen to the video. The message from President Mrs. Pratibha Jagdish.
Manjeet Singh, Director, Principal of the Guru Ramdas Institute. Dr. A.P. Singh, Dean and the Organizing Chairperson of this conference. Madam Dr. Sushma Saini, Principal, College of Nursing. Today's Chief Guest, Madam Achala, Director General of Nursing, Additional Director General of Nursing, DGHS. Guest of Honor, Dr. Puneet Giridhar, who is a Joint Director, Medical Education Research, Punjab. All the executive members of main ONI and the Punjab chapter, dear students and dear delegates. It was very exciting to understand that there were about 650 delegates for this conference. It was like Chetan Bhagat's two states, where Mumbai and Punjab were the two states, and me and Rupinder were talking endlessly, and today it was the tireless efforts of Rupinder who has made this a successful conference. Kudos to Rupinder. Dr. A.P. Singh, we understand that you were the organizing person, and it was your attitude, your philanthropic way of making this, and with the registration fee of rupees 700, with 3 days stay. This was all possible. It was all because of you. Another important person for this organizing conference is Madam Parvesh Singh, who is the principal. As we say Mata, Pita and Guru, I think the College of Nursing students of this college will be very lucky to have this madam, as she's very calm and composed person, and she faces all the odds. So, Madam Saini, kudos to you for organizing this conference. To Madam Achala, we say that we at Tata Memorial Hospital offered oncology nursing and with many subspecializations. At this time, we would like to say that we would like to introduce palliative nursing in the near future with guidance and support. We do have the executive members of the main ONI, the secretary, and all the other persons, and the secretary and the executive members of the Punjab chapter. All of you have worked towards making this conference. We wish each one of you. We do have the two international delegates, Dr. Annie Young and Dr. Isabella White. At the beck of the call, they have come to India. We appreciate your efforts which you have taken to make this conference a very successful one. It is your knowledge and expertise with whom you are going to share with will be a good, useful one for all of us. We welcome you to India. There are many persons in front and at the back who has done various activities to make this conference a very good one. We respect each one of you and regard the same. What at this Oncology Nurses Association of India, what are we doing? We are an association where many interested oncology nurses joined together, and it was started in 1990. What we understand from various medical fraternity is that there is a lack of knowledge in the oncology. What we have done is disseminating the knowledge of oncology nursing. And so what we have done is we have introduced ourselves to many schools and colleges of nursing, wherein the introduction of oncology nursing was done, and it was also done in the syllabus of some of the colleges. We also understand that the core competencies of oncology nursing to be done. So various activities which we have done. There are also some sort of social commitments by this association. So what we have done is early detection of cancer was organized by means of the preventive oncology department. This was spread to all the female employees of Tata Hospital, and we have found around 2 to 3 positive cases which were detected earlier and which would not have been done without association. We have also spread the same to the Maharashtra nurses and their families, and thereby some of them could benefit the early detection. We are also associated with the National Cancer Grid, where many meetings and presentations were done. We have put up our opinions, and thereby we feel that we are growing. There were many tele quizzes, many other competitions, and various other things which have been done. So, what is the future of this association? We are linked with various international organizations, wherein we think that many research coordinating activities we are going to do. There are few modules which we are going to put up. And some of the students will be introduced to the Western atmosphere, and thereby the standard operating procedures will be understood, which they will carry to India, and we are going to put it up. So these are a few of our projects. What we would like the Punjab chapter to do is, it's a great honor for this association to have the Punjab Association too. There are various educated personalities in this chapter. That's what we have understood. We want each one of you to put your informations and disseminate this into patient education, research activities, and various other things. You're being given the entire power, and we all can do this. It is a very good. The young nurses, what we would like to see is you, the young nurses, have been in the clinical activities or in various other activities. We request you to put it down and publish it in the Indian Journal of Oncology Nursing, wherein the voicing out and the publication will be understood by many. So we thank each one of you who has been gathered for this conference, and we wish all of you a very colorful conference. Thank you.
Big thanks to President ONAI. The chief guest is going to arrive. Please switch off your mobile phones. chief guest and guest of honors, they will be arriving. We have to give them a huge round of applause. When they will be arriving, then you have to give a huge round of applause. I'm just preparing you people.
Healthcare is
Announcement करने का?
all of us some of the time, but public health is vital to all of us all of the time. With this motto, we are leading the charge and putting our contributions to public health at Shri Guru Ramdas University of Health Sciences, which constitutes a medical college, a nursing college, and a 900 bedded tertiary care hospital situated in the holy city of Amritsar. Shri Guru Ramdas Charitable Hospital came into existence in the year 1977. At this institute, all our motives are driven by the vision of producing excellence from dissection till reconstruction. The university is synonymous with prowess in health sciences. It is the epicenter of quality healthcare services for the underserved population and at the same time provides in-depth training for undergraduates and postgraduates. Talking about numbers and statistics, we take in 150 students for graduate courses and 60 students for postgraduate courses annually. In addition to this, the College of Nursing admits more than 100 students annually. Keeping in mind the importance of basic clinical skills, a simulation lab has been recently set up to provide immersive learning experiences for graduates as well as postgraduates. The lab has lifelike clinical sim lab rooms, mannequins, and equipment, allowing learners to develop expertise of basic and advanced procedures without any risk of patient harm. Sri Guru Ramdas Rotary Cancer Institute, established in the year 2000, is dedicated to the selfless service of cancer patients. The hospital is a premier medical institution in North India for the diagnosis and treatment of cancer. We are pleased to launch the Fellowship in Palliative Care for desirous applicants across the globe. The hospital has 14 operation theatres stocked with state-of-the-art monitors and anesthesia workstations. There is a dedicated medical ICU, a surgical ICU, a neonatal ICU, a pediatric ICU, a cardiac catheterization unit, fitted with an array of leading-edge technology. The lecture theatres provide an indulging and immersive learning experience in conjunction with well-furnished laboratories where students can lay emphasis on the extremely vital practical aspect of sciences. Expressing our concern for public health, a hospital-based cancer record system has been set up in association with Tata Memorial Institute, through which we are constantly gathering cancer-related data for North India. This data empowers us to predict the prevalence and patterns of the disease while also promoting research for better management. Putting our best foot forward to deal with this pandemic, a molecular diagnostic lab has been established for diagnosing COVID-19. We have also achieved a significant 86% recovery rate for patients with stage 3 COVID. We are proud to share with you our plethora of international collaborations for student exchange programs. Under the aegis of UNITO, our institute has been selected for the implementation of environmentally sound management of medical waste. The project is first of its kind in India as an effort towards societal benefit. Free medical camps are held 4 times a year. The founders of this institute came up with the splendid idea of the All India Sports and Cultural Festival, Resonance. Medicos from all over India reach our university to participate in the most awaited gala of the year. We invite you to continue your quest and explore all that Sri Guru Ramdas University of Health Sciences has to offer.
So it's an honor to be a part of SGR University of Health Sciences. have Shri Guru Ramdas University of Health Sciences on the name of our fourth Guru, Shri Guru Ramdas Ji. He was the founder of this city, Amritsar. Amritsar is a city of gurus. We have Golden Temple, the most sacred place, well known nationally and internationally. Where we go, there is the one name that is in the heart of every person, that is the Golden Temple. And all we will be having an honor to visit the Golden Temple these days. It will be our privilege. So I request everybody to please visit that sacred place. You will be find a peace, lot of peace that you will not be finding anywhere. So yes, the list is vast, ma'am. There is many things to visit here in Amritsar. We have Indo-Pak border, we have Jallianwala Bagh, then we have this Durgyana Mandir. What? Yeah, War Memorial. Okay, what else? The Amritsar's people, please. You can add number of items to the things. Sadda Pind. Okay. Numerous sites to visit. And the food is delicious here. Don't forget to have all the special spices, sweets, sour. You will get every taste here in Punjab. So every corner of Amritsar is having a different taste. Don't get set for golgappas and tikkis now. Formally, we are going to start with the inaugural session. Ladies and gentlemen, the wait is over. Announcing the arrival of our chief guest, guest of honor and dignitaries. बहुत बहुत स्वागत, बहुत बहुत अभिनंदन. We welcome our chief guest, guest of honors, our dignitaries. A big, huge round of applause. A very good morning to all of you, ladies and gentlemen. It's an honor in itself to honor this beautiful audience who has gathered here. I, Kulvinder Kaur, along with my co-host Pooja Joshi, welcome you all on the behalf of whole family of SGRD and ONAI on this 4th International and 20th National Oncology Nursing Conference 2022. Thank you for joining us today.
Let us first acknowledge the presence of some of our eminent guests. I would request Dr. Sushma Saini, Principal, SGRD College of Nursing, to welcome our respected chief guest and present a floral welcome.
With a huge round of applause, ladies and gentlemen, Mrs. Achla, Assistant Director General, DGHS, Ministry of Health and Family Welfare. Ma'am is today's chief guest. Thank you so much, ma'am, for joining us.
We are honored to have amongst us guest of honor Dr. Puneet Girdhar, Registrar, Punjab Nursing Registration Council.
With a huge round of applause, we invite Ms. Anita D'Souza, Secretary, ONAI.
The ideal of knowledge and the man known for his wisdom. Dr. Manjeet Singh Uppal, Vice Chancellor, Shri Guru Ramdas University of Health Sciences, Shri Amritsar.
I welcome Dr. Rita Lakhani, Vice President, ONAI. Huge round of applause, Vice President Dr. Rita Lakhani.
A very kind and enthusiastic personality, Dr. Baljeet Singh Khurana, Registrar, Shri Guru Ramdas University of Health Sciences.
May I now invite Dr. Annie Young, Professor of Nursing, Warwick Medical School, United Kingdom.
Next, I want to acknowledge Dr. Isabella White, Head of Clinical and Psychosexual Therapy Lead, London.
Now we welcome Dr. M.J. Kumari, Principal, College of Nursing, Pondicherry. Our worthy Dr. A.P. Singh, Dean, SGRD, University of Health Sciences, will be joining us soon. Thank you all of you and heartiest welcome.
As we all know that no program can be started without remembering the Almighty, the creator of the whole universe. Every morning brings us new thoughts, new words, new strength, and endless possibilities. So, to enlighten us and brighten our morning, here comes the student of SGRD for Shabad recitation. So, I request all to kindly stand and cover your heads for Shabad recitation. Let's all rise for the prayer. Thanks for bringing down God's blessing on all of us.
Now we are obliged to invite the excellencies on the dais. I request Dr. Parvez Saini, Principal, SGRD, College of Nursing, to grace the dais. We welcome you, ma'am, on the dais.
It's a privilege to invite Dr. Baljeet Singh Khurana, Registrar, Shri Guru Ramdas University of Health Sciences, to dais.
A big round of applause. Next, we look forward the presence of Dr. Manjeet Singh Uppal, Vice Chancellor, SGRD University of Health Sciences, on the dais.
I am fortunate enough to call Ms. Anita D'Souza, Secretary, ONAI.
I consider it a great pleasure to invite Dr. Puneet Girdhar, Registrar, PNRC. Put your hand together.
I consider a great honor to invite Chief Guest Ms. Achala to grace the dais.
It's a great honor for us to have you all amongst us. Thank you so much. Ma'am, Dr. M.J. Kumari, ma'am, occupy the seats on the dais. It's the light that brings life to everything around us, from the smallest blade of grass to the tallest trees, from one person to another, from one place to another. To make this occasion a blessed one, invoke Goddess Saraswati by kindling the lamp of knowledge and wisdom. To start up a serve on this auspicious note, we will now have a lamp lighting ceremony. Ladies and gentlemen, to do this honor, we have esteemed guests among us on the dais. May I request the dignitaries on the dais to please head forward to kindle the auspicious lamp. Please put your hand together as the dignitaries light the way. Lamp lighting is supposed to bring in a lot of positivity in the entire atmosphere where it is lit. I would request our esteemed guests to give us a photo opportunity. As the photographers, they are waiting in anticipation. Thank you so much. As the lamp is now lit, you may all have your seats. Thank you for doing the honors.
Fragrance of flowers spreads only in the direction of wind, but the goodness of a person spreads in all direction. Here I am talking about our principal, Dr. Pravesh Saini ma'am, and I invite her on the dais to extend a warm welcome to our guest and unfolding of the theme.
Hands together for Dr. Warwick Sani, Principal, SGRD College of Nursing.
Morning, everyone, and Sat Shri Akal to all of you. And you all are very warmly welcome to SGRD University of Health Sciences Amritsar, as well as Holy City of Amritsar. So thank you, all of you, for making all this to coming here. So good morning again. It gives me immense pleasure to welcome you all at Shri Guru Ramdas University of Health Sciences. We all are gathered here to attend 4th International and 20th National Oncology Conference, being organized by Shri Guru Ramdas College of Nursing and Oncology Nurses Association of India at Amritsar, Punjab from 1st to 3rd December 2022. The main theme of conference is One Team, One Dream, Let's Uplift Healing and Caring Across the Cancer Continuum. It's a very, very sensitive issue on which we will be discussing a lot. All the eminent speakers will put a light on the cancer, which is a prevailing problem nowadays. As the magnitude of the problem of cancer in India is one of the explosive dimension, so day by day, the number of cancer patients is increasing at rapid pace. I'm sure the deliberation at this conference will help in advancement of expertise and knowledge in the field of oncology nursing and will promote newer ways to meet the challenges in the coming years. I extend my heartiest welcome to our chief guest, Ms. Achla, currently working as Assistant Director General Nursing, Directorate General Health Services under Ministry of Health and Family Welfare, Government of India. Ma'am is having 28 years of experience in pediatric nursing and she is a postgraduate of RAK College of Nursing, New Delhi. Having 29 years of experience as nursing superintendent in Lady Hardinge Medical College, New Delhi. She has been awarded with National Florence Nightingale Award for the year 2019 by the President of India and also awarded certificate for her outstanding services and contribution to improve neonatal care by IFPB in November 2014. It's a proud moment for all of us to have you, ma'am, here with us as a chief guest. Thank you, ma'am. I welcome you wholeheartedly. I must mention our deep sense of appreciation and gratitude to Dr. Puneet Girdhar as guest of honor. Sir is holding various positions as Registrar, Punjab Dental Council and Punjab Nurses Council, National President of India Dental Association, and Joint Director, Medical Education and Research, Punjab, and Joint Director in charge of Dental and Ayurveda as well. It is indeed our pleasure to have you among us for today's event. Thank you, sir, for coming. I am pleased to extend my warm welcome to Dr. M.J. Kumari, Professor cum Principal, GIPMER, College of Nursing, as guest of honor. Ma'am has various publications, including 3 books in her credit. Thank you, ma'am, for accepting our invitation. Your presence is indeed invaluable for us. Thank you, ma'am. I would like to extend my deep sense of gratitude to Dr. Manjeet Singh Uppal, Vice Chancellor of Shri Guru Ramdas University of Health Sciences. He is a renowned surgeon and having good administrative skill. We are honored to have you, sir, with us. Thank you, sir. I would also like to take this opportunity to give a special welcome to Dr. A.P. Singh, though he could not come here and could not join here with us because of his some busy schedule, but I must acknowledge him. So he is a Dean SGRD University of Health Sciences, Shri Amritsar, and Additional Secretary SGRD Trust, as well as chairperson of this conference, who has been one of the college's staunchest supporters since the very beginning. We are truly delighted by having such kind of personality with us. I extend my heartfelt welcome to Dr. Baljit Singh Khurana, Registrar, SGRD University of Health Sciences and HOD of Forensic Medicine. Sir has done many research publications in his field. We are really proud to have such great personality with us. I am thankful to Sir for accepting our invitation and marking his presence here. Thank you, Sir. I am extremely thankful to ONAI members who are present among us on the stage as well as off the stage. Miss Anita D'Souza, Secretary, ONAI, and Professor cum Principal at College of Nursing, Tata Memorial Hospital, Mumbai. Miss Pratibha Jagdish, she is a President, ONAI, Associate Professor, College of Nursing, Tata Memorial Hospital, Mumbai, and co-organizing chairperson of this conference. I should not forget to acknowledge her contribution for the continuous support and guidance to organize this conference, though she could not join with us today because of her health issue. Dr. Rita Lakhani, Vice President ONAI and Principal Jupiter College of Nursing, Karnataka. Ms. Rashri Yadav, Joint Secretary ONAI and Clinical Nurse at Tata Memorial Hospital. I welcome you all wholeheartedly for organizing this conference and also for their constant support and guidance. Thank you, everybody, all the ONAI members. Also, I welcome our international delegates, Dr. Isabella White, currently working Head of Clinical Services, Percy Health Limited, London. She provides clinical leadership and oversight for professional activity and on supportive cancer care and work as psychosexual therapist. And Dr. Annie Young, Professor of Nursing, Warwick Medical School, UK. She is actively involved in various research projects and have many publications in her credit. We are really grateful to have both of you among us. Thank you, ma'am. Thank you so much. I would like to thank and welcome all the eminent resource chairpersons who will contribute by deliberating their views in this conference. Thank you. I must not forget to welcome the students who are the future of this country, reached here from different colleges by traveling from far off areas to update their knowledge, and also to all faculty members of SGRD University, SGRD Nursing College. So your presence here will add a boom to the enthusiasm of everyone. So it's a matter of great pleasure to have more than 700 registrations from different states of India, almost 11 states. From 11 states, people have joined with us today. UP, Karnataka, Assam, Maharashtra, Rajasthan, Gujarat, Jammu and Kashmir, Himachal Pradesh, Chandigarh, Telangana, Kerala, Delhi, Pondicherry, Uttarakhand, and Punjab, as well as international registration from London, UK, and Ireland. So it's a great moment, and it's a proud moment for all of us that we have such a huge number of delegates with us and good response from everyone. The hard work and dedication of all the members of the organizing committee during the preparation of this conference is highly appreciated. Without them, the event would not have been possible. Thanks and acknowledgement are due to the Dean, SGRD, University of Health Sciences, Dr. A.P. Singh, for the support and continuous follow-up that makes it a success. I would like to assure that our role will not end at this stage. We are totally committed to follow up all the details during the days of conference. The organizing committee has tried its best to make your visit to Shri Guru Ramdas University of Health Sciences, Amritsar as comfortable and scientifically fruitful as possible. And any inadvertent lapse may please be excused. I hope you all will enjoy the content, renew old friendships, make new friends, get new ideas, And above all, have a good time and also enjoy heritage of Shri Amritsar. My sincere felicitations to all the delegates and wish them all the success in their future endeavor. I again take this opportunity to welcome you all in this esteemed event. I wish this conference a great success. Thank you. Thank you so much. Now I will be
Ma'am, to start with the unfolding of the theme.
as we already know that we are going to have a deliberate discussions on related to the on this conference related to oncology of. So I will not take much of your time. Already Madam Sushma Saini has deliberated on this in her keynote address, and all might have got lot many information. This will be a little bit information about the theme of this conference. So the theme is One Team, One Dream. Let's uplift healing and caring across the cancer continuum. Next slide, please. Can you just? Okay, I'll see it. So as per this is the theme. So next slide. So as we know that India faces significant challenges of cancer burden, continuously growing. And as per estimates indicate, India reported cancer incidence in 2022 to be 19 to 20 lakhs, whereas real incidence is 1.5 to 3 times higher than the reported cases. And WHO has ranked in 2020 on cancer burden in terms of new yearly cases being reported, had ranked India at 3rd position after China and US. As we know that patients with cancer, they experience significant physical, psychosocial and financial challenges. And with the increasing number of patients with early stage cancer transition to survivorship, so in that stage, there is a critical need to address health promotion and overall well. And that is the prime responsibility of the nurses to make them aware and to make them aware about the cancer if they do not know it, and if they already got that cancer, so to make them aware of how to get treated and from where to get the treatment and to change their lifestyle and all. And for those with advanced cancer, so we have such type of discussions and conferences and prognosis and early integration of palliative care. So it can also have a profound impact on the quality of the patient life. So as we know that patient and their families, so the main problem in the developing country like India is they do not receive the right information at the right time, how to take the, from where to get the treatment and to whom to approach. And because of this, even many patients do not have access to palliative care, and too few, if they are referred to hospice at the appropriate point in their disease trajectory. So simultaneously, because of the growing demand of the cancer care, there is a growing demand of the cancer care with increase in new cancer diagnosed and the number of patients surviving cancer. So here is so we have to follow this cancer care continuum. So as per the theme we have chosen for that. So one thing is the responsibility of the nurses to make them aware. So first one is the risk assessment. So risk assessment, that is not only for the unhealthy person, but it is this is applied even for the healthy person also. That is our duty to make them aware how to go for the risk assessment, like as per the age. As previously with the advancing age, there was a more incidence of getting this problem, but nowadays it's not the case. Even in the children also, we are seeing that many cases come in the hospital in the cancer when they're very young. Then about the family history and about exposure to any kind of treatment, genetic disorder and lifestyle. So that's our responsibility, whether we are in the community or in the hospital, to ask the patient and to make them aware. And second one is a primary prevention. So in this case comes the lifestyle changes. So many in the scientific session, people will be, our resource person will be deliberating on this also. So lifestyle mean what? Like kind of diet person and they are having at their home. And even the sedentary life of most of the people nowadays prefer to have sedentary life of type of lifestyle, which is also which also gives harm to their health. So we have to make them aware that avoid sedentary lifestyle, avoid alcohol, avoid tobacco, because these are the main sources, reasons which can cause cancer. Then make them aware about the early detection about if they are asymptomatic, screening should be done, and if they are symptomatic, then appropriate testing. Then diagnosis, so there are different tests which you can advise them to go for. Then cancer treatment, that is also depends upon the type of cancer and what kind of treatment the patient is needed. So you have to educate the patient accordingly. And survivorship, and for survivorship is in case they survive, they get cured after cancer. So you have to give them advice about the testing, follow-up care, palliative care, or recurrent surveillance. And then end of life care, like a palliative care, advanced care planning, and bereavement support. So that's all our responsibilities to advise the patient, so that we can have some control on this problem, which is prevalent nowadays at a fast pace. So by keeping in view the theme of the conference, so we have selected certain topics, so on which resource person will be deliberated. So I'll give you just nutshell of that. So global epidemiology, management responsibility of oncology nurse in head and neck cancer, then diagnosis and treatment of breast, cervical, colorectal cancer and their preventive measures, psychological aspects in cancer care, then various nursing roles and challenges faced in providing nursing care to cancer patient. So these are the few of the topics so which will be highlighted in this 3 days conference. Hope you would enjoy and would carry a good message to your home, and would also disseminate the information in the community as well as in the hospital to the patients and to the people, those who are really in need. Thank you so much.
Thank you so much, ma'am. Now it is my privilege to invite our Honorable Dr. Manjeet Singh Uppal, Vice Chancellor, SGRD University of Health Sciences, the most passionate and dynamic personality. Put your hands together for Dr. Manjeet Singh Uppal, Vice Chancellor, SGRD University of Health Sciences.
Good morning, everyone, and Sat Sri Akal to all. First of all, I would like to on behalf of the university, extend my warm welcome to the chief guest, Dr. Achla. He has already been introduced very nicely by Dr. Parvesh Saini. Also the guest of honor, Dr. Puneet Girdhar and Dr. MJ Kumari, Dr. Anita D'Souza, our registrar, Dr. Baljeet Khurana, and I think there are so many other nursing college principals who are also, welcome them all. And also the international guests, Dr. Isabella White and Dr. Annie Young. So I welcome you to this holy city of Amritsar, and I hope you have a good time here. And the first thing that is, I feel really so glad and happy about that our college, our university is holding this conference, a national and international conference on this theme, cancer theme. So needs no introduction, cancer needs no introduction, but this is already a part of a spate of conferences that has been going on for the last few weeks. And they will go well off maybe into up to the month of February, March even. So that's the endeavor of our university to hold as much as conferences as possible. And all because of this reason that this kind of learning is the best kind of learning. We can have knowledge from the books, but the skill is always acquired by experience. And this is where the role of conferences and the workshops they come, because there all the delegates who are the new in the field, the students, and from different corners of this country, and they can come across with the stalwarts in their field, and they can share the experience and they can have a glimpse into the latest things and what they have acquired with a lot of experience in their field. And this is the biggest advantage of conferences. And a theme like this on cancer we all know is so much common, and but there are a few things, even it was an eye opener for me also, because I came across one article, and this was a very beautiful study they done, and the idea of this study was whether to see is there actual rise in the cancer incidence. And after going through that study, was a very different kind of study. And what they did was, the only thing that is available to us in the human form is the mummies. The ancient mummies, they were preserved by the Egyptians. And they had their own secret formula with which they applied chemicals. And, the mummies are still there after so many hundreds and thousands of years old. And they took out those mummies and subjected them to different investigations, predominantly MRIs and CT scans, just to see that what was the prevalence of disease in those days, when the affluence was not there. What we call as the affluence, present day affluence was there. And it was a shock and a surprise that at that time also, many of those these mummies, they were already the important persons or important people in at that time, mostly kings and queens. And they also had diabetes, and they also discovered that they had all different types of cancers and all those diseases which are prevalent today. That means the cancer is as old as mankind. So it's not new. So why we feel that the incidence is increasing? Because it's the diagnosis which is now easy to make. And of course, the population. The increase in population, so you get more number of patients, and we always tell you that this cancer is prevalence, and this is so many patients per 100,000 or per lakh population. And if the number of population is increasing, and the incidence will also go up. Probably that is the reason. So this is something quite old, and it's been in constant endeavor in the field of medicine. Even today, as we talk of, a lot of research is going on world over to look for the treatment of cancer. And different fronts, and the treatment has shifted from the surgical treatment and to the newer things. We are going now shifting from the gross treatment of the disease after it has occurred, and the constant endeavor is to go to the molecular side and try to stop the disease before it happens, so that it can be stopped there instead of waiting for it to happen and then treat. So these are the things which are important, and we are moving in that direction. And I think in future, there'll be treatment of every cancer will be a preventable disease, but we are still quite far from that day. And everything will be like treatable with the antibodies. If we detect something goes wrong at the chromosomal level and the genetic level, and we'll be giving those specific targeted antibodies for those, and the person will be cured. So till that time, we have to live with it. We have to treat it as per the present knowledge and everything that we have in our hands today. And regarding the cancer treatment and the lives of cancer patient, I would just like to say there is a common saying by the Confucius, a very prominent thinker from the past. He said the man has two lives, and the second life begins when you know that you have only one. That is the second life which begins. No, you have only one. But I would like to add to this that a cancer patient again has two lives, but a different kind. And the second life begins when the patient is diagnosed with cancer. because this life changes everything, which was in the first life, it changes everything. And there are so many turmoils in this life, so many of anxiety, so much of uh, psychological trauma, and also emotional shifts, sometimes high, sometimes low, and so many things that one experiences. And it is this time, this second life, that the role of doctor, and more than doctor, because doctors, they never spend more time with the patients. Probably they are already hard pressed for time, and but they don't spend time. And this is the time when the patient needs more of psychological and moral support than the treatment, actual treatment. This is where the role of nursing and the special team specializes in treatment of these cancer patients comes in. And this is the best thing that can happen to the cancer patients, if they can have a few words of solace, few words of which can boost their morale, and that will just tell them that everything is going to be all right, and you'll be a normal person again. These are the few things that everybody loves to hear after the diagnosis of cancer. This is the second life, and the aim and the everything that we are planning to do here is just to direct it towards those. And those unfortunate ones who are at the end of their life, where the disease has advanced to such a level that nothing much can be done, and they require even more psychological support. And the idea is to have a peaceful end, and it should be also a painless one. So the everything, like say, they have the important role, the nursing profession, especially who are trained in this. That's the most important thing, because they can spend more time with the patient, and patient also feels more comfortable talking to the nursing staff than to the doctor. So I think that highlights enough the great role that the nurses and the nursing profession, who can actually form a very important part of the cancer team which treats the patients. And that is they can provide that missing link between the doctor and the patient, and to fill in the gaps, to fill in all those information that the patient wants to know, and of course offer them psychological support. So this is what this is all about, I assume, and this is a quite exhaustive this all the curriculum that I've seen, and the program and the talks by all the experts, and I hope everyone will benefit, and especially the newer ones and the younger ones, they will benefit to learn from the experienced ones who are deliberating on these topics. So I again wish that all of you take back good knowledge from this place after attending this conference. And I would end up by saying that every life is important, and your life is important too. So take care. God bless.
Thank you so much, sir, to say from plethora of your words and experience. The more you take responsibility of your past and present, the more you are able to create the future you seek. It is my turn to extend a gracious and inclusive welcome to respected Mrs. Anita D'Souza, Secretary, ONAI, Principal, Tata Memorial Hospital, Mumbai. Your endless guidance and support throughout, the compassion to listen to the need of others is an art. Ma'am has been exemplary. It is an ardent pleasure to welcome you and invite you for giving the orientation of ONAI. Put your hands together for our Secretary, Mrs. Anita D'Souza.
Thank you and good morning to all. I stand here on behalf of the Oncology Nurses Association of India, which is the first of its kind in India in the area of oncology nursing. And I would just like to orient all of you to this organization and what we have been doing and what our past executive members have been doing in the area of oncology. So the beginning of ONI was in the year 1994, and the ONI was established, or it was formally announced to be an association on 1st November 1994. And the aim of this association was to bring the oncology nurses under one roof and to equip the nurses who are interested in oncology area in the knowledge and skill with regard to the oncology. This oncology nursing was actually launched under the guidance and leadership of the then nursing superintendent of Tata Memorial Hospital, Madam A.K. Bhargavi, and she, along with the like-minded people, they actually conceptualized the idea of having this. The first quarterly newsletter was also released during the launch of this association, which was at New Delhi at the UICC conference. And this quarterly newsletter was released by the then Executive Secretary of Oncology Nursing Society, by Miss Pearl Moore. And this association is also now registered under the Charity Commissioner of. The structure of association is like this. The director, who is in office at TMC, holds the post of patron of ONI. And currently the patron of ONI is Dr. Rajendra Badve, who is the director of Tata Memorial. We have an executive member. The main ONI chapter has 13 members, whereas all the other chapters will have 11 members. And the term of every executive member is about 4 years. The member can apply for the post again the next year, but the member cannot hold the same post for the 2 consecutive terms. The selection of the executive members is done by holding the elections, and the functioning of the association takes place in accordance with the bylaws which have been stated and are amended time to time whenever the need is felt. We have got 2 types of memberships of ONI, that is a life membership and the institutional membership. The institutional membership is for a period of 4 years, and the institutional memberships do not have the voting rights, whereas the life members do have the rights to vote. We also have, and currently I'm very proud to say that currently we have almost 2,000 life members in the association. We also have the chapter, we are also, the ONI is also an associate member of the various other association. To name a few, AONS stands for Asian Oncology Nurses Society, International Society for Nurses in Cancer Care, that is ISNCC, Global Power of Oncology Nursing, and the National Cancer Grid, which is the national organization. And National Cancer Grid constitutes about 805 centers. And the aim of National Cancer Grid is to standardize the treatment for the cancer patients in India. We conduct various activities under ONI, and these activities go on all throughout the year. We have both curricular and non-curricular activity conferences, and this conference is also one of conferences. We have a lot of workshops. We do have certification course. To name one of them is the chemotherapy certification course, which is a 2 weeks duration, which is conducted by ONI in association with Tata Memorial Hospital. We also conduct various debates. We do have telequiz and various art competitions such as painting, singing, rangoli, etc. We have chapters that are associated with the ONI, or ONI has its own chapters. The first chapter we had started in the state of Kerala. Then we have chapter at Delhi. We also have a chapter at Kolkata, and we are going to now start. We have already started a chapter at Punjab. So now this, fulfills all the 4 regions of India. That is West, East, South, as well as North. The ONI also gives various awards, and these awards we give to, which includes even the chapters of the ONI. We have Vivan Sangvikar Award, which is given for the best clinical nurse. We have A.K. Bhargavi Award given to the nurse the student who stands first in the post-basic diploma in oncology nursing program. We have Gopi Bambani Award for the best clinical nurse again. We have Miss Ratnamani Award for best clinical. This is for the best sister in charge. This is Then we have a Carbomenesis Award, which is given to the student who is standing first in the MSc Nursing. And we have got 3 peer group awards. That was for our 3 chapters at Kolkata, at Kerala, and at Delhi. And now we will be having the 4th award even for the Punjab. We have a regular quarterly publication under the name of Indian Journal of Oncology Nursing, which is distributed to every life member throughout their entire lifetime. We also have a student exchange programs, and we have had 2 exchange programs in the past. One was at the Chinese University of Hong Kong in the year 2017, and we've had the second one at the Singapore General Hospital and National Cancer Center at Singapore in the year 2019. We were going to have them even later, but then COVID pandemic struck and we had to halt this particular activity. And we are going to again have it in the future too. We also have the scholarships given to the students who deserve it and are meritorious at the same time. And we also give research grants to the nurses who are interested in doing research. This is all from with regard to the orientation. Thank you very much.
Thank you for giving orientation on ONA, ma'am. It will be a great pleasure for us to listen you again in our future events.
I am profoundly delighted to take an opportunity of inviting the chief guest of the day, Mrs. Achala, Assistant Director General Nursing, DGHS, functioning under Government of India. She is working towards connecting minds to strive towards success and achievements. We are grateful to her for accepting our invitation and becoming chief guest for today's event.
I'm extremely privileged to have opportunity to speak about your achievements, ma'am. Ma'am is awarded National Florence Nightingale Award for year 2019 by our Honorable President. Ma'am has been awarded for her contribution to improve the neonatal care, empanelment as external quality assessor of public health facilities under NHM. The list is endless. We are proud to have you, ma'am, as our chief guest. Ma'am, please welcome on the stage.
Thank you so much for the nice introduction. Morning, one and all present here. Greetings from the Directorate General of Health Services, Ministry of Health and Family Welfare, Government of India. It is my proud privilege to be amongst this august gathering on the occasion of 4th International and 20th National Oncology Conference in Sri Guru Ram Das University of Health Sciences in collaboration with Oncology Nurses Association of India on the theme, One Team, One Dream, Let's Uplift Healing and Caring Across the Cancer Continuum. Respected dignitaries on the dais, Dr. Baljit Singh Khurana, Registrar, SG, RD University of Health Sciences, Dr. Puneet Girdhar, Registrar, Punjab Nursing Council, Dr. Anita D'Souza, Secretary, ONI, Principal, College of Nursing, Tata Memorial Hospital, Mumbai, Dr. Manjeet Singh Uppal, Director, Principal, SGRD, University of Health Sciences, and Dr. Parvesh Saini, Principal cum Professor, SGRD, College of Nursing, and Dr. MJ Kumari, Principal, GIPMER, Pondicherry. It is a great opportunity to be with you all today. The theme of the conference is very relevant to today's scenario, and it is the need of the hour. As there is a saying, you can be a victim of cancer or a survivor of cancer. It is a mindset. As we know, the cancer is the second leading cause of death in the world. And the patients with the cancer, they experience significant physical, psychosocial, and financial challenges. And the physical symptoms of advanced cancer, it often results in significant debilitation, inability to perform basic self-care, and diminished quality of care. So cancer is a huge burden as it affects a diverse population. We know that treatment is expensive, and resources also, we know there are scarcity of resources, and potentially it is detrimental to well-being also. So increased cancer awareness and screening have improved diagnosis and outcome of the most common cancers. As the survival rates, they are improving due to improvement in cancer screening, treatment and prevention, and of course with the good nursing care. There is a critical need to address health promotion and overall well-being. So for those with the advanced cancer, discussion about the prognosis and early integration of palliative care, it can have a profound impact on the quality of care. Many patients, they find the transition from the cancer patient to cancer survivor, it is really very difficult. The early survivorship period is an important time for patients to focus on personal well-being, but this requires information and communication that we all know. Regarding the communication skills, nurses are playing a really very vital role in it. So involvement of multidisciplinary teams, it is not only with the nurses and all, it has to be a multidisciplinary team which included all the doctors, nurses, psychologists and counselors. They are imperative to relieve patients and caregivers of their physical or psychosocial symptoms. As the nurses, they play an important role in cancer care delivery, because the nurses, they are providing the direct patient care, including appropriate supportive care and administration of chemotherapy, biological therapy, targeted therapy, and associated supportive medications. And also it includes all the blood components, fluid and electrolyte replacement, and other oncology treatments as prescribed. So providing education to patients and families, which includes applicable referrals and bereavement counseling, is also very important part. And following the continuous quality improvement objectives and safety, infection control standards, and involvement in training and guiding other nursing personnel also. Nurses are the only one, those who are not only teaching to their colleagues, and they also give information to the patients also, awareness regarding the patients. And most importantly, as we all know that the lung cancer is one of the commonest cancer, so stop smoking. By awareness regarding that, if you smoke, quit. If you don't smoke, don't start. These are few of the things that it may not only leads to the lung cancer, and even it can have many other life-threatening effects to the patients also. Then avoid exposure, excessive sun exposures, and regarding promoting a healthy lifestyle also, healthy diet and exercise most of the days. Do we exercise? All of us, we exercise or not? We if you are doing it, that's great thing, 5 days a week, and at least 30 minutes of exercise must be for all. And maintaining a healthy weight also, being overweight may also increase the risk of cancer. So, and regarding scheduling care screening examinations also, as based on your risk factors, you can recommend others like self-breast examinations, doing mammography and the pap smear, and other examination methods can you see. And regarding the importance of immunization also, it helps to prevent the viruses, including hepatitis B, which increases the risk of liver cancer, and human papilloma virus, which increases the risk of cervical cancer. So during these 3 days, the eminent speakers and experts will deliberate sessions on various topics like types of cancers, their diagnosis, new treatment modalities, handling chemotherapy drugs, and prevention of cancer. And the participants also will have the exposure of open discussion on patient care experiences also. So there is one saying that there is always hope beyond what you see. It is possible not just to survive, but to thrive and to live a healthy, wonderful life again. So life is only 10% what happens to us, and 90% how we reacted to it. So, one of the quotes by the cancer survivors, like being positive is the best medicine you can take. So, being optimistic and being be positive is, it is for all. Everyone, we have to be, every time we need to think positive. Then enjoy every day without worrying about the next. With these words, I wish to convey my best wishes to the organizers and the whole team of Sri Guru Ramdas University of Health Sciences and Oncology Nurses Association of India for conducting this wonderful 3 days conference from 1st to 3rd December 2022. And I hope that it will be really fruitful and informative for all the delegates, those who have come across the country and beyond the country, some of the international delegates also and experts we are also having here. And I am very glad to see this house full of all the delegates. Just clap for yourself also. Thanks a lot. Thank you. Jai Hind.
Thank you so much, ma'am. Taking these all valuable suggestions forward, which these all surely will help us to work better and better. Thank you so much, ma'am.
Now, I would like to introduce our honorable guest of honor, His Excellency Dr. Puneet Girdhar, Registrar, Punjab Nursing Registration Council. Sir has been known for his distinguished work in numerous capacities. He is fountainhead of illuminating ideas. Sir is proud alumni of Punjab Government Dental College, Amritsar. Sir has been awarded first prize in the state for doing commendable work under intensive dental health care program. Sir is also having numbers of years of experience and holding various administrative posts under Government of Punjab, and the list is vast. Now, with great honor, I would like to invite Dr. Puneet Girdhar, sir, for words of wisdom. A huge round of applause for sir.
The chief guest of the day, Dr. Achla, Vice Chancellor of Ramdas University, Dr. Uppal, Dr. Khurana, Dr. Pravesh Saini, the dignitaries on the dais. First of all, I want to tell you that it is a glad moment for me to be here because I belong to this city. Although I'm settled in Chandigarh now, I've done my graduation and post-graduation from here at Government Dental College, Amritsar. Did my MDS from here. For last 3 years, I'm connected to you through PNRC. You all get registered over there, and we are in the process of as an examining body for A&M and GNM. We are doing, with the help of the various principals, the various advisors at the nursing colleges. Ma'am Devinder and Ma'am Ramankali are here. We are working very hard for your profession because basically I'm an oral surgeon. But when I got this opportunity to be registrar of this profession, Nursing Council, it has been a delightful experience. When we talk of various treatments and the disease oncology on which this conference is based, I must tell you there are two things. One is दवा and one is दुआ, और इन दोनों के बीच अगर है तो वो आप हो. This decade rather I would say this millennium belongs to you. एक लॉ ऑफ नेचर है, सर्कल है डॉक्टर्स का, और जो पैरामेडिकल हमारा स्टाफ है, सपोर्टिंग स्टाफ है, आपने देखा होगा कुछ सालों से इसका वो जो रिस्पेक्ट था, डॉक्टर्स एंड द पैरामेडिकल स्टाफ सपोर्टिंग, दे वर कंसिडर्ड नेक्स्ट टू गॉड. हम सबको भगवान के साथ जोड़ के नाम लिया जाता था, बट देयर हैज़ बिन डिटीरिएशन इन द सोसाइटी. लेकिन अगेन मैं बोलता हूँ कि वो एक नेचर का झटका था, लॉ ऑफ नेचर है. कोविड के अपने डिसएडवांटेज थे, लेकिन एडवांटेज ये था कि लोगों को ये सोचने पे मजबूर किया. उस टाइम जब कोविड आया तो दो चीज़ें काम की, दो चीज़ों ने काम किया. यू आर द फर्स्ट पर्सन, द कॉन्टैक्ट पर्सन फॉर अ पेशेंट, इंक्लूडिंग पेरेंट्स, इंक्लूडिंग बच्चे, इंक्लूडिंग रिश्तेदार. कोई पेशेंट के नज़दीक जाने को तैयार नहीं था. यू वर देयर फॉर देयर लाइफ. दो ही चीज़ों ने वहाँ पे काम किया, द सपोर्टिंग स्टाफ and to some extent Dolo 650. So और कुछ नहीं था उस डिजीज में. We are out of that thing. Again, I am very happy that we are sitting here without mask. उस टाइम तो ये लगता था, डॉक्टर खुराना जैसे हम शेयर कर रहे थे, डॉक्टर उपल, कि शायद ये फिजिकल कॉन्फ्रेंसेस हो ही नहीं पाएंगी, हम ऑनलाइन ही देखते रहेंगे. As far as we are concerned, our profession is concerned, we cannot work online, we cannot perform online, we cannot learn online. It is only the practical skills we have to attend. उस टाइम पे जो भी ऑनलाइन कॉन्फ्रेंसेस हुई, आई थिंक 80% लोगों के तो स्विच ऑफ होता था, साइलेंट पे बैठे होते थे, बिकॉज वी कैनॉट लर्न एनीथिंग विदाउट द physical thing. And these conferences, they impart you that platforms जहाँ पे मिल के हम नई टेक्निक्स, नई स्किल्स उनको हम सीखते हैं. मैंने बताया बेसिकली आई एम एन ओरल सर्जन. नर्सिंग का मुझे काम दिया गया. आई एम हेडिंग मेडिकल ऑल्सो, आई एम हेडिंग नर्सिंग ऑल्सो, आई एम हेडिंग आयुर्वेदा ऑल्सो. आयुर्वेदा का भी मेरे पास काम है, आई एम जॉइंट डायरेक्टर आयुर्वेदा. So right from allopathy, Ayurveda, nursing, homeopathy, one thing I must tell you, these may be different pathies, different professionals, different professions. Right from allopathy to homeopathy, the only thing that works is only empathy. It is the empathy. I must tell you, कैंसर का पेशेंट या और कोई पेशेंट जब आपके पास आता है, उसकी दवाई पता नहीं कब काम करेगी, दुआ दिखती नहीं है, काम करती है. इट इज योर हीलिंग टच, योर हीलिंग टच. एक पेशेंट आपके पास आता है, प्लेसिबो इफेक्ट आपने पढ़ा होगा. आधा उसका इलाज तो तभी हो जाता है जब वो कहना है कि बीबी कुछ नहीं होया तेनू, कुछ नहीं होता. Just a healing touch. So this works wonders. So between dua and dawa, you are there to create the magic. You are the medical magicians. Please keep it up. With all, I say good luck to all the organizers and this beautiful university standing tall. ਗੁਰੂਆਂ ਤੇ ਪੀਰਾਂ ਦੀ ਧਰਤੀ ਵਿੱਚ ਇਹ ਜੋ ਧਰਤੀ ਹੈ, ਇਹ ਜੋ ਇੰਸਟੀਟਿਊਸ਼ਨ ਇੱਥੇ ਖੜੀ ਹੈ, ਜੋ ਮੈਡੀਕਲ ਸਾਇੰਸਿਸ ਦੇ ਵਿੱਚ ਆਪਣਾ ਇੱਕ ਚੋਟੀ ਦਾ ਨਾਮ ਬਣਾ ਕੇ ਰੱਖਿਆ ਹੋਇਆ. ਇੱਥੇ ਆ ਕੇ ਤੁਹਾਨੂੰ ਇੱਕ ਡਿਫਰੈਂਟ ਫੀਲਿੰਗ ਆਉਂਦੀ ਹੈ. ਤੁਸੀਂ ਸਭ ਸਟੂਡੈਂਟਸ, ਸਭ ਡੈਲੀਗੇਟਸ ਇੱਥੇ ਆਏ ਹੋ. ਦਵਾ ਔਰ ਦੁਆ ਦਾ ਜੋ ਇੱਕ ਰਿਸ਼ਤਾ ਹੈ ਤੁਸੀਂ ਇੱਥੇ ਦੇਖੋਗੇ ਇਸ ਪਾਵਨ ਧਰਤੀ ਤੇ. ਗੋਲਡਨ ਟੈਂਪਲ ਵਿਜ਼ਿਟ ਕਰੋ, ਵਾਗਾ ਵਿਜ਼ਿਟ ਕਰੋ. ਇਟਸ ਅ ਟੂਰਿਸਟ ਡੈਸਟੀਨੇਸ਼ਨ ਆਲਸੋ. enjoy yourself. Good luck to all. Thank you.
Thank you, sir, for your wonderful words of insight.
Now I request Ma'am M.J. Kumari to say a few words.
Very good morning, all of you, respective dignitaries sitting on the dais and beautiful faces sitting on in front of me. It's my privilege to stand before you all on the representative of GIPMER, Jawaharlal Institute of Postgraduate Medical Institute. This is one of the INI institute in India, like AIMS. How the AIMS is very familiar in the north, the same way GIPMER is very familiar in the south. So I feel proud I'm a part of this GIPMER. So first of all, I have to thank the organizer. They given me the opportunity to give this speech in front of you. So cancer is a well-known, is a one of the most topest. It's a disease. So 10 out of 10 deaths, 6 is because of the cancer. So one more thing I want to convey here. Nursing and medical, both are excellent noble profession. Here, doctors main responsible to cure the disease. Okay, nurses responsible to care the patient. So cure is not possible without efficient, effective care. So nurses having more important vital role while take care of the patient. So we may not be post one doctor, one nurse for each patient, but we can make the patient to understand what is their responsibility. So one of my PhD scholar did the PhD on the cancer. Another one scholar is doing on the obesity. So when they are doing the data collection, we are going for the field. So when we are exposing in the field work, so what we studied in the book, the scenario is little bit different. So usually for the causative factors, many of the things we put the burden on this illiterate, uneducated. Those people only have the main reason for getting all the disease. But in the field scenario is little bit different. So when we are conducting the focus group discussion to get the what is the problem in their lifestyle because of they are getting the overweight. So many of the uneducated, lower economic patient people, they are coming forward to participate in the group discussion. But we faced none of the educated, high-level economic people, they are not participated in this group discussion. So we are not getting it. At the same way for female, they are very interested to come forward to express their feelings, what are they are enable, everything. But we are not yet get the single men to participate in this focus group discussion. So what we studied, that is information is we are getting, but when we are really working in the field, the scenario is we are getting, and that is a different scenario. So we have to do our effort in the practical aspect, not only getting the books. So what we get the information in this practical scenario that we want to disseminate to the others. So because of that only we are conducting the professional, they are conducting these many forums, they are creating these many forums. All the nursing officers, those are working in the field, in the clinical area, they also come up to present their additional knowledge to our fraternity. So one more thing I want to convey here, cancer that make an impact on not only the individual life, it's indirectly, it's affect burden to the society and our country also. So that's why this is a right time to call for the action to prevent the cancer. So a few decades before, we are mainly focusing on the communicable disease. Now, our full focusing on the non-communicable disease. Even the WHO, they have to focus on the non-communicable disease up to 2020. Now they are extend 2023. So the focus main thing is common cancer, breast cancer, then colon, rectal, lung cancer, prostate cancer. These sort of things is very common. 30 to 50% of the cancer is preventable by following a simple strategy. So simple thing make a big difference. So usually for the breast cancer, yearly detection, not only for the breast cancer, everything yearly detection is very, very important to cure the disease. But you want to do the yearly detection, you want to have the awareness. That awareness as a nurses, we can create among the people. That is the main thing. So prevention is better than cure. When we are creating awareness to the all the individual, they are ready to do it. Their life is very important for them. We want to create the awareness, definitely they will cooperate. We can reduce this. This is the one way message I want to convey all this forum. All of you, just you have to pass the message, pass the positive message, create the awareness. If you sensitize the patient, definitely they will follow it. That is the only submission for all of you for this forum. Then I thank the organizer. I good applause for the host institute for organizing such a wonderful conference, because last year we are organized international conference. We know how much it's difficult to gather from all the different parts of the nation, and even though foreign delegates are sitting in the front rows, it's not an easy thing. So I appreciate and congratulate all of you, ma'am, for organizing such a wonderful conference. Thank you so much to give me the opportunity. Thanks for GIPMER also to grant the permission for this. Thank you.
Thank you, ma'am, for your valuable suggestions and words of wisdom. I hope the gathering will take a message home. I will now request all the dignitaries on the dais for the release of souvenir.
Huge round of applause. Release of the souvenir. Let the photographers to take the photo. Thank you so much, sir. Thank you so much, ma'am. Now it's time for honoring our worthy chief guest and guest of honors. And to do the honors, we would like to call Dr. Manjeet Singh Uppal, Vice Chancellor, SGRD University of Health Sciences, Dr. Baljeet Singh Khurana, Registrar, Mrs. Anita D'Souza, Secretary, ONAI, Dr. Rita Lakhani, and Dr. Parvez Saini, Principal, SGRD, to honor our worthy chief guest.
Inviting our chief guest to receive the honor, please. Mrs. Achla, Assistant Director General, DGHS, Ministry of Health and Family Welfare, Government of India.
Put your hands together, ladies and gentlemen. Chief guest of the day, receiving token of appreciation from SGRD University of Health Sciences. We are privileged to have such a great personality amongst us. The blessed moment.
I am pleased to call upon our guest of honor, Dr. Puneet Girdhar, Registrar, Punjab Nursing Registration Council. A huge round of applause for Sir.
Dr. Puneet Girdhar, Registrar, PNRC. Guest of honor, we are proud to have such a great personality amongst us. Huge round of applause for Dr. Puneet Girdhar, Registrar, PNRC. Give time to photographers to have a photo. Thank you so much, ma'am. Thank you so much, sir. Dr. M.J. Kumari to receive the token of appreciation. We call Dr. M.J. Kumari. Thank you, sir. Have your seats. On the dais. A timely word is a treasure that is wrapped in timeless memory. The much awaited moment is finally here as we move towards the launch of ONAI Punjab chapter. A big and huge round of applause for the launch of ONAI Punjab chapter. The aim of bringing all the oncology concerned nurses under one roof to update the oncology nursing through various activities would now be carried forward by the launch of this ONAI Punjab chapter. I would like to invite Dr. Anita D'Souza, Secretary ONAI, to declare the launch of ONAI Punjab. Dr. Rita Lakhani, Vice President, to join her.
Yeah, it's our honor, a proud privilege to announce. Actually, as it is said, that the team cannot win if half the team members are out of the team or are not present. So we've had actually out of 4 regions, we've had 3 regions where we had a chapter and the activities going on. The 4th was missing, and Punjab has filled up the gap. Okay? I want to officially announce that the Punjab has become the chapter of ONAI, and Punjab chapter and the members of Punjab chapter will get all the privileges that the other members of the other chapters are enjoying. Welcome you all in the body of ONAI, and looking forward to working with all of you. It's also time that I want to thank Dr. Singh, who has been the organizing chairperson of this conference. Dr. Singh actually has been there right from the beginning, from the time the concept, the formation of the Punjab chapter was conceptualized. We have been hearing that he is with the team right from the beginning. And it really reminds me of a quote which says that the true leader is not the one who leads from above, but the one who leads from within. And he has been that kind of a leader. He has been very philanthropic, very generous, and he has taken the keen and very keen interest in minutest details of the formation of this Punjab chapter, as well as organization of this conference. So I would like to really thank Dr. Singh on behalf of ONAI and the organizing team of this conference. And as part of our appreciation, I would like to present a memento from ONAI.
Have the honors, Dr. Baljeet Singh Khurana, on behalf of Dr. A.P. Singh, will receive. the honors. Dr. A.P. Singh, expressing our tremendous gratitude. He is the most supportive man. His heroic efforts helped us fundamentally change everything we do, from educating our students to conducting the research and organizing the various conferences. The whole campus is vibrating and echoing his prominence. And on behalf of Dr. A.P. Singh, Dr. Baljit Singh Khurana, Registrar, to receive the honors from ONAI. Truly a deserving achievement. Thank you, ONAI. So now we move forward for honoring executive members of National ONAI. To do the honors, I would like to respect our chief guest, Mrs. Achla, Assistant Director. Our guest of honor, Dr. Manjeet Singh Uppal, Dr. Parvez Saini, Dr. Baljit Singh Khurana. To honor our guest of honor, Dr. Puneet Girdhar. To begin with the honors, Mrs. Pratibha Jagdish, President ONAI, though the ma'am is not here. So one of the executive members will be receiving on behalf of her. Mrs. Pratibha Jagdish, President ONAI, on behalf of her ONAI executive members will be receiving the honors. Huge round of applause, ladies and gentlemen. This is time to honor the eminent guest and the executive members of National ONAI. Next, I would like to call upon Dr. Rita Lakhani, Vice President ONAI, Principal, Jupiter College of Nursing, Karnataka.
Next, I would like to invite Mrs. Anita D'Souza, Secretary ONAI and Principal, College of Nursing, Mumbai.
Receiving the honors, Dr. Rita Lakhani. Calling up next, Mrs. Anita D'Souza, Secretary ONAI. Next, we call upon Rashri Yadav, Joint Secretary ONAI.
Next, I would like to invite Reena Nair, Treasurer ONAI, Assistant Nursing Supervisor, Tata Memorial Hospital, Mumbai.
Thank you all the executive members of National ONAI. Now it's time to honor executive members of ONAI Punjab chapter. I request Dr. Rita Lakhani, Vice President ONAI, to join us, and Mrs. Anita D'Souza, Secretary ONAI, to join us for giving the honors to the executive members of ONAI Punjab chapter.
With a huge round of applause, President Dr. Parvez Saini, Professor cum Principal, Shri Guru Ramdas University of Health Sciences, Shri Amritsar, ONAI member, Punjab chapter.
Vice President Dr. Preksha S. Maheshwari, Associate Professor, University College of Nursing, Baba Free University of Health Sciences, Faridkot.
Secretary ONAI Punjab chapter, Ms. Rupinder Kaur, Associate Professor, Shri Guru Ramdas University of Health Sciences, Shri Amritsar.
Joint Secretary Mrs. Shaminder Kaur, Assistant Professor, University College of Nursing, Faridkot.
Treasurer, Ms. Komalpreet Kaur, Assistant Professor, College of Nursing, Adesh University, Bathinda.
Joint Treasurer, Mrs. Rubia Ahuja, Professor, Mohandai Oswal College of Nursing, Ludhiana. Ahuja, Professor, Mohandai Oswal College of Nursing, Ludhiana, as a Joint Treasurer.
Next, I call upon Executive Advisor Dr. Kiran Batra, Professor cum Principal, Mata Sahib Kaur College.
Ma'am is not here. Next, we call Chairperson Member Dr. Davinder Kaur, Development and Welfare Committee, Professor cum Principal, Gyan Sagar College of Nursing, Rajpura, Patiala.
Next, I call upon Chairperson Research Education Committee, Ms. Jyoti Katwal, Professor cum Principal, GMCH College of Nursing, Mohali.
Chairperson, Patient Welfare Committee, Mrs. Iqbal Kaur, Nursing Superintendent, SGRD Charitable Hospital, Valla, Shri Amritsar.
Next, I call upon Chairperson Membership Committee, Ms. Nancy Diana, Nursing Superintendent, Homi Baba Cancer Hospital and Research Center, Mulanpur.
Now it is time for honoring our special invitees, our keynote speakers, Dr. Sushma Saini, Associate Professor, PGI Chandigarh. Ma'am has accepted our invitation at a very short notice. Thank you so much, ma'am. Dr. Sushma Saini, Associate Professor, PGI Chandigarh. Dr. Annie Young, Professor of Nursing, Warwick Medical School, United Kingdom. Dr. Annie Young, Professor of Nursing. Dr. Isabella White, Head of Clinical and Psychosexual Therapy Lead, London.
Next, I would like to extend a special thanks to Principals, College of Nursing for joining us. To begin with, Dr. M.G. Kumari, Principal, GIPMER College, Pondicherry. Dr. M.J. Kumari. Next, I call upon Dr. Namesh Kumar Dev, Principal, Government College of Nursing, Ajmer. Next, with great honor, Dr. Rita Lakhani, Principal, Jupiter College of Nursing, Karnataka. Dr. Rita Lakhani, Principal, Jupiter College of Nursing, Karnataka. Next, with huge respect, Dr. Raman Kalia, Principal, Saraswati Institute of Nursing, Roopnagar. Next, I call upon Kunjan Vikas Kulkarni, Head of Nursing Department, National Cancer Institute, Nagpur. Next, I call upon Miss Shweta Garg, Assistant Nursing Superintendent, Tata Memorial Hospital, Mumbai.
Dr. Darshan Sohi, Principal, CKD College of Nursing, Amritsar. Ma'am, to please join us on the stage, ma'am, to do the honors. Reena Sudan, ma'am. Dr. Harjinder Kaur, Principal, SGRD, Pandher College of Nursing. Dr. Ramesh Kumari, Principal, Mai Bhago College of Nursing, Amritsar. We extend our token of appreciation to Ma'am Reena Sudan, Harjinder Kaur, Principal, SGRD, Pandher College of Nursing, Amritsar. Dr. Ramesh Kumari, Principal, Mai Bhago College of Nursing, Amritsar. A token of appreciation for Mrs. Reena Sudan, ma'am. Meena Sudan, ma'am. We request all the to present a token of appreciation to Dr. Meena Sudan, ma'am. This was all from the honors. Thank you so much, sir. Now, vote of thanks. Now I request Dr. Manpreet Kaur. You may have your seat, sir. Thank you so much.
Now I request Dr. Manpreet Kaur, Vice Principal, SGRD College of Nursing, to extend the vote of thanks.
So now it has good afternoon. I know everyone, each one of you is very tired now, but I'm not going to take much of your time. But as a part of this ceremony, this vote of thanks is also must. So सदा न कोयल कूकेगी, सदा न खिलते फूल, ऐसे अतिथि पधारते जब भाग्यो अनुकूल. And this quote, I personally believe, will unfold to its real meaning with my next few sentences, as each one of us in this organizing committee of this conference feel fortunate enough to host such a huge gathering, especially after COVID. So thank you everyone for joining with us. So a beautiful and graceful afternoon to our most valued honorable chief guest, Ms. Achla, Additional Director General Nursing, DGHS, Dr. Puneet Girdhar, Registrar, Punjab Nursing Registration Council, Dr. Manjeet Singh Uppalji, our Vice Chancellor, sir, Dr. Baljeet Singh Khunana, Registrar, Dr. Anita D'Souza, Secretary, ONAI, Dr. Parvez Saini, Principal, all our special invitees, my colleagues, dear delegates, and everyone gathered over here. On behalf of Shri Guru Ramdas College of Nursing, it's my proud privilege to propose a vote of thanks and acknowledge the contribution of one and all. So my sincere thanks, first of all, has to be toward Almighty God for making today's event a resounding success. With His blessings and grace, we are able to make this event for what it was envisaged. I extend a hearty vote of thanks to our chief guest, Dr. Achla, ADG Nursing, for accepting our invitation at really a short notice. So thank you, ma'am, and your inspiring speech reflecting an enviable combination of experience and wisdom. These words will stay with us for a long time. Thank you so much, ma'am. Gratitude to our guest of honor, Dr. Puneet Girdhar, who spared time from his busiest schedule to grace the occasion. It is indeed a deep sense of pleasure to listen to your motivating and inspiring words. I would also like to thank our Dr. M.J. Kumari, our guest of honor, for joining our today's occasion. I would also like to thank Dr. Pratapa, President ONAI. I know she is not here, but she has joined us virtually and she is showering her blessings upon us. And Dr. Anita D'Souza, Secretary ONAI, and all ONAI national executives for helping us in initiating Punjab chapter of ONAI. Thank you so much, all the national executives of ONAI. I need to mention my deepest sense of appreciation to Dr. A.P. Singh ji, although he is not physically here, but again, I know he is connected with us. And He is our dean as well as organizing chairperson for being a catalyst that stimulated us to do our best and always standing as a pillar of wisdom and strength. With a deep sense of appreciation, I thank Dr. Manjeet Singh Uppalji, our Vice Chancellor, Sir, Dr. Baljit Singh Khurana ji, our Registrar University, for all their help, and it is always just a phone call away. I would like to acknowledge our keynote speaker, Dr. Sushma Saini from Chandigarh, Dr. Isabella White, and Dr. Annie Young from UK for accepting our invitation and gracing the occasion. Thank you so much, ma'am. And thanks to all our special invitees, principals from different nursing colleges of Punjab and other adjoining states, nursing superintendents, senior nursing faculty, and nursing officers especially. This is the first time I was discussing. We have such a huge participation from nursing officers. So please, a great round of applause for all the nursing officers. So, and this is the first time such a huge registration for any conference from nursing officers. Thanks to our respected principal, ma'am, Dr. Parvez Saini, and co-organizing chairperson for leading us and guiding us throughout this event. I also extend thanks to all our faculty members for their enormous cooperation for organizing this conference. We are also grateful to Mr. Bhupesh Arora from CBS Publications and Mr. Gurvinder Singh from INSCOL for sponsoring this event. Thanks to press and media for their coverage. Thanks with folded hand to each and everyone who worked behind the scene. Special thanks to Sardar Manmohan Singh ji and team, without which any event is not possible. And of course, Jaspreet Singh ji, Harvinder Singh ji, JP Singh, and Ms. Sujata, who have helped us throughout organizing this conference. And finally, I would like to thank our dear delegates who have come from faraway places, 11 states, a huge one, again, to participate with enthusiasm in this gala event. If time is money, then today you have spent millions for us. Thanks to all of us for making this event successful. Have a wonderful stay at Amritsar and enjoy this academic feast and the campus life of Shri Guru Ramdas University of Health Sciences. And not forgetting our multi-talented students. I can see few students at the back. So for working very hard and bringing new ideas, whatever we do and whatever we plan for. Without your active participation, this conference can't be executed. So once again, thank you, each one of you.
Thank you all of you for your presence. Ladies and gentlemen, this is all from our inaugural session. Thank you for patience listening and enjoying this inaugural session. Thank you so much. Okay, now we are going to start with our next plenary sessions. So kindly have your seats. I request our senior faculty to have a tea break. After a bit while, you will be moving for your tea break also. So let's begin with our plenary session now. So I request all my SGRD colleagues to please accompany our senior faculty for tea outside. Our respected faculty members, all our guests to have a cup of tea. So let's begin with our first session. To proceed with, I invite Sukhmanjot and Gursimar to start off with the plenary session 1. Thank you so much.
Thank you so much, ma'am. So we are heading towards our first plenary session, that is head and neck cancers. So head and neck cancers are emerging as major public health problems in India, which are lifestyle related, have a lengthy latent period, and need dedicated infrastructure and human resource for treatment. So to begin this seminar, I would like to call Dr. Sushma Saini, Associate Professor 9 PGIMER Chandigarh, as our chairperson.
Hold on. Dr. Sushma Kumari Saini, lecturer 9 PGMR Chandigarh. She has completed her PhD from PU Chandigarh, MSc in Community Health Nursing. She has 24 years of teaching experience, member of 13 national scientific bodies, joint editor of Nursing and Midwifery Research Journal, and a member of editorial board of many reputed journals. Presented many papers and is the invited guest faculty at local, national, and international conferences. Has 80 publications in reputed journals and is the author of many chapters in various books. Special interest in reproductive and child health. Guide for PhD students enrolled in INC Consortium and PGMR Chandigarh. Project Director of Composite Target Intervention Project run by Indian Public Health Association in collaboration with State AIDS Control Society, Chandigarh.
I would like to call Dr. Preksha Sharma Maheshwari, Associate Professor, College of Nursing, Baba Farid University of Health Science, Faridkot, as our chairperson.
Dr. Preksha Sharma Maheshwari, PhD INC Consortium, MSc Nursing, AIMS, Delhi. Currently working as Associate Professor in Baba Farid University in Health Sciences, Faridkot, Punjab. Alumni of SMS Hospital, Jaipur, AIMS, New Delhi, INC Consortium. Working in the field of oncological nursing more than 14 years. Written 38 original articles and 4 review articles and 2 chapters. Editor and reviewer in 11 national and international journals, member of TNAI, ONAI, INRSI, Red Cross Indian Science Congress, etc. Gargi Award of Meritorious Position in 10th and 12th by Ministry of HRD and GOI, India. He is member of IEC for PG program, member inspection report evaluation committee, Baba Farid University Health and Sciences, organized several conferences, workshops, public awareness, companions, CNE including ICMR funded workshop, etc.
Shall we start, ma'am? Sorry.
So, good afternoon, everyone. And with the permission of my co-chairperson of this session, Madam Sushma Kumari Saini, I'm going to introduce the first speaker of this session, and she is none other than the renowned Dr. Manpreet Kaur, Professor cum Vice Principal at SGRD College of Nursing. So, as you all know, that ma'am is presently working here, and she is also actively involved as the organizing person in this conference. Ma'am has completed MSc Nursing in Community Health Nursing from 9 PGIMER Chandigarh. She has done PhD from Baba Farid University of Health Sciences, Faridkot, and having fellowship in palliative care. She has clinical experience for few time, and she has worked in CMC Hospital Ludhiana. She has more than 16 years of teaching experience at College of Nursing DMC and SGRD Cone itself. Now, and she has attended numerous national and international conferences. She has presented near about 30 scientific papers and having 15 presentations in various national and international conferences. Ma'am has received Best Teacher Award in 2022 itself from Nursing Teacher Association of India. Congratulations, ma'am, for this once again, for having Best Teacher Award. So today, first session, we are going to receive from the Best Teacher of this year. And ma'am has been the associated member in Indian Society of Psychiatry in Nursing, and she is the reviewer of many journals, and including in the Journal of Occupational Health. So with this, I invite Dr. Manpreet Kaur for first session. Please come. Thank you.
Yes, good afternoon. May I have your attention, please, everyone at the back? I know you must be tired, but we have to start with the session. It's all unavoidable now. We are running quite a late of time. And after the session, we have a lunch break. Yes, please, everyone, because we are here to attend the conference. We are here to listen to the new things. So, to begin with the first session, thank you, Preksha ma'am. Thank you, Sushma ma'am, for nice introduction. And the topic, as you can see on the screen also, it's about global epidemiology of head and neck cancer, its burden, including treatment modality. Although it's global, but as I was preparing for this topic, please, everyone, the person who is standing over here feel little disheartened and demotivated when audience is not listening. So please, okay. So as it's about global, but as I was preparing for this presentation, I have focused most of the Indian data, because that's what with which we are mostly concerned with. So to begin with, all this head and neck cancer. So as we know anatomically also, there are several delicate, intricately organized structures for basic physiological needs, as well as head and neck, it is part of our appearance. And also whenever we are communicating, all the muscles and all the internal organs are involved. And so expression as well as social interaction, this head and neck, these two are the most important organs. And whenever they are involved with any kind of pathology, there are mild to severe degree of structural deformities, functional handicaps, and it all depends upon site, size, as well as pattern of spread. So, and very importantly, whenever there is a patient of head and neck cancer, and out of all these cancers, I'm very sure the biggest threat, it is toward one's well-being as well as self-esteem, because it's the body image is altered significantly with head and neck cancer. And further, it's not only up to the diagnosis, but as treatment is initiated, the quality of life further declines as the treatment advances. And further, because radiotherapy and surgery, most importantly, it is involved. So additional mutilation, it further deteriorates the quality of life of these victims. Okay, now just a few data about the global burden. So worldwide, approximately 9 lakh cases occur every year around the world. and out of which 4 lakh cases die because of head and neck cancer only. And in US, 3% of malignancies, these are just because of head and neck, and approximately 66,000 cases every year with 15,000 deaths. Then in Europe, around 250,000 cases, and it is nearly 4% of the cancer incidence with 63,500 deaths. And males are affected significantly more than females. We can very easily correlate related to one's habit of tobacco chewing, smoking, alcohol. And this ratio ranges from 2:1 to 4:1. Incidence rate in male exceeds 20 per 1 lakh in regions of France, Hong Kong, even in India, Central and Eastern Europe, Spain, Italy, Brazil, and even among African Americans in United States. And out of all the cancers, head and neck only, mouth and tongue, these are the commonly affected sites in India. Nasopharyngeal, it is more common in Hong Kong, and pharyngeal or laryngeal cancer, it is more common in other population. Now coming to our country, with which I think we are directly concerned. And here, the picture is entirely different because we are living in a unique demographic profile. We have unique type of risk factors like tobacco chewing, pan is something very common over here. Food habits, entirely different, as well as our unique personal and family history. And head and neck cancer, it is emerging as a major public health problem, which is related to our lifestyle. And another unfortunate thing is it has got lengthy latent period, and in our country especially, it requires dedicated infrastructure and human resources, which is lacking significantly. So what we need at our country level is need-based and coordinated research so that we can understand the problem of all the chronic diseases, which also includes head and neck cancer, and new ways of diagnosis, new ways of treatment. This is something it has to gain importance now. And overall, 57.5%. So just remember, 60% of global head and neck cancer, which exclude esophageal cancer, occur in Asia, especially in our country for both sexes. Head and neck cancer accounts for 30% of all cancers in male, except for Dibrugarh in Assam, where it is nearly half. In female, it constitutes 11 to 16% of all sites of cancer. And out of all these, tongue and mouth, these are the most common sites among male. So 1/3 of total cancers, again, except in Dibrugarh, where hypopharynx, it is the major contributor. And among female, mouth cancer was noticed as the leading cause. So this is from this graph, you can very easily see the difference of all the cancers basically in both sexes. So among males, head and neck is the most frequent one, and among females, it is cancer of cervix and uteri. This is the common one. And over 2 lakh cases of head and neck cancer occur every year in our country. Nearly 80,000 are oral cancers, which are diagnosed every year. And 2/3 of oral cancers are located in bucco-gingival sulcus, where the beetle quid, it is kept for a long period in the oral cavity. That's why it is also called as Indian carcinoma. So because it is quite prevalent in our country. Then around 40,000 cases of pharyngeal cancers, which excludes nasopharyngeal cancers. So 31% of the contribution it is by our country, and nearly 29,000 cases of laryngeal cancer, again 18%, occur in our country every year. And India stands second place in prevalence of esophageal cancer, and it's only after China. And most of the oral lesion, that's something unfortunate with these cancers, these are detected in their advanced stages. But at the same time, we have to understand oral cavity is something very easily accessible for visual examination. And right now, our ASHA workers and CHO, they are doing this examination, visual inspection of oral cavity. They are supposed to do for all the adults in the community after, say, age of 30 years. And 60 to 80% of patients present with advanced disease in India, as compared to 40% in developed countries. So diagnosis is delayed, and overall survival, that is also reduced. Incidence, if we say, Bhopal has the world's highest age standardized incidence of both tongue and mouth cancers among males. And Trivandrum has a high incidence of oropharyngeal cancers. And if we just look at how with the time it has changed, although there is a slow decline in incidence of most of head and neck cancers, but at the same time, it is observed that trends in tongue, hypopharynx, and larynx are declining in almost all the population-based registries, while cancer of the mouth, it is still, whether either it is increasing or somehow the same numbers are reported every year. And oral cancers, this has gradually, for males, since 1986, the number has decreased, but stable for females. And in both sexes, less than 40 years, incidence of oral cancer has been stable since 1986. Overall incidence of cancer in children under 15 years of age, it ranged from 11.22% to 14.03 cases per 1 lakh in 1994 to 96, and there is an approximate increase of 25%. In the time period of 1973 to 1975, a greater increase in the incidence of pediatric head and neck malignancies, these has also been documented. Now, after the numbers, let's see the important risk factors which are prevalent, which are quite frequently seen around us. So first and foremost, very obvious one is tobacco. And tobacco, it is used in various forms, in the form of cigarettes, bidis, cigars. These are the different names which are used in different regions of our country. Chuta, chirut, dhumti, water pipes, hookah, what we say, even reverse chuta smoking, hukli, chillam, so different names, but the culprit is tobacco only. And around 57% of all men and 11% of women, so women are also not spared, they consume one or another form of tobacco. And results from Global Youth Tobacco Survey in India that shows that 10 to 20% of students, that's something I feel bigger to concern about. Even our students from 8th to 10th grade, they use one or another form of tobacco. An epidemiological study show that the risk of developing oral cancer is 5 to 9 times greater for smokers than for non-smokers, that we have seen in the morning keynote session also. And this risk multiplies to as much as 17 times greater for exceedingly heavy smokers of 80 or more cigarettes per day. And about 1/4 of oral cancers, this is just because of cigarette smoking. And more than 60 carcinogens, these are present in cigarette smoke, and at least 16 in smokeless tobacco, these have been identified. And besides smoking, use of smokeless tobacco, which is also quite prevalent, what I was referring to, betel quid or pan, this is extremely widespread. And along with pan, usage of zarda, gutka, khara, mawa, kani, and all these are different preparations which are prepared by these vendors, and ultimately all use dry mixtures of erica nut flakes, lime, and tobacco powder. And in certain regions, it is also used as a moist stuff which contains lime with tobacco, vegetable oil, and water. And regionally, it is referred to as naswar, and also in the form of dried tobacco, which is just applied on gums and teeth. And this habit of betel quid chewing, this is well known to cause precancerous conditions of mouth, especially submucal fibrosis, which has been identified as an oral carcinogen in humans, and there is a very strong dose-response relationship. And recent population-based cancer registry, it shows that proportion of cancer related to tobacco use among males in India, it ranges from 33% in Bangalore to half in Ahmedabad. And relative proportion of tobacco cancers, it varies from 15.2 in both Bangalore and Chennai to 10.7 in Delhi among females. And head and neck cancer, the risk increases significantly when smoking duration is more than 20 years and daily frequency is higher than 20. Then second lifestyle factor, which is widely contributing to oral this head and neck cancer, that is consumption of alcohol. So regular consumption of 4 to 5 drinks daily, the risk of oral cavity, it increases 2 to 3 times than among non-drinkers. And overall, 7 to 19% oral cavity cancers, these are just because of habit of heavy alcohol drinking. Then alcohol along with combination of smoking. Again, here also there are different partners. So addition of alcoholic drink to intake of tobacco in any form, which already we have seen in the previous slide, it increases the risk of oral cancer by 11-fold. And a case control study, which was on oral cancer, buccal and labial mucosa in Thiruvananthapuram, it showed that alcohol alone conferred a non-significant odds ratio of 2.6. But there was a significant odds ratio seen with alcohol along with BD smoking, alcohol with pan, tobacco chewing, and alcohol with pan and smoking altogether. You can see the numbers, how this odd ratio is posing a risk. Infection with human papilloma virus, usually we correlate with CS cervix, but evidence suggests that HPV may be linked with some oropharyngeal and oral cancers. HPV 16 has been detected, again a major number, in up to 22%, and HPV 18 has been found in up to 14% of oral cancer cases. Then sexual behavior. Sexual behaviors are linked with cancer risk, with head and neck cancer. And earlier, again, it was seen mainly with the HPV. Having a history of 6 or more lifetime sexual partners and 4 or more lifetime oral sex partners, it is linked with cancer of the oropharynx. Then even oral cavity lichen planus, specifically its erosive form. So there are white patches, painful patches, inflammation on the oral cavity, which may be associated with an enhanced cancer risk. And another one is this Plummer-Vinson syndrome, which is triad of iron deficiency anemia, dysphagia, and post-cricoid webs. So when these three are present collaboratively, again, a high risk for development of carcinoma of oral cavity, oropharynx, and esophagus. Then nutrition and cancer, again, here the role is well documented. So this is something preventive we are talking about. Regular vegetable consumption and fish in diet. It is, research has shown it is protective. And in a case control study on various head and neck cancer, it has been seen with non-consumers, the risk is twofold. And to a lesser extent, the role of buttermilk and pulses, this was also found to be protective. Then oral precancerous conditions. So usually we see 3 types of lesion. Most commonest is leukoplakia, and it turns into malignancy in 0.13 to 10% of the cases. But at the same time, erythroplakia, although these are not very frequent, but most severe, and these carry a much higher risk of turning into malignancy. Then other precancerous lesions, submucosal fibrosis, with malignant transformation of about 17%, this is considered as an important factor in increasing incidence of oral cancer, especially in adults 35 years and below. Then immunosuppressions. So again, the data has shown that in a number of patients who have undergone kidney transplantation and those who were on immunosuppressive drugs, cancer of lip has been reported, and similarly in case of young AIDS patients, oral carcinoma are also documented. Now briefly about management, how it is being managed in our country. So the problem, as I've shown you the data as well as the global comparison, the picture is entirely different for our country. The lifestyle, the risk factors are different, and similarly the diagnosis and treatment, these are not as per the Western standard. And the major shortcoming, it is first of all with the diagnosis. Diagnosis is often delayed. Although it is something very much evident, but it is delayed, and even when it is diagnosed, treatment is initiated, many patients, they lost during the follow-up. And the data says microscopic examination was the most widely used method for diagnosis in our country. And over 80% of cancers in both sexes has had regional spread of disease at the time of diagnosis, except in Mumbai. Again, the figures are roughly near to 70%. So there are 80% cases, there is regional spread. And diagnostic infrastructure, it is lacking significantly. We have lack of pathologists, cytology centers, which are very much important for diagnosing cancer, and these are not available in many of the districts in our country. And as we have participants from 11 states, so it's somehow similar in Punjab, even in other states, the facilities are not available at the grassroots level. And again, another common problem, significant urban concentration of these facilities only in urban areas. And there is lack of manpower, trained manpower, which also includes trained oncology nurses. So significant number of cancers diagnosed, they are not treated. And treatment facilities, again, restricted to urban areas, and there are no uniform protocols for management. A patient who is being treated at a private center, as a government center, regional cancer center, the treatment is quite different. We have lack of oral and head specialists at all the levels. Then another problem, which is again very much common, that is affordability and availability of cancer treatment. Here also there are significant disparities. Radiotherapy, this is the most commonly used modality of treatment in various cities. And surgery with radiotherapy, this is the most common form of treatment which was given in Mumbai as reported by these cancer registries. Treatment results are 20% less than what is being observed in a similar scenario for the developed countries. And as I said, mainly the problem is with delayed diagnosis and lack of uniform protocols for treatment. Childhood cancers, head and neck only, these are highly curable, but again, it is not achieved in our country due to lack of access to quality care and lack of support system. And the highest 5-year age standardized relative survival for tongue, hypopharynx, laryngeal cancer, this was seen only in city of Mumbai. So all other population-based registries, these are not reporting major 5-year survival rates. Now this is the last one, otherwise. That's about primary prevention, because I belong to community health nursing. Without primary prevention, I'm not going to complete it. So, and I personally believe this is something very important, although this remains neglected whenever we talks about different levels. So few points which already you are familiar with, but once again to reinforce, once again to be talked about each day with all the community people. That is, first of all, it's totally no to consumption of tobacco in any of the form. Then role of diet, it is well documented, and consumption of vegetables, iron, zinc, copper, ascorbic acid, beta carotene, this is associated with decreased risk of precancerous conditions. Role of turmeric, all our Indian spices, cumin seeds, chilies, herbal health foods, and variety of plant seeds, these are also under trial for their protective role in cancer. Then vaccination strategies, especially for HPV, that has to be strengthened. And mass examination screenings, as I said, visual examination of oral cavity, this is something very easily possible. It doesn't require any sophisticated equipments. It is very easily possible even at the grassroots level, by which early diagnosis is really possible. But it has to be brought into our it has to be streamlined actually. Although as per our government programs, ASHA workers, even our community health officers, they have been given instructions to perform this visual inspection of oral cavity for all the adult members, and they are doing screening for all the adults in the community for all NCDs, including screening for head and neck cancer. So this is something very important, primary intervention, which could go a long way in identifying the cases, prevention also, and further, when the case is diagnosed, seeking for early treatment. So that was all with my presentation. Thank you so much. These are few references. Thank you so much.
Thank you very much, Manpreet, for highlighting on head and neck cancer, especially the primary prevention part of it. I think we will take up the question. Anna, so should we call upon the second speaker? Note down the question. So the next speaker is Ms. Sangeeta KS. She is working as nursing officer, head and neck rehabilitation clinic at Regional Cancer Center, Trivandrum. She has worked as nursing officer at Cosmopolitan Hospital, Regional Cancer Center, and PRS Hospital, Trivandrum. Special training in and swallowing from Tata Memorial Hospital, Mumbai. Is life member of Oncology Nurses Association of India. So I think we will have a very good interactive session. She will relate lot of experiences as she has already worked with these patients. So I request Sangeeta to please.
All. Thank you for an opportunity. Today my topic is Diagnosis, Road to Recovery, the Management in Head and Neck Cancers. Greeting from Regional Cancer Center. It is established in 1981, State Cancer Institute, NABH accredited Research and Training Center. I am from southmost part of India. Let's start with my topic, head and neck cancer epidemiology. In my center, head and neck cancer are the number 2 leading cancer among males. It accounts 4% of all cancer and it is the 7th most common type of cancer worldwide. 90% of head and neck cancers are squamous cell type and the usual time of diagnosis is after the age of 40 and more predominant in males. Next, we can see the site where it can occur. It can occur in the lip and oral cavity, larynx, hypopharynx, oropharynx, thyroid, salivary glands, nasopharynx, nasal cavity, paranasal sinuses, and the site-wise incidence you can see in the slide. Then when it comes to head and neck cancers, the nurse's responsibility is to help the patient who underwent treatment such as surgery, chemotherapy, and radiotherapy. Let's see the nurse's responsibility in the postoperative management of patients. The postoperative problems involving risk for aspiration, neck and shoulder problem, nutritional problem, presence of tracheostomy, patients with the surgical OIS restoration processes. First, about the risk for aspiration. Impaired swallowing increases the risk of aspiration. The site and degree of swallowing dysfunctions that depends upon the site and stage of tumor, extent of surgical resection, and the reconstruction used. That is, the resection of structures, vitals for bolus formation, oral transit, and airway protection will make a greater impact in making swallowing dysfunctions. But the resection of lateral floor of mouth and the alveolar ridge having less effect. The nurse's responsibility include maintaining posters, timely assessment of patient by the nurse, and the swallowing manuals. First, about the posters. Posters are very effective for the management of post-surgical swallowing dysfunctions, post-surgical silent aspirations. Choice of poster that depends upon the site of surgery and the kind of aspiration which is noted in the video fluoroscopy. The swallowing disorders can be diagnosed by video fluoroscopy, flexible endoscopic evaluation of swallowing, and flexible endoscopic evaluation of swallowing with the sensory testing. Then the first poster, chin tuck, chin down or neck flexion. Patient is instructed to flex the neck during swallowing. So the base of tongue and epiglottis become closer to the posterior pharyngeal wall and thereby narrowing of the airway entrance, which help to improve the airway protection and prevents the risk of aspiration. Next is head back posture. If the patient having a near total glossectomy or total glossectomy, the oral tongue is not there to propel the bolus from the oral cavity into the pharynx. Hence, gravity-aided passage of food from the oral cavity is possible. So, high risk of aspiration is there, and voluntary airway protection maneuvers should be advised along with it. So, the patient having an increased oral transit time, head back posture is often very possible to that patient. Head rotation. Next posture is the head rotation. Head rotation means rotation towards the operated side, which closes the affected side and bolus pass normally through the normal side. Then next about the swallowing maneuvers. First, supraglottic swallow. It is originally designed for patients after supraglottic laryngectomy, base of tongue resection, and in post-RT patients. It is a voluntary airway closure technique. Patient is instructed to take a deep breath and while holding the breath, ask the patient to swallow and cough immediately thereafter, which help to expel the residue from the airway entrance. Next, effortful swallow maneuver. It increases the pharyngeal pressure and improve the bolus clearance from the vallecula. The patient is instructed to squeeze hard with all their muscles while they swallow. This maneuver is the Mendelssohn maneuver. The larynx is grabbed at the midpoint of swallowing and the patient is asked to continue swallow. Manual elevation closes the larynx and prevents aspiration. Voluntary prolongation of laryngeal elevation during swallowing increases the duration of cricopharyngeal opening. Then the swallowing maneuver is the tongue hold, which is designed to augment the posterior pharyngeal pressure, posterior pharyngeal wall movement. The patient is asked to protrude the tongue and hold in between the central incisors while swallowing. Next problem is the neck and shoulder problems, which is due to cervical contractures and resection of the spinal accessory nerves during surgery. Range of motion exercise. range of motion exercises are designed to improve the movement by extending a target structure at a desired direction, and the stretched position should be hold it for 1 or 2 seconds and thereafter relax. Post-op patients, the post-surgical patients who are doing this range of motion exercise have a good swallowing function than those who are not doing all these exercise. Then the range of motion exercise of the jaw. There is a condition called a trismus or lockjaw. It may be due to involvement of the masticatory muscles. There is scarring, fibrosis. The management is by mouth opening exercise, finger assisted stretching, tackled tongue depressors, and therabite. The therabite, which is a device which is used to restore the jaw mobility. Then the range of motion exercise of the tongue. Instruct the patient to stick out the tongue as far as possible, pass the lips, hold for 1 or 2 seconds and thereafter relax. Next, the patient have to move the tongue towards the right corner of mouth and hold it for 1 or 2 seconds and thereafter relax. It should be repeated on the opposite side also. Then lift the tip of the tongue and place it behind the top of the teeth along the alveolar ridge. Hold it for 1 or 2 seconds and thereafter relax. Then the shoulder mobility exercise. Standing with the shoulders relaxed and head facing forward. Let the arm on the affected side hang freely. Make a circle with the shoulder by moving it forward, upward, backward and downward. Then next the wall climbing exercise. Standing, facing on a wall with your feet few inches from it. Slide the hand on your affected side upward and as far as possible using this wall support. Perform the same exercise with your affected side facing the wall. Repeat this exercise, but do not turn your body while doing this exercise. Then the neck range of exercise. Bring the chin to the neck in a relaxed way and then let it fall gently backward so a stretch is felt on the neck muscle. Slowly turn your head as far as possible to one side as if attempting to look over that shoulder. Do the same on the other side. Bend the head towards the shoulder on the unaffected side. A stretching will be felt on the operated side. The next problem is the nutritional problem. Usually nasogastric tube is there 7 to 10 days after surgery. The tube feeding every 4th hour if the patient tolerate. Report any intolerance, discomfort from the feeding such as nausea, fullness, bloating, diarrhea. Reinforce that changes may be made in feeding to help decrease or alleviate these problems. High protein diet, advice to avoid provide high protein diet, advice to avoid tobacco, alcohol and irritating foods such as hot, spicy, acidic, rough foods. The next problem is the presence with the tracheostomy. That is care of tracheostoma, post-laryngectomy, voice rehabilitation. Care of tracheostoma. Always keep the stoma open. Remove the crust and mucus from the stoma. Always wear a stoma protector which help to prevent the foreign bodies entering into the stoma. Clean the stoma with soft cotton cloth. Take extra care to prevent water entering into the stoma. Avoid showering and swimming. Then putting a thin layer of vaseline jelly around the edge of the stoma before bedtime. It helps to prevent the crust formation. If there is too much mucus in the stoma, to cough it out. Pour hot water in a hand basin and inhale the steam through the stoma. Some patients have a tendency of shrinkage of stoma. In such cases, larytubal tracheostomy, metal tracheostomy tube is inside the stoma, inserted inside the stoma. Then next the post-laryngectomy voice rehabilitation. Immediately after surgery, the patient can communicate only by writing and thereafter they should know how to learn with the alternative measures. There are 3 ways of post-laryngectomy voice rehabilitation. They are artificial larynx or electrolarynx, tracheoesophageal voice prosthesis and esophageal speech. Artificial larynx, which is placed externally for the purpose of sound production. It replaces the laryngeal source with an external sound producing mechanism. Artificial larynx, which is hold against the neck, press the button and make a voice inside the throat. The pitch and volume can be changed. Speech with an electrolarynx, unnatural and robotic. Then next, the components of artificial larynx. It is the size of a small torch and running on battery. It has an on and off switch and there is tone control and volume control and pitch control. The parts involving power supply, oscillator, wheel vibrator and a diaphragm. Artificial larynx vibrate to produce a sound inside the throat. The teeth, lips and tongue that convert it into speech. The typical one involve Servox and Neovax. London made about 40,000 and Indian made cost about 12,000. There is a video, patient speaking with the artificial larynx or electrolarynx. Video, it's not working. Not working. Then next, tracheoesophageal OIS processes. A hole or fistula is made connecting the trachea to the esophagus. In the fistula, the surgeons will place the prosthesis. If it is done at the time of surgery, it is called the primary TEP insertion, or it can be done after 6 months or whenever needed. That is the secondary TEP insertion. Then the OIS processes is a one-way valve that allow exhale air to pass freely into the esophagus, but close during swallowing to prevent and the liquids from entering into the lungs. To speak, simply exhale while covering the stoma, and the air from the lungs will be pushed through the OIS processes into the esophagus, where a pseudo or false OIS is produced. It is articulated as speech. Then care of the TEP valve. There is a special brush is often available along with this kit, and which help to remove the colonized yeast, debris and mucus inside the processes. Thus, we can extend the life of the processes. To maximize the result, the brush should be used at the morning and at the evening. Actually, candid mouth paint gel can be used for cleaning processes as a precaution to prevent the fungal infections. Wash hands with microshield or soap and water before cleaning the processes. Working. Then the esophageal speech. The voice is created by swallowing air and then transferring it back up. From a burp-like tone is produced, which can be articulated as desirable speech. Not all laryngectomies are able to do the esophageal speech, but it provides a hand-free speech at all the time. Then problems related to head and neck post-radiation therapy, oral mucositis, skin reactions, xerostomia, taste changes, dental caries, osteoradionecrosis, hypothyroidism. The clinical features of mucositis involving erythema, ulceration and pseudomembrane formation. According to the grading scale, RTOG grading scale, the grade 0, no changes, grade 1 erythema, grade 2 patchy reactions, the grade 3 confluent reaction, and grade 4 deep ulceration, necrosis and bleeding. And the nursing care of patient with mucositis, assessment of the oral cavity, any watch for any desquamations or anything you should be reported, administer analgesics before meal, dietary modifications, instruct do not take smoke and avoid smoking and alcoholism, instruct for good oral hygiene, use of artificial saliva if needed, suggest sugarless lemon drops or mints to increase the salivation. Then the nursing care of patients with xerostomia. Radiation to the xerostomia is due to radiation to salivary glands. The silagogus such as pilocarpine is available. Intravenous amifostine infusion daily before radiation therapy. The saliva substitutes are often available: dry mouth, wet mouth. Then tooth decay and caries. Comprehensive dental evaluation. Dental extraction should be completed within 10 to 14 days before radiation. Speak into time, allow a time for healing. Then the fluoride gel application. Osteoradionecrosis, dosage exceeds 60 gray. Good oral hygiene, avoidance of smoking and alcoholism, maintaining adequate nutritional status, poorly fitting dentures, educating regarding dental, properly fitting dentures, educating regarding dental care and follow-up after radiation. Then the problems related to chemotherapy, there is myelosuppression, chemo-induced nausea and vomiting, mucositis, diarrhea, constipation, anorexia, stomatitis, altered taste, dry mouth, heartburns, alopecia, dermatitis, urticaria, nail changes, hyperpigmentation, and radiation recall. Then the follow-up. Follow-up in head and neck patients has several goals: to assess the clinical response and late effective treatment, to detect the recurrence and secondary cancers at an early stage, to restore the nutritional and psychological status. The comprehensive patient care involves relief from cancer-related symptoms, better compliance to treatment, relief from treatment-related symptoms, better delivery of treatment. The supportive care from nurse act as a. Thank you.
Thank you, Sangeeta, highlighting the diagnosis and swallowing practices of patient. I hope we could see those nice videos so that we can see actually this how this process is going on. And I think whosoever want to see, she may be having on her phone. You can simply look at her phone and see how actually the video progresses. So I will call upon the third speaker of this session, Dr. Anita D. Souza. She's professor cum principal, Tata Memorial College of Nursing, and she's secretary, Oncology Nurses Association of India. She has completed MSc Nursing, graduate diploma in education management, certificate course on research methodology. She is pursuing PhD in nursing from MD of Health Sciences. Has published various articles in national and international professional journals, including PubMed. He has conducted research on 12 problems. Involved in content validity of research to editing in research articles as a research for lectures on research at UG and PG. Contribute the chapters writing in book as a co-author chapter Oncology Nurses, book published by TNAI in 2010, has been resource person conducted at national and international level. I request Anita D'Souza to kindly present the topic. We'll talk on role of nurse navigator in head and neck cancer.
Thank you, ma'am, for your introduction. I think 2 sessions are already over on head and neck cancer. There may be some of repetition might be there, but just bear with me for that. So I'll be talking, excuse me, role of nurse navigator in caring for patients with head and neck cancer. So head and neck cancer, what are the head and neck cancer? They are the cancers of the upper aerodigestive tract, okay, which includes right from your the nasal sinuses, your oropharynx, oral cavity, your hypopharynx, laryngopharynx, larynx, thyroid, etc. So these are the cancers which are actually included under the head and neck cancers. And as you can look at this picture, you can see that this head and neck region is very, very, it is like, drained by a lot of lymphatics. So that's the reason the role of lymphatic removal is very important when we talk about the head and neck cancer treatment. Now, looking at the incidence of head and neck cancers in India, if you look at the graph, you will be able to appreciate that the head and neck cancer incidence is very, very high. In fact, it is the highest cancer among the Indian population. Probably this is because of the use of various forms of tobacco. And it is also seen that HPV infection is responsible for causing head and neck cancers as well. The risk factors are like various forms of tobacco, alcohol consumption, as I told, the diet, which may be lacking antioxidants, poor oral health. Because, and also, sometimes people have got ill-fitting dentures, or the teeth may be very sharp. And of course, as I told, viral infection by HPV virus. So in HPV virus, it is the 6 and 11 strain is the one which is responsible for causing the head and neck cancers or the oral cancers. So how do we diagnose the head and neck cancer is initially by screening among the patients who are actually not having any symptoms of the cancer. So screening the larger number of people. Then by symptoms, many of the patients come with pain, or they may come with ulceration in the on the tongue, or there might be some kind of a lesion or difficulty in opening the mouth. Okay, so those might be the early symptoms of the head and neck cancers, or even the hoarseness of voice. Then in the later stages, the patient will come with dysphagia because the tumor might be big and it may be pressing onto the esophagus. As we know, larynx lies just anterior to the esophagus. The patients might also experience weight loss, that is we call as cancer cachexia. There might be respiratory difficulties, voice changes, and there might be neck masses if in case there are lymph nodes which have been involved by cancer. So what investigations the patients typically undergo is that when they come with the symptoms suggestive of the cancer of either head or the neck region, we take the biopsy and we check it. We do a histopathology for that. FNAC, fine needle aspiration cytology, is done if the patients have got a lymphadenopathy or the enlargement of the lymph nodes. Then USG is done, and USG is typically done of the neck, again to find out if the neck nodes have been involved by that. And CT scan is done. Now, we don't do PET scan much in head and neck cancer because it has got a limited role in case of the head and neck cancer, and because head and neck cancer don't much metastasize to the distant parts of the body. So it may not be recommended, or it may not be advised for the patients in many of the centers. So now once the patient has been diagnosed with cancers, this is a typical continuum or the journey that the patient goes. First there is a state of health, then the changes in the health happen, the patient undergoes diagnosis for cancer, there is a treatment, and the treatment outcome could be that the patient is cured of it, or that the patient is not responding, or the patient the symptoms have been have subsided and the patient might come. So there can be either disease-free survival, or there might be a recurrence, or the patient may be diagnosed to be in the end stage disease. So this particular road, right from the health till whatever may be the outcome of the treatment, this particular journey is not very easy. There are lots of obstacles, and there are a lot of difficulties that the patients face. So what are those difficulties? One of the things is very important for these head and neck patients is that they have got a very poor functional status. The reason is because many of the patients tend to neglect or ignore these problems, and because of which by the time they come to the hospital, they're already in third stage. And during this time, the patient would have had suffered a lot of nutritional impact, the negative impact, because of which the patient's nutritional status has gone down and now it has affected the patient's functional status. Then the patients come with advanced disease, and when the patients come with advanced disease, sometimes they might have a very huge tumors, fungating tumors in the oral cavity or on the buccal mucosa, and that makes things very difficult for them even in the psychosocial realm of life. The patients also have a lot of treatment related side effects. We just saw that when the patients undergo surgery or the radiation therapy, it not only has acute effects, but the patients do have lifelong negative impact because of the treatment. Then many of the patients come from the low socioeconomic status, and we know cancer is a disease where the treatment is not limited to for a period of maybe few days, but the treatment goes on for months and also years. And the patients usually come from the lower strata of the society, and because of which the lower socioeconomic status will actually again complicate the matters for the patient and make this journey more difficult. Nutritional status I've already talked about, and the comorbidities. The patients will also have comorbidities in the form of diabetes mellitus or hypertension or many other things, and we cannot, and this will also restrict the treatment to some extent. And of course, there are multi-step complexities. For example, when the patient comes for a diagnosis, the diagnosis itself will take a lot of time, because when we find something in the patient or we don't find something, the doctor might advise the patient to do some other test. And these investigation modalities may not be available in all the institutes. And the institutes which has these modalities available will have a large patient load. So the patient will have to wait. So all these factors together, along with the psychological health of the patient, makes this journey extremely difficult, and that's where the role of a nurse navigator is very, very important. So what is nurse navigator? It is the nurse navigation is an individualized assistant provided to the patient and family to reduce the barriers, to increase access to medical and psychosocial care across the entire continuum. So this nurse navigator not only provides care to the patient, but also to the family, because in cancer setup, it is not only the patient, it is the entire family which gets actually wrapped up in this trauma of cancer diagnosis. And to increase the access to medical as well as psychosocial care, because we know that cancer has got a lot of impact on the psychosocial health or the state of the patient, and that we need to help them even through that particular area of life. So there are certain roles of, there are certain models of nurse navigation. So I think this is the one which is more easy for us to understand. That this nurse navigation doesn't begin at a particular stage in the cancer continuum, but it starts right at the time of prevention till the time the patient is either declared to be a disease-free or the patient's life has come to an end. So toward this journey, the nurse navigator is there with the patient and the relative to provide alleviation from the physical and the psychological difficulties. So what are the important characteristics of these nurse navigators? One thing is that she provides individualized care. Second thing is that there is a clinical coordination. She coordinates among the multidisciplinary team members. We know that cancer is something which needs to be managed with the multiple disciplinary team, which includes right from the time of, right from the physicians who are in the preventive oncology till the palliative care team. It also talks about the healthcare utilization, because many of the patients are not aware about what works, what doesn't work, and what needs to be taken care of, or what needs to be done in case there are any complications related to the side effects. So she also, kind of an advocate for the patients to tell them, what can they utilize and how can they go about utilizing it. And of course, and also early supportive and palliative care for the patients. So, the role is more comprehensive, and it transcends into every area of the patient's cancer journey. So, so what is the role of a nurse navigator as far as the diagnosis is concerned? One thing is that we understand, since we are working in the cancer setup, we understand patients have a lot of barriers, and it's mostly psychological. Even if there are any symptoms that are maybe suggestive of cancer, patients don't want to come to the hospital. So we need to, we need to help them to overcome this barrier by telling them that early diagnosis will aid in cure for the patients. educating them, to identify what are the signs and symptoms of the cancer, because patients will have, trismus, they might have ulcers which don't heal. So we need to tell them about that also. And importantly, patients don't know where to go. So referrals are again very important. The patients can be referred to the dental department. The speech, once the patients have been diagnosed of cancer, they need to do a lot of workup before they are actually started on the therapy or the treatment. So they need to be referred to the dental department, because as the earlier speaker has said, that they need to, look at the oral health. They need to look at if there are any loose teeth, okay? And that needs to be taken care of before the patient. Patient will not know why this has to be done. He doesn't understand what is the relationship between this dental, concerns and the treatment for the cancer. So that needs to be told to them. Referring patients with the speech and the language pathologies, because many of these cancers, will impact communication, swallowing of the patients. So the speech and the language pathologists will actually aid patients in telling them how they can be rehabilitated in the post-operative period with regard to communication. See, sometimes the patients may not have a permanent tracheostomy. They might just have, an oral surgery done and may have a temporary tracheostomy. But even during that time, the patients will have difficulty in communication. So that's what is explained by them. And also, the speech and language pathologist will also take care of the patient's swallowing difficulties post-operatively. Another thing is dietitian. As I told, that many of the patients will have poor nutritional status, and these patients' nutritional status needs to be built up before they're actually put onto any type of therapy. So they need to be referred to the dietitians for an optimal nutritional build-up. Social workers are extremely important, because many of these patients, since they come from lower socioeconomic status and they might have the poor finances, they need to be referred, and so that they will be able to get some help. And tobacco cessation facilities. So there are certain centers, or there are certain clinics where they actually help the patients with the tobacco cessation facility, in terms of giving them chewing gum which contains nicotine, because it's the nicotine which causes withdrawal symptoms in the patients, and that can be done for them. So patients can be told, these problems are something that can be taken care of. Now, head and neck cancer is actually, it's a multidisciplinary team, and you have a surgeon, nutritionist, the radiation oncologist who will give the patients radiation therapy depending upon the stage of the disease, social worker, psychiatrist, psychologist because of the psychosocial issues, radiologist who help in diagnosis the disease and also the extent of the disease, dentist, palliative care team, a head and neck nurse, speech language pathologist, and the palliative care nurse, and the physician in case the patient is declared to be in the terminal stages of the illness. So what are the surgeries done for the patients with head and neck cancer is that we resect the area as much as possible. And also the second picture, you can see the person with all these neck nodes. They also remove the neck nodes in case the patient has got a spread to the lymph nodes. But there are certain cancers like the tongue cancer, where even if the cancer has not spread to the lymph nodes, to prevent further problems, the patient's lymph nodes are still taken out. Okay? So these patients will undergo lymph node dissection anyways. And then after that, for the cosmetic purposes, or even for the purposes of function, to allow the patient to function or have the adequate function of the oral cavity, the patients do undergo reconstructive surgery. So you can see in the first picture, the patient has had that entire removal of the cancer part and some of the normal tissues around, which is the principle of cancer surgery. The second picture you can see is there is a flap put. Okay, it is a part. It is a part of the skin and the subcutaneous tissue taken from the other part of the body, and it is placed in that place, okay, so as to avoid any disfigurement. And the lower picture you can see is the how the flap looks from inside when you open up the oral cavity. Okay? Now, when the patients are in the acute stage, what we need to do is that oral care is very important for these patients, whether it is a surgery on the neck, or it's on the trachea, or on the larynx, or in the oral cavity, because many of these patients will have a flap. And if the oral care is not adequate enough, the flaps can undergo failure. And these flaps, if they undergo failure, is going to take more time again for reconstruction, and is going to involve more expenses. So the patients need to be told, that during the daytime, yes, the nurses will come and look after you, but it's equally your responsibility that you use some antiseptics and gargle your mouth every time and keep your oral cavity clean. The care and maintenance of the airway is also another important thing, because many of the patients might have a temporary or the permanent tracheostomy. So maintaining this airway, we used to have this problem earlier, that we used to send the patients home with a temporary tracheostomy because we have a lot of patients, turn around. But many times the patients used to come with the blocked tracheostomy. Okay, so in centers where the patients go home with a tracheostomy tube, they need to be educated on importance of suction and importance of keeping it clean and preventing any foreign substances going from inside. Nutrition is again important, because it is, when the patient is going to receive the chemotherapy or radiation therapy, it is further going to bring it down. Head and neck exercises are very important, because these surgeries itself will cause lot of strictures and lot of because many muscles are taken out, so that is going to affect the patient's movements. So they need to be encouraged to do these exercises even after the physiotherapist is not there in them. And also the neck exercises, because we know that lymphatics, when they are removed, the lymph fluid can get collected and the patient can have lymphedema on the oral cavity and in the neck region. So they need to be told to do these exercises more often, because otherwise that can affect the patient's quality of life. The care of flap, I told you, and monitoring for complications such as hemorrhage and the flap failure. When the flap begins to fail, it starts looking edematous, it starts looking dull. Okay, and when you prick it with the 26 number needle, you will find that it's taking a lot of time for the blood to come out, which is again maybe dark in color. Then if the patients are undergoing radiation therapy, because sometimes the patients require not sometimes, many of the times, because they come in stage 3. So they might require radiation therapy. Again, the patients will be thinking, ye kya hai, ek light to dena hai, uske liye how much time they are taking. But again, the patients have to be told that when you are undergoing radiation therapy, we have something called as radiation therapy planning, which might take time. Okay, so in radiation therapy planning, you can see in the first picture, they prepare the fixing device, which we call as ORFIT. Okay? So this ORFIT is made individualized for every patient, and the patient has to be told to keep it, preserve it, and to bring it every time the patient comes to the hospital, because this immobilization device will help to keep the part in place, because of which the radiation therapy beams or the rays will not go to the other parts where it is not required. So the patients have to be told that it might take some time, because we want to give you the treatment which is more precise and it is delivered to the tumor and not to the other normal tissues. Okay? And you can see the second picture, you can see that's a brachytherapy, and brachytherapy is an internal radiation which is given to the patients when they have either the tongue cancer, okay, where we put in the, you can see those tubes, and through those tubes we put in the source into the area where there is cancer, and this delivers radiation and helps to kill the malignant cells. Okay? So you can see this is that the radiation therapy planning is called as this, the stimulation, okay, where it is the entire setup is just like the radiation therapy, but it does not deliver the radiation. We just look at where is the tumor and where are we directing our radiation beams to, and we adjust it accordingly. So the patients need to be told, they don't understand these things. Okay? So they need to be told, and which is an important part that can be performed by a navigator. So the acute complications, of the therapy could be like, the radiation therapy can be dermatitis. The patient will get, it can be either wet desquamation or they can be dry desquamation, where the patient's skin starts looking, black. There might be oozing of the fluid, and there might be even pain. So we can tell the patients to, need to apply some junction violet, and tell the patient to keep the area dry and keep applying this junction violet. Mucositis is another problem when the patients receive radiation therapy to the oral cavity. Okay, so it's already told earlier that when mucositis happens, prevention and treatment is by gargling mouth with the chlorhexidine or any antiseptic mouth washes in the concentration of 1:1. There can be salivary gland dysfunction. Okay, this is something which happens primarily because of radiation therapy, because many of the centers still have the conventional radiation therapy techniques that are used for delivery of radiation therapy. Now, when your salivary gland, especially the parotid gland, comes in the way of the radiation therapy, the parotid gland will stop producing or will produce very little saliva, and the patient will have dryness of mouth, which we call as xerostomia. And unfortunately, they don't recover after the radiation therapy has been stopped. So the patient has to live with it for the entire life, and it really reduces the patient's quality of life to a very, very large extent. The secondary complication could be infection, pain. This is not because of radiation therapy, but because of the complications. There might be dehydration because of difficulty in swallowing, dysgeusia because here the patients are unable to taste the food that they are eating, which can further complicate malnutrition. The late complications, as I said, is xerostomia, which is dryness of mouth, dental caries. Now, all of us know that the saliva is very, very important for us to maintain the hygiene of our teeth, because this actually helps us flushing. It also has certain proteolytic enzymes which kills the bacteria. So when the saliva is produced in less quantity, the patient will have the dental caries. Okay, so the patient needs to be told that you need to follow up with a dentist more regularly, because these patients require fluoride treatment every 6 months. So again, the patients to be told that this is not something which is going to go away. You have to be doing and following it up with the dentist, because the researchers have shown that the artificial saliva, the pilocarpine, all those things don't help. Okay, and they're very expensive also. The best thing to do is that you follow up and keep eating. I mean, this also affects the patient's nutrition, because patient is not able to swallow the food as saliva is not there. Then the patients can have trismus. Trismus is difficulty in opening the mouth. This may happen because of the healing of the surgical scar in the post-operative period. So for this, we ask the patients to use the jaw key. Okay? So jaw key is given to the patients, and we teach them. It's a key that we keep, and we keep extending the diameter of it, and we tell the patients to use it all throughout till the time they're comfortable and are able to open their mouth to the optimal ability. Then osteoradionecrosis is a condition which is again encountered when the patients have undergo radiation to the mandible. So the mandible gets affected. There is kind of an erosion, and because of which the patients will experience a lot of pain. Because of osteoradionecrosis, the patients need to be told that you might have this problem, and if you have this, you have to come, because the patients are given hyperbaric oxygen therapy to take care of this particular problem. So tell them not to sit just quietly at home. And the dental effects, as so all the surgery, chemotherapy, and radiation therapy will have oral and dental effects. Okay, and this needs to be explained to the patients. Then the patients patients need to be referred to the speech therapist, because the patients have to be told that the patients who undergo surgery on oral cavity as well as laryngectomy, because the laryngectomy patients, again, as we have heard, they have a voice prosthesis, or they can have an electrolarynx. Okay? And they need to be again informed, that when they use an electrolarynx, the voice may be robotic. But now new electrolarynx have come where the voice is of a better quality, but the cost is quite high. So the patients need to be told about this also. And esophageal speech. Esophageal speech is something which doesn't cost patients much. But here, the esophageal speech, it requires a lot of skill on the part of the patient. Then the patient will also have difficulty in swallowing. So in difficulty in swallowing, the speech therapist help the patients to swallow the food and the fluids in a particular manner. So they need to be told to follow those things and not try, Initially, they have to swallow liquids, and then they go on to the semi-solids and then solids. So we have to tell them that you keep the flow in the similar manner and don't hurry up. As I told, the dietary restrictions and the consistency of the food that they take. Then psychosocial aspects of care is again very important. The interpersonal relationships, because of these, because the cosmesis is affected, the appearance is affected. So many times we see nowadays the spouse of the patient leaves and goes. And let me tell you that this is not that only the men leave their wives and go. Nowadays, even the wives are leaving their men and going. Okay, so that is the trend that we have been seeing in our hospital now. So we have to actually help them in their interpersonal relationships, because it is the entire family who is at work in helping the patient to get all right. The social stigma again is something that is experienced by the patients, So we need to tell the patients, that fine, there may be social stigma, but as the people become aware about these things, there might be a better acceptance. And the other thing is that we need to be happy that we are at least cured and we've got a second lease of life. Then we need to warn them about the continued substance abuse. Okay? To be told them that to stop it altogether. Finances, the nurse navigator needs to educate the patient with regard to various government schemes which are available, and also direct them to the social worker, because without these financial aids, it's extremely difficult to continue with the patient's treatment, and they play a very, very important role. I'm telling you, this is what we have experienced in Tata Memorial Hospital. It can also have an impact on employment, especially if the patient is involved in the work where he requires to speak. Okay? So this might impact the employment. So there are many agencies who are helping the patients in terms of their employment rehabilitation. So we need to refer them to even those agencies where the patients can be employed. The patients can also have body image disturbances, like there can be visible scars. There can be changes in the facial contours, especially when the patient has a lateral mandibulectomy done. The patient's contour will be changed, because it is not necessarily they do a reconstructive surgery. There can be changes in the facial expressions, because sometimes, your facial nerve gets damaged because of the tumor, and the patient might have some drooping of the eyelids or even the corner of the mouth. The patients can have visual changes as well. Dysgeusia, I have told you. Anosmia, whereas the patient has got a loss of sense of smell. There can be lymphedema because of the removal of the neck nose. Skin changes, the skin might look darkish, and there might be fibrosis. The patients need to be told about all these things, and there are many patients who have been successfully rehabilitated despite all these shortcomings because of the treatment and the disease. We need to make them meet, because once they know that there is somebody else who's living a life as normal as possible, they get much encouraged by that. Then advocacy is something important, because nowadays there are tooth implants which are available. So the patients can actually undergo tooth implants. With regard to the cosmesis, patients can, if they want to, for the purpose of cosmesis, they can undergo repeat reconstructive surgery, so that the appearance is as near as it was before the treatment. The speech, swallowing, I told you, and the trismus, that is use of the jaw key. Another important role of a nurse navigator is the end of life care, because many patients may be declared to be palliative. So, taking care of the pain, these patients are put onto the narcotics. So teaching them about narcotics and teaching them about how to take it and how often to take it. Otherwise, the patients use the narcotic, and then they don't, after some time they don't take it regularly, and the patients get more severe pain than before. We call it as a breakthrough pain, and they're very difficult to manage. So patients need to be told that please take it as a doctor, because ultimately the goal is to help the patient in relief of pain and to have a painless journey towards the end of life. Dysphagia, so for these patients, the doctors might put the Ryle's tube, and we need to teach the relatives about the feeding. Then they might experience a lot of fatigue, weakness. So we need to tell them a few exercises might help. The patients can have chest congestion and pneumonia because of the immobility. So we need to tell them about use of the steam inhalers, cough, dysphonia. There might be bleeding, because many a times the patients after radiation therapy, because of the involvement of the carotid artery, can have a carotid rupture or the blowout. Okay? So they need to be instructed about it, and should be told that if in case it happens, you need to come immediately to the hospital. Then xerostomia, I told you, and wound management again, because many of these patients will, many patients with the oral cancers come with fungating wounds, where it is, it looks very bad to look at. Secondly, there might be some maggots, the flies are sitting, and it can also have it doesn't have a very good odor. Okay, so we also need to manage these wounds. The role of a nurse navigator in survivor care is lymphedema. Management of lymphedema. So there are trained lymphedema practitioners. So we can refer them if they don't want to go to the physiotherapist. Telling them about going to the speech pathologist, dietitian, because many of these patients might be even fed through the nasogastric tube. Physiotherapy for ongoing musculoskeletal pain, neck, shoulder, and temporomandibular junction, chronic wound management, and the employment issues. So what can the oncology nurse do in all these things? One thing is that help the patient to understand the diagnosis, the disease, the prolonged treatment. Next thing is that provide education to enable informed decision making, because they, before they make the decision, they need to know what could be the, because like many a times when the patients are in stage 4, they want to take immunotherapy, but they don't understand that immunotherapy is extremely expensive and it cannot be given for a very, very long period of time. And there are some patients who are just not fit for immunotherapy. So they will be able to make a better decision with regard to these therapies. Coordination of care with the multidisciplinary team, care of the patient in the acute stage of the disease and the treatment, and stand with the patient through their cancer journey. So in the end, I would like to say that the one size does not fit at all, fit all. And that's how the nurse navigation may not be the same for everybody, depending upon the patient, the disease, the stage, the treatment, and the other factors which are associated with the patient and his family. You might have to change the way you are navigating them through the. Thank you very much.
Thank you, Dr. Anita. And with this, I once again thank all the speakers of these sessions, including Dr. Manpreet Kaur, Dr. Anita D'Souza, and MS Sangeeta. So, as during this session, we already have had extensive knowledge sharing regarding the role of nurse and various issues, and of course, epidemiology related to head and neck cancer. And all the speakers have nicely shed light on all these issues. So if any of their query regarding all these issues, we can just entertain few of the questions. Actually, participants are getting late for their lunch, but still we want few of the query if you have any. So from participant side. If anyone has any query. Yeah. So actually, as we know, this head and neck cancer, it is actually like we have seen the epidemiological facts in the first session. So we know that this is very much vast data are there, and in Punjab also, Malwa region, we can focus on the Malwa region. It is it once known as the cancer belt. Cotton belt as well as the cancer belt and cancer train. We have all heard about that cancer train used to go to Bangalore, Bikaner for the treatment. So looking at these issues, we can say this is very much and practical topic that we have discussed during this session. So if there is still no more questions, so I thank all the speakers. And with this, I think I should hand over this to the, those who are handling this stage. Thank you.
So thank you so much, ma'am. And now I would like to request Dr. Rita Lakhani, Principal of Jupiter College of Nursing, Maharashtra, and Dr. Parvez Saini, Professor cum Principal of SGRD College of Nursing, to honor our chairpersons. Dr. Sushma Saini, Associate Professor, 9 PGIMER, Chandigarh. Dr. Sushma Saini, Associate Professor, 9 PGIMER, Chandigarh. Dr. Preksha Sharma Maheshwari, Associate Professor, College of Nursing, Baba Feed, University of Health Science, Faridkot. Now I would like to request our chairpersons, Dr. Sushma Saini and Dr. Preksha Sharma Maheshwari, to join Dr. Parvez Saini ma'am to honor our resource persons. Dr. Manpreet Kaur, Professor cum Vice Principal, SGRD College of Nursing. Ms. Sangeeta KS, Nursing Officer, Regional Cancer Center, Trivandrum. Dr. Anita D'Souza, Secretary, ONAI, Professor cum Principal, College of Nursing, TMH, Mumbai.
So, ladies and gentlemen, this is the meal time now. We will be resumed here at 3 p.m. and meanwhile, paper presentation will be started at Biochemistry Hall at 3:50 p.m. Those who have taken their lunch, please stay here.
Actually, we are late. So those who have done your lunch, please keep sitting. And rest of you have your lunch. We'll start with our next session. Our next interactive session on BMT.
I'm really
Moving on with today's event, I, Amitosh Kaur, and I, Barbie Kaur, students of BSc Nursing 3rd year, Shri Guru Ramdas College of Nursing, are here to announce the commencement of interactive session on bone marrow transplantation. Distinguished guests, ladies and gentlemen, Dr. Rajiv Gupta, Associate Professor, Oncologist and Hematologist, Shri Guru Ramdas Medical College, Walla Amritsar, have been gracious enough to join us as a chairperson today. Sir has done his MBBS and MD in medicine from University of Jammu, achieved professional diploma in clinical research, diplomate of nursing board, medical oncology from New Delhi. He worked as a senior resident in Department of Medical Oncology, Rajiv Gandhi Cancer Institute and Research Center, New Delhi. As consultant and head, Department of Medical Oncology and Hematology at Patel Cancer and Super Speciality Hospital, Jalandhar, Fortis Escorts Hospital, Amritsar and SGRD Medical College, Amritsar. He is editorial board member, ACTA, Scientific Gastrointestinal Journal, certified reviewer, annual research and review in biology journal. He worked in 6 clinical trials as principal investigator. He presented 25 paper and scientific publication at national and international level. He presented 2 posters at national and international level and supervised 3 theses. Now, may we ask our respected ma'am, Dr. Parvesh Saini, Principal of SGRD College of Nursing, and Ms. Anita D'Souza, Secretary, Oncology Nursing Association of India, Professor cum Principal, College of Nursing, Tata Memorial Hospital, Mumbai, to honor our chairperson of today's event. Please, ma'am, do the honors. Dr. Rajiv Gupta. Ladies and gentlemen, we really get this opportunity to listen to the great words of great knowledgeable speaker. Yes, I'm talking about Ms. Komal Kailash Munde, Nursing Officer, Department of Bone Marrow Transplantation, Advanced Center for Treatment Research and Education in Cancer, Mumbai. She has received diploma in oncology nursing and certified central venous access device nurse, and she is working as senior staff nurse at Tata Memorial Hospital, and she joined the hospital in 1995. She has work experience in bone marrow transplantation unit from 2007, that is 15 years, and she is an Oncology Nursing Association of India Executive Committee member. And she has participated in poster presentation at national and international level and got second prize at national level. So I invite Ms. Komal Kailash Munde, ma'am, on the stage to address the gathering about tutelage for bone marrow transplantation patients with graft versus host disease, which is a nursing challenge.
My session is the bone marrow, tutelage of the bone marrow transplant patient with the graft versus was disease, nursing challenges. My topic is tutelage of the bone marrow transplant, patient with the graft versus was disease, nursing challenges. Next, introduction. GVHD is the most recognized life-threatening complication post-hematopoietic stem cell transplant. It was the first observed in the 1956 in the Murrell model. Definition. Acute graft versus was disease is generally occur within the 100 days of the allogenic transplant, stem cell transplantation. It is a reaction of the donor tissue cells and a recognized host was disease. There will be the main three part of the affected. One is the skin, GI tract and liver. Types of GVHD. There is the two types of the GVHD. One is the acute GVHD and chronic GVHD. Acute GVHD is typically occur within the first 3 months of the after transplant, and chronic GVHD when the right cells are on the rising, then probably is called the chronic GVHD. There is a risk factor of the GVHD, mismatch related, unrelated donor. The donor and recipient is relative, but they are not 100% matching. The most of sometimes they are the 50% match. That is called the haplo matching. The age of the donor and recipient is the older ages. This is the one of the risk factor of the GVHD. Then pre-transplant, we are giving the pre-transplant high dose of the chemotherapy and total body irradiation. This is the one of the risk factor of the GVHD. Next is a donors. Donors is a woman. He has the more number of children. Means donor is a woman, but she has having the 3-4 child. This is the one of the risk factor of the GVHD. Then common virus affected after the bone marrow transplant, like a fungal infection, bacterial infection, and cytomegalovirus is present after the transplant patients. Sign and symptom. There are the sign and symptom of skin GVHD, GI tract, liver GVHD, lung GVHD, and mouth GVHD. One by one, you will see the sign and symptom of the GVHD. Skin GVHD, in the skin GVHD, rash present on the hand, palm, face, and when especially look like the sunburn, blister present in the skin. Then GI tract, anorexia is present. Patient is not feeling, patient is not taking proper food. They are anorexia is present. They feeling the nausea and vomiting. 5 to 6 times they are passing the vomiting in the day. Weight loss, because they are not taking the properly food, the weight loss is there. Then diarrhea is present. The GI tract, when the GI tract GVHD is present, the patient are having the 7-8 episode of the diarrhea. Then stage 4 crampy abdomen pain is present. This is a very worst crampy abdomen pain when the patient is a stage 4 GI tract. Liver GVHD, hepatomegaly, when you are palpating the abdomen, the liver is palpating while the examination. Jaundice present in the liver GVHD because the bilirubin is rising, that is the patient having the jaundice. Then coagulation, abnormal coagulation present in the liver GVHD. Then itchy skin present because the bilirubin is high. The patient complaint of the itchy skin is present. Lung GVHD. When you are in the lung GVHD, when you are taking the X-ray, then in the X-ray we will see the pneumonia, pleural effusion present in the X-ray, and because the pleural effusion, patient complaint of the breathing difficulty, dry cough present in the lung GVHD. Mouth GVHD, white patch present in the mouth. Oral pain is present, sensitive to food. When you are taking the patient food, they are not taking proper food because the mouth GVHD. So we will see the diagnosis of the GVHD, clinical examination. Daily we have to do the clinical examination. Every shift duty you have to change any changes in the patients. Then X-ray test, we have to rule out any pneumonia, any pleural effusion. When you are taking the X-ray, we will see the that pleural effusion and any patches is there. Colonoscopy, for when we are doing the colonoscopy, that time we are taking the biopsy to rule out the gut GVHD. Then liver biopsy, we are taking the small piece of the liver and sending for the histopathology and to rule out the liver GVHD. Blood investigation, in the GVHD patient, the patient coagulation is deranged, then patient having the zero count and patient having the infection count, platelet count, and WBC count is less. So we are doing the daily CBC and all biochemistry, we are doing the all investigation. CT scan and MRI we are doing to any patches is there, any fungal infection are there, we are seeing in the CT scan and MRI. Endoscopy, upper GI endoscopy you are doing for the gut, GI, upper GI, mouth GVHD. Skin biopsy, when the skin patient skin GVHD there, whether taking the small piece of the skin and sending for the histopathology to rule out the skin GVHD. Then prevention, the prophylactic immunosuppression drugs we are giving in our hospital. We are giving the cyclosporin, methotrexate, then mycophenolate, the tacrolimus, sirolimus immunoglobulin. Cyclosporin we are giving the -1 BD to the patient. Then immunoglobulin we are giving the day +1, day +21, day +42, and day +64 we are giving. This is all are the immunosuppressive drugs. Then MTX we are giving to the patient day +1, day +3, day +3, day +6, and day +11. If patient is having the severe mucositis, we are skipping the day +11 methotrexate. We are not giving the day +11 because MTX we are not giving. Then select the best HLA matching donor. You have to select the 100% HLA match. If the donors and relative is not matching, you can go for the MER transplant. Match unrelated donor, you can choose the MER transplant. Then use the antifungal, antivirus, and antibacterial. When patient's count is 0, that time the patient having the fever, systematic antibiotic, you have to start the systematic antibiotics and you have to change the antibiotics gradually. Then we are giving the antiviral before the transplant. We are starting the tablet Acyclovir 400 mg TDS to the patient, and if patient having the fungal infection, we are giving the oriconazole ambizone injection, ambizone 50 mg in 5% dextrose. Then we are giving the oriconazole injection if the patient is not able to eat orally. Then we are giving the mycofungin also to the for the coverage of the antifungal. Then there are the staging of the GVHDs. Stage 0 is stage 0, rash present on the skin. First we will see the skin GVHD. Stage 1, stage 0, no rashes on the skin. Stage 1, rash less than 50% present on the skin. Stage 2, rash 20 to 50% present on the skin. Stage 3, erythema derma present on the skin. Stage 4, blister present on the skin. And then liver GVHD, we will see the liver GVHD staging. 0, the bilirubin is at less than 2 mg per dl. Stage 1, the bilirubin is 2 to 3 mg per dl. Stage 2, bilirubin 3 to 6 mg per dl. Then stage 3, bilirubin 6 to 15 mg per dl. Stage 4, bilirubin is 50, more than 15 mg. This is very dangerous for the patient. And last is a gut GVHD, where we will see the staging of the gut GVHD. The stage 0, patient passing the diarrhea 500 per day. 3 episode of the motion. The stage 1, patient passing the motion 500 to 1000, 3 to 4 episode of the loose motion. Then stage 2, patient passing the diarrhea 1000 to 1500, patient passing the 5 to 7 times. Then stage 3, diarrhea is the more than 1500, then patient episode of the more than the 7 episode present. Then stage 4, this is the very dangerous, patient having the abdomen pain, crampy pain, and patient passing the motion around 2000 around. Then one by one we will see the nursing management of the GVHD. First we will see the skin GVHD. In skin GVHD, assess the skin every shift duty, and if any changes is there, you have to inform, otherwise you have to record in the nurses station. Keep skin clean and moisture. We have to clean every shift duty, clean, keep and moisture. Corticosteroid, we are giving the steroid to the patient. Then topical systematic, in our setup we are using Betnovate and ointment for the ointment we are using. Use the moisture and lotion. For the moisture lotion we are using petroleum jelly and Vaseline jelly we are using for the moisture lotion. We are using the Johnson & Johnson for the bathing to the patients. Then GVHD, protect skin from the sunlight. Do not go the middle of the day to protect the sun from the sunlight. Use sunscreen when we are going out. You can use the sunscreen to protect from the sun. Then wear the long sleeves and pant when we are going out. Daily bath, we are giving the daily bath with the Johnson & Johnson soap. Use the cortisoptic cream for the face and Betnovate for the whole body of the patients. Then mouth GVHD, rinse mouth with the chlorhexidine. The mouthwash we are giving the every 4th hourly. Then do mouthwash every 6 hourly. Avoid the spicy food and take the small frequent liquid to the patient. Eye GVHD, use the artificial tear, because in eye GVHD, eye is very dry, so you have to use the artificial tear to keep the moist of the eyes. Then use the steroid drop for the eyes. Do not scratch the eyes. Then liver GVHD, check the vital parameter every hourly. If patient is sick, you have to check the vital parameter every hourly. Otherwise, patient is stable, you can take the vital parameter every 2 hourly. Check the blood investigation. In the liver GVHD, LFT is rising, so daily LFT is required for this patient. Daily weight, because we are the monitoring the intake output and patient is not eating properly, so you have to check the daily weight every 12 hourly. Check the abdomen girth, because the patient is a hepatomegaly, that abdomen distension is there, so you have to check the abdomen girth every 6 hourly. Start the antibiotics. If the patient is the count is 0 and patient is getting the infection, use the gradual, you start the antibiotics according to the sensitivity of the cultures. Monitor intake output strictly. And pain management, because the patient having the abdomen pain, we have to manage the pain management. In our setup, we are giving the paracetamol 6 hourly, tramadol 50 mg TDS. If paracetamol and tramadol the pain is not reduced, then we will starting the morphine drip 1 mg per hour. Then gut GVHD. Gut GVHD, check the vital parameter, keep patient is NBM. Because you give the rest to the gut, you keep patient on NBM, start the parenteral nutrient, you start the TPN to the patient. Then watch for the color, quantity and consistency. You have to check the color, quantity, how much motion is there in the 24 hours, you have to check that. And consistency, you have to check the patient is a passing semi-solid motion, loose motion and solid motion. You have to see the consistency of the motion. Give the lactose-free diet, soya milk, arrowroot kanji, apples, 2 boiled potato. Then neutropenic diet, low microbial diet you have to give to the patients. Preparation in the gut GVHD, we are doing the colonoscopy. For the colonoscopy, we are preparing the previous day, we are preparing the patient. We are giving the peg leg to the patient to clear the colon. Rash-free ointment, because we are applying the rash-free oil because the patient is passing the 10-15 times the motion, the perineal area is very vast. That time we are using the rash-free ointment. Check the daily weight, because the patient is passing motion, so the weight is decreased, we have to check the daily weight. Monitor intake outputs are strictly, because the patient passing the motion, so you have to monitor intake output 12 hourly. Then sugar monitor, because we are giving the total parenteral nutrition to the patient, that sometimes sugar level is high and low. That time you have to monitor sugar level. We are putting in the insulin in the total parenteral nutrition also. If patient sugar is high, according to sliding scale, you have to give the regular insulin to the patients. Then daily blood investigation, because the patient is passing the more motion, the electrolyte is imbalanced. So daily you have to send the daily electrolyte to electrolyte. Then give the methylprednisolone 0.5 mg to 2 mg per kg gradually, tapering of the wear. But this prednisolone we are not giving the according to weight, because we are very conscious for the steroid. In our setup, we are giving the 20 mg BD and gradually tapering every 5 to 7 days, and then we will stop the steroid. Dietitian reference to meet the calories requirement. Then lung GVHD, monitor vital signs, because the patients, sometimes patient having the breathlessness, then we have to check the vital parameter every hourly. Watch for the breathing pattern, because the pleural effusion there, then pneumonia is there, and sometimes patient having the breathlessness. So you have to watch breathing, you have to see the breathing pattern. Then if necessary, suppose patient is having breathlessness, you start the oxygen according to oxygen if necessary is there. Keep patient on the semi-flawless positions. Then in the BMT setup, we have the good dietitian. They are the plan, the GVHD diet. There is the phase 1, phase 2, phase 3, phase 4 and phase 5 diet. In the phase 1, we are giving the only total parenteral nutrition, and we are giving the 100 ml liquid to the patient every 3 hourly. That means we are giving the rice, kanji, all we are giving the clear soup in the phase 1. Phase 2, we are giving the liquid diet, soya milk, arrowroot kanji, then rice kanji we are giving. Then patient is tolerating, then gradually we are increasing the liquid. Phase 3, we are giving the maida roti to the patient, liquid khichdi, soft khichdi, potato veg, pumpkin, padwal we are giving to the patient. This is the first 3. Same diet we are giving in the phase 3. In the phase 4, we are adding the white egg 2 daily to the patient, and soft khichdi we are giving the potato veg, padwal, dudi we are giving in the phase 4. Then continuous same we are giving the full diet to patient in the phase 5. And phase 6 also we are giving the full diet with the patients if patient is recovered. Then in nutshell is the acute GVHD occur until the 100 days, classic acute GVHD, and beyond day 100 as the dilated acute GVHD. As the treatment option, the limited beyond the use of the corticosteroid carefully, select the GVHD prevention essential. Then institution standard and treatment and nursing are essential. Thank you.
Thank you very much, ma'am, for sharing such valuable knowledge. Now we can really say that we are aware about tutelage for bone marrow transplantation. The next distinguished to honor us with her presence is Ms. Rajshri Rajesh Yadav, Senior Clinical Nursing Officer, Tata Memorial Hospital, Mumbai. She has experience of 28 years. She is working as clinical nurse at Tata Memorial Hospital. She has done post-basic diploma in Oncology Nursing at Tata Memorial Hospital. She is joint secretary of ONAI at Tata Memorial Hospital.
So, good afternoon, or is it evening? It's past 3, na? So, good evening, all of you. Can you hear me? So, post lunch session, right? So, are you all sleepy? I think so. Okay. First of all, before starting my topic, I would like to thank our administration, Tata Memorial Hospital, and our nursing administration to give me the permission and to allow me share this dice. So thank you, Tata Memorial Hospital. Yes, starting on to the topic, that is nurses' responsibility. Do you all think nurses' responsibility is all the time difficult? Do we find it difficult all the time? No? I do find it difficult. Okay. So my today's objective, group will be able to define chemotherapy, know routes of exposure to cytotoxic drugs, understand the health hazards while handling cytotoxic drug, explain nurses' responsibility while handling chemotherapy. So first, introducing to the term that is chemotherapy. The term chemotherapy was first coined to describe the use of chemicals or drugs for routinely. Do you all know we give drugs during tuberculosis, right? So that was also called as chemotherapy. It's a chemical combination of drug which we are giving it to the patient at a specified protocol and a dose. Okay. So to treat, this was first coined to describe as a just administration of drugs to treat microbial diseases. And later it was now chemotherapy. Once this word comes to our mind, what comes in our mind is the cytotoxic, right? Does it comes? I want to hear y'all. Yes. Okay. So we should know who's the father of this chemotherapy. That is Paul Illich. He's the father of chemotherapy. Now, moving on to definition, chemotherapy is a systemic cancer treatment Do you all agree with me? It's a systemic therapy and not a local therapy. Why do we call it as systemic? Because, yes. Any answer? Because I find no one questioning only. So I should ask questions. Huh? Why do we call it as systemic therapy? Right? It is going to be circulated throughout your circulatory system. Is it right? Yes. So, a treatment that uses one or more cytotoxic drugs as a part of standardized chemotherapy regimen. Cytotoxic drugs act on rapidly dividing cells. Now, do these drugs know which is a normal and which is the cancerous cell? No. So what will happen? It is going to affect the normal cells, because of which we see certain kinds of side effects or toxicities within the patient. Now, do you tell me, if without knowing the safe handling of chemotherapy, if we handle chemotherapy, are these drugs going to harm us? Surely it is going to harm us, which we are unaware, right? So that's what I say, nursing is very difficult. Okay? So what are the routes of exposure to cytotoxic drug? How do we get exposed? Can we have a direct skin contact? Yes. Then we can inhale. Now, why we can inhale? Because we are contaminating the environment where we prepare these cytotoxic drugs. Okay? So that's why we are going to inhale these cytotoxic drugs. And continuously working in certain area, we are going to expose not only ourselves, but the caregiver who is present with the patient, along with that, all the work persons who are present in the premises. Then inadvertent ingestion of drug on food, because many a times what happen in the preparatory area, what we keep our food, and unknowingly we keep our food, or sometimes we have a party. I do have a party. So what we do is we keep all the whatever we brought, we keep in that area, and unknowingly we are going to ingest all these cytotoxic drugs. Okay, so nothing keeping. Okay, when you're preparing your antibiotics also. So moving on, cytotoxic drugs, what are the hazards? Yes, it's carcinogenic. It can cause cancer. And not for us, even for the patients, it can give them a secondary cancer when we give certain drugs like alkylating agents. It is genotoxic. Yes, it is going to cause mutatic changes in the DNA. Then it has a teratogenetic effect, that is, it can give certain malformation in the fetus. Okay, fetus go. Then moving on to the main topic, that is nursing responsibility. So I have divided nursing responsibility into knowledge and practices. Unless and until we believe in knowledge, and knowledge is not a short term, we need to understand what are the things we need to know during handling chemotherapy. That is cell, yes, basic unit of our body, and the cell cycle, principles of chemotherapy, drug classification, chemotherapy protocols, management of cytotoxic drug, counseling, emergency and side effects of chemotherapy, extravasation, recording, reporting, auditing, and research. And unless and until we have knowledge related to certain things, our responsibility towards certain practices will not improve. The skills which we need to develop, so in that we will cover, that is how we need to preparation of cytotoxic drug, then administration, disposal of cytotoxic waste, and spill management. So moving on to the knowledge part, what we need to know. What are our responsibilities? Yes, understand cell as well as cell cycle. So cell cycle is further divided into interphase, that is the active phase. previously it was believed that this was a phase where the cells are in resting phase. Isn't it? I want your yes. Yes. Okay. So here in S phase, so what I say is in interphase phase, this is the time period when the cell is too much active. That is G1 phase, where it collects all energy in the form of ATPs, the nutrients required in the form of proteins and rDNA. Okay. Then comes the next phase, that is the S phase, where the actual DNA synthesis takes place. Yes, very good. Now I should hear some voice. Okay. Then moving on to G2 phase, where now the cell prepares itself for the cell division into two daughter cells, which is again further further divided as prophase, metaphase, anaphase, telophase under M phase. Okay. And then the actual cell division takes place in cytokinesis. Are you all with me? Yes? It's not like a good topic, na? Cell cycle and all. Ah. So here actually what happens is now why do we need to know this? Because at certain phase there are certain hours a cell cycle to one single mother cell to replicate into two daughter cell. There are certain time period which is needed. That is what we want to know when we handle chemotherapy and we are giving certain protocols or regimen to the patient. Yes, the goal of chemotherapy is cure of the patient, control. Many a times it happens that nothing can be done, but we need to keep certain things into control, and palliation, when we need to give chemotherapy to reduce certain sign and symptoms or give symptomatic treatment to the patient. What are the principles of chemotherapy? Dose intensity. Dose intensity is a drug which we need to give unit per time. So for that, you see all the times on the drugs it's written meter per square. Have you all seen drug calculation? We write na meter per square. So that is what dose intensity means. Then high dose of chemotherapy. In certain cases, yes, before this we had a session on bone marrow transplant, which they give chemotherapy, high dose chemotherapy is given so that the patient comes into a phase of nadir, which is called zero phase. So to attend such type of phases, we need to give high dose of chemotherapy, or for example, in patients of AML, we give high dose of cytarabine, and in certain cases of ALL, acute leukoblastic leukemia, what we give is injection methotrexate in high doses. Then comes to chemosensitivity. Yes, cells are certain cells are very active or they are rapidly dividing. So what happens is at that certain phase, the chemotherapy drug will act on those types of cells. So which are the rapidly dividing cells in our body? Yes? Yes? We see GI ka zyada we see na toxicities. Yes, GI related mucositis. Then I have added to it. Yes, name. No? I'll have to speak only. I don't want you all to sleep. Okay? So certain toxicities do happen because those cells are rapidly dividing. Example is your hematological cells, that is all your blood cells. Then the mucosal lining of the oral cavity, as well as from the mouth up to the anus, your nails, hairs. That's why we see all these toxicities, right? So there are certain drugs which we need to use in certain cases. That's why we need to see chemosensitivity. Then comes your neoadjuvant chemotherapy. What do you mean by neoadjuvant? It's a new. Just first we are going to introduce chemotherapy to the patient. And the aim for this, it will be for certain cases of solid tumors. What happens is the tumor is too big or too large to be operated. So in that case, what we will do is we'll give chemotherapy and we'll shrink the tumor so that the tumor becomes operable. Okay. So what we give, neoadjuvant is your first chemotherapy and then followed by surgery or followed by radiation. Then comes the adjuvant chemotherapy. Yes, after surgery, there are certain microcells which are left in the circulatory system. The main aim of this adjuvant therapy is to take care of all those micro cells which are left in the body. So we give, followed by surgery, we can give chemotherapy, or followed by radiation, we give chemotherapy. Then is the single agent chemotherapy, where only one single drug is used as a part of the treatment. Example is bendamustine, which is used for certain cases of NHL, a single drug. Only when it will come to combination therapy, where more than 2 drugs we use in that, more than 2 drugs we use as a part of chemotherapy. So we have most of the chemotherapies in those, what we use is more than 2 drugs. Then combination coming to salvage chemotherapy. So salvage, certain time what happens is we need to preserve certain body parts, or the patient doesn't land up into relapse. For example, many a times it happens till the donor we get for the BMT transplant, or till the phase of investigation, we need to control that patient, whoever we have posted for bone marrow transplant. So during that phase also we give chemotherapy to salvage, right? So that further we can do. And in many of the cases of osteogenic carcinoma, to preserve, we give organ, we give salvage chemotherapy. Then comes our palliative chemotherapy, which is palliative chemotherapy just to manage the symptoms, and it can be concurrent, so both simultaneously chemotherapy as well as the radiation therapy works. So in certain cases of GI, we give weekly chemotherapy, simultaneously the patient goes for radiation therapy. Now, knowledge of drug classification, isn't it important? Because there are certain drugs, we need to know what are those toxicities related to it. So cytotoxic drugs are further classified as alkylating agent, anti-metabolites, anti-tumor antibiotics, phytotoxins, then taxanes, vinca alkaloids, miscellaneous. The main aim or main action of all these drugs is to manage or break the DNA cell, thus causing death of the cell. Then we need to understand what do we mean by protocol and regimen. Have you all heard these words, protocol and regimen? Yes. So we need to know what's the difference between the protocol and regimen. A protocol describes a complete schedule of tests, procedures, chemotherapy and supportive medications, including the doses used in a research study or clinical trials. Right? During the clinical trial phase, whatever this chemo regimen is used, that we call it as protocol. Now we need to understand what do you mean by regimen. A regimen is a specific plan, detailed chemotherapy and doses to be used. So regimen are often identified by acronyms and of the drugs used. For example, I can give you in certain cases of breast cancer, we give the regimen that is CEF, which means cyclophosphamide, epirubicin and fluorouracil. Or in certain cases of breast cancer, nowadays what we give is AC, adriamycin and cyclophosphamide. Coming on or moving to management of cytotoxic drug, which is also a responsibility, because here this is a time when errors can happen and we can whatever work we are doing or whatever chemotherapy we are handling be toxic to the patient. So during ordering, whether the physician has written the order clearly, the dose, the drug, the duration period of time, the dose calculation, so everything needs to be written properly. There we can have a problem. Transcripting, where you and me are going to transcript what is written, what type of protocol the patient is receiving, the dose, duration, everything we need to specify. If there is any doubts, we need to clear out with the treating physician. Then dispensing, where we collect the drugs from the pharmacy, there we can go wrong. Sometimes it happens. Certain drugs do look alike, sound alike, so there can be a problem. And then comes the administration. Proper knowledge of drug will help in proper administration of the cytotoxic drug. Have you all seen these drugs? This is an example of sound alike, where ifosfamide and cyclophosphamide, you all can see they sound little phosphomide. Okay, single use of just phosphomide. It can be worse for the patient. Or a look-alike, we have injection ondansetron, right? Ondansetron and or granicet, which is there, which comes in vial form, that can be mistaken as etoposide. So there we can go wrong. Instead of giving etoposide over an hour, we will transfuse. What will happen? We will mistake it as antiemetic and we'll give it as within 15 minutes, and there the problem can arise in the patient. Then certain things while handling chemotherapy, what you need to know is the material which has been used. So the normal plastic bottles which are there, which we find for IV fluids, should not be used. So either we could opt for a glass bottle, or certain Ecoflex bottles are there. The set which we are using, it should not be a normal set, it's a cordon set or different material, so that there is no reaction of any cytotoxic drug. Along with that, what we need to know is never mix two drugs together, right? So each drug is to be given individually. Management of cytotoxic drug, further continuing the storage, how you need to store. So many a times we have, in certain places there are rushes. So what happens, patients, caregiver, they carry the cytotoxic drug in their hand, and the temperature which we need to manage between 2 to 8 degrees centigrade, it's not managed. So what happens? Ultimately, the potency of the drug reduces. Then comes the counseling part, which is also the responsibility of nurse. So chemotherapy, we need to make them understand what do you mean by chemotherapy, how long the chemotherapy will last, how long the protocol the patient needs to take. For example, in ALL case, the treatment lasts for 2.5 years. Just imagine, if he is unknowing, he will leave the treatment in between and he won't follow up with us. Then the procedure, what type of chemo, how we are going to administer, what care he needs to take, all the procedure you need to explain to the patient. The length, the cost also, many a times cost becomes a barrier for the patients, because of which he leaves the treatment. The diet and hygiene, which is very important, because all the cancer patients are immunosuppressed. Now, when they take chemotherapy, you know that chemotherapy drugs are going to cause certain toxicities, that is bone marrow suppression. So which we need to handle with care, and patient, since it causes neutropenia, we need to maintain the hygiene of the patient. Side effects, certain toxicities, immediate, it can be late, also need to explain to the patient and what type of care he needs to take. So a proper care during chemotherapy is going to help to the patient. So counseling related, not only a part, it should not be a part of practice only, but take the aspects of, that is psychological aspects also you need to take in mind when you're counseling to the patient. Then comes the warning signs. So you should tell him what are the warning signs when he should come immediately to the casualty or immediately to the hospital. Example is fever. In adult patient, fever of 100 or more than 100. In pediatric patient, fever of 99.5 and more. These are certain warning signs. If the patient doesn't pass urine, no motion for 2 days, there are certain indication or warning signs which we need to explain to the patient. Then continuous follow-up with the patient. So counseling doesn't end in a single visit. it is a continuous process. When the patient comes to the hospital, as soon as he is diagnosed, now it doesn't mean that counseling will start or palliative care will start at the end, that is when the right time will come. No, when the person enters in the hospital and he is diagnosed, your palliative care, everything should, your counseling should start. Then emergency, certain emergencies and side effects we need to manage. Certain drugs like arsenic trioxide, it can cause QT, delay of QT waves. So what happens? Patient has palpitation, and because of which we can even lose our patient if we neglect certain things. So we should know what certain emergencies we can face. So to avoid that phases, we need to give certain, we should be alert what type of drug we are giving to the patient. Tumor lysis syndrome, yes, within 24 hours your patient will come with tumor lysis syndrome if there is a huge burden. And certain allergic skin reactions after giving, if the patient is allergic to certain drugs. We have already seen what are the early and late side effects are there, which we have discussed. Then coming part 2, extravasation, where we need to be very much careful. So what do you mean by extravasation? The expel of a vesicant drug into the tissue, okay, other than your vein. So what it is going to cause? It is going to cause extravasation, which you can see in one of the pictures here. So you should be able to verify which is your vesicant drug, which is an irritant drug, and which is a non-irritant drug, because this is going to help you in the management of certain cytotoxic extravasation. So I'll just give a short this thing. If any time there's an extravasation, what we need to do is mark the area, aspirate as much as drug. We can never put a pressure or anything while aspirating. Gently let the aspirate come out. Check for any antidote is there. So for certain drugs like vinca alkaloids, we know there is a disperser or neutralizer is there. So for neutralizer, for VCR, vincristine like drug, we have is injection hyaluronase. So that injection we can get it, and then we can remove, after giving this dose of hyaluronase, we can remove the needle or the cannula which is there. Or else, if nothing is there, no this thing neutralizer is there, antidote is there, what we need to do is certain other management we need to see forward. Now, these patients need to be follow up for 42 days after extravasation, which we usually miss. So first 7 days, we are going to call the patient every alternate day, followed by weekly till 42 days. Then recording and reporting is very much important as concerned to nursing. Recording of what type of chemo, the dose, which cycle, how duration, which vein you have given to, or which route you have given, specify it. The incident report, many a times what happened, we very much hesitate to write the incident report. Yes, it is going to help for future certain studies. Auditing of, yes, this is also a nursing responsibility. Auditing of what is the knowledge and practices within the nurses, then the knowledge and skills to improve. What we need to do, certain refreshment courses. It can be within an department also. Certain proper documentation are going to help for certain retrospective studies. In one of the studies, this was done in Switzerland, that a safe handling of chemotherapy drug in low middle income countries and overall practice. So what did they find in this study was that there was a major gap in our lower income group countries, that is related to handling of drugs. Then not only that, but environmental contamination, then staff safety, which was also a neglecting factor in the aspect which they found. This was an online studies which they had done during the year 2018 and 19. So coming back to practices which we need to know, that is how we need to prepare the drug. proper hand washing, wear PPE, then reconstitution of drug where we all the time fail. So prepare the cytotoxic drug away from the body and below the chest level. The diluent should be slowly introduced down the walls of the vial all the time. So be careful. And while you remove the needle from the vial, wrap these sterile gauze around the neck of the vial. So what will happen? This will prevent expel of exposure or expel of air into the environment with cytotoxic droplets. Then even while diluting also, we should swirl the solution slowly in a circular manner. Then all must be knowing the routes of administration: the oral, subcutaneous, intramuscular, intravenous, intraperitoneal, then intrapleural, intravesical, that is bladder, then topical solutions. Now coming to the part of IV administration, we need to see which route we need to give. And if we know which route we need to give. If it's an intravenous, we need to have a good patent IV line. Never take the digital veins, peripheral veins for cytotoxic drug administration. We need to know whether we can pose the patient or whether we can opt the patient for certain central venous access devices, that is Hickman catheter, chemoport and PICC. Now, when we handle such type of central lines, we need to know how to manage these central venous access device. Then IV administration, always administer cytotoxic drugs through a fresh cannula and flush 5 to 10 ml of normal saline. Safe monitoring administration, then check backflow, swelling, pain, etc. Flush the device and remove the cannula and apply pressure pressing. Disposal of waste. Yes, the universal color which is there for cytotoxic drug is purple color. So proper labeling. Now we know who are at risk. Previously also we had talked that who are the people at risk of cytotoxic drugs. So from starting onwards, if we mismatch or if we are unaware how to dispose all these cytotoxic drugs, ultimately we are going to harm not only ourselves but the entire people who are there in the hospital. Along with that, improper disposal of cytotoxic drug is going to cause a hazard or really a great emergency in the population or in the society also, where we are going to dispose this waste if it's not properly disposed. Spill management also you should be aware of. Immediately isolation of that area wherever spill is there. You should have a spill kit which is next to the preparation area. So anytime any type of spill, you should be able to manage it. Proper labeling of cytotoxic drug is very important. Then to conclude with, nursing responsibility is a broad term. Proper education, in-service education, incidental teaching, refreshment course and workshop are really of great help. Any questions? Okay. Yes, I'm waiting for questions.
Thank you very much, ma'am, for sharing your profound knowledge with us. Now, since Rajiv sir had busy schedule, so now it would be a delightful moment for us to speculate our respected principal, ma'am, Parvez Saini, STRD College of Nursing, Shri Amritsar, and Dr. Raman Kalia, Principal, Saraswati Institute of Nursing, Roopnagar, doing honors of Miss Komal Kailash Munde and Miss Rajshri Rajesh Yadav. Please do the honors, ma'am.
So, ladies and gentlemen, paper presentation will be starting at Biochemistry Hall. So, our next session, symposium. Once you have stood up to cancer, everything else feels like a pretty easy fight. But knowing it exists is not enough. So, our next session is symposium on breast and gynecological cancers. So, chairperson for this session is Dr. Raman Kalia, Principal, Saraswati Institute of Nursing, Roopnagar.
Dr. Raman Kalia, she is principal at Saraswati Institute of Nursing, Roopnagar. She has done her MSc Nursing in Medical Surgical Nursing from Punjab University, PGIMER, and done her PhD in Pediatric Surgery from PGIMER, Chandigarh. She worked as clinical nurse and administrative and teaching experience. She is a gold medalist in MSc Nursing and is awarded with Best Thesis Award. She has received WHO Fellowship in Thailand in Children Daycare. She is founder president of Nursing Research from 9 PGI. She is research guide to MSc Nursing and guide to PhD nursing students in INC Consortium and Baba Farid University Health and Sciences, Faridkot. She has published paper in various nursing journals. She is author of various books and journals.
Our next chairperson is Dr. Parvez Saini, Principal, SGRD College of Nursing, Amritsar.
Dr. Parvez Saini, Professor cum Principal, SGRD College of Nursing, Shri Amritsar. She has working experience of 29 years. She had worked as Professor cum Principal, SPSP Memorial College of Nursing, Moodal. She has completed her MSc Nursing in Maternal and Child Health Nursing from CMC College of Nursing. She has completed her PhD Nursing Science from Himalayan University. She acted as a chairperson, resource person, and delivered guest lectures in more than 30 scientific sessions. She organized and participated in various workshops, conferences, and seminars. She has published more than 20 papers in various national and international journals of nursing. She has received Lifetime Achievement Award Certificate of Nursing Scholars Society. She is the author of 4 books and life membership of TNAI, SOMI, IAMCH, and NRSI. She has received appreciation certificate and cash prize on enrollment of nursing students, TNI, and in New Delhi.
So, our resource persons for this session is Ms. Shivani Kandola, NS, Indo-American Cancer Hospital, Hyderabad. Ms. Ranganaiki L., Professor, SGRD College of Nursing. Mrs. Reena Nayyar, Treasurer, ONAI, ANS, TMH, Mumbai. Ms. Shilpa Bhosle, TMH, Mumbai. I request all the resource persons and chairpersons to be seated on the stage, please. So I would like to call Mrs. Shivani Kandola to start this session.
She worked as NS at Apollo Hospital, Nellore, Andhra Pradesh, at ETCM Hospital and College of Nursing. She has received 19 certificates at national and international level. She was awarded as Best Nursing Scholar Society NSS as COVID-19 services with dedication certificate by the government Telangana. She also achieved Nursing Excellent Award for the year 2018 and 2019. She conducted various conferences and workshops at national level. She conducted 6 research studies and 1 dissertation.
Good afternoon, one and all. I have only less time, only 10 to 20 minutes only. I will go very fast. Okay? I won't be take much time. This is my topic, how to diagnose breast cancer, how to treat triple negative breast cancer. My name is Shrivani. I am nursing superintendent in Basavatarakam Indo-American Cancer Hospital in Hyderabad. Now at present I am doing their nursing superintendent. The first topic is breast cancer means. What is cancer? Cancer is, everybody knows, this is the abnormal growth, invade or spread. Is the cancer development, normal cell, cancer cell, doubling and malignant. Here we are two types of mucogenes. Another one is mutagenes. Another one is oncogenes. The mutagenes is a proliferation the cell, and then oncogenes is having a tumor and suppressant of the malignant cell cancer. Now, what is breast cancer? Breast cancer is starts is a breast cancer. It happen cell in the breast. It changes, grow out of the control. It normally we are forming a tumor. If the cancer does not spread any other parts, is the inside, and then the other parts it is spreading is the invasive. It is a metastasis means it is involving the lymph node and or blood. Now prevalence of breast cancers, we are seeing 1.3 million new breast cancer cases each year, and every 4 minutes an Indian woman is diagnosed with breast cancer. One woman dies of breast cancer every 13 minutes in India, and 4,58,000 deaths from breast cancer every year. Now we will see risk factor. Risk factors is that prior we have breast cancer history, age and sex. Normally we are seeing the age group is a 50 years or 45 to 50, and then above age group, and hereditary mutations and reproductive process, and obesity, and use of oral contraceptives, environmental factors. Another one is use of hormonal replacement therapy. Another one is a family history, and then lifestyle factors. This factor here we will see the modified and unmodified, and then factors in this triple negative breast cancer. We are seeing 70% of the breast cancer diagnosed with a woman with an inherent BRCA1 mutation or triple negative breast cancer. The pathophysiology of breast cancer, normally we are seeing here permanent damage of DNA. Here it process to the mutation of the genes. That mutation of gene is that side is the activation of the growth inducer oncogenes. Here alteration is the apoptotic genes, means here the reduction in the cell proliferation, and then it leads to the growth of the colony. Growth of the colony means the microorganism will be one set of the organism, they are the growing the tumor. It leads to the progress of the tumor. It leads to the breast cancer. Now we have to see the classification of breast cancer. Now triple negative breast cancer, we are seeing that luminal and basal genes it is involving here, and based on the original ductal, lobular and connective tissue, we are seeing the ductal it is the cancer affecting inner lining of milk ducts, and the lobular is cancer affecting lobules, and connective tissue is the most probably we are seeing under the skin, it is the Paget's disease, and then based on hormones genes is the luminal, and basal means triple negative, that is estrogen, progesterone, HER2, negative is the basal like cancer, and luminal means HER2, estrogen and progesterone HER2 is the negative and positive we are seeing. See here some types of breast cancer. Ductal breast cancer is 80%. We are seeing the invasive, non-invasive procedures. Invasive means it is an 80% lumpectomy we are doing. And then lobular breast cancers, we are seeing for the lobular like all milk canal like medullary and tubulars, whatever it is there, that surgeries we are going, the total mastectomies and all we are doing. A miscellaneous breast cancer, we are seeing that after 70 years women's their hormonal therapy and all, they are taking this type of breast cancer. We are seeing inflammatory breast cancer, we are seeing the triple negative breast cancers and all. We are seeing the most probably inflammatory breast cancers. And mixed tumor breast cancers means here both together it will be mixed together. Now what are the types and all I discussed already. And breast cancer symptoms, now we have to see the symptoms. Breast cancer, see how that nipple discharge not breast milk, and nipple that turns the inward, pain or tender spot, and then the dimpled skin will be seeing, and swollen area, redness will be there one side, and thickened or discolored skin, and swelling or lump nearer the armpit means the swelling and the lump will be enlarged in axilla or collarbone, and change in breast shape or size, and lump in the usually hard. It is the lump, and the tumor will be irregular in shape. How breast cancer is diagnosed? Presently, the focus is diagnose breast cancer via screening method, bilateral mammography, and even before person has symptoms, a person might notice a lump in breast or a mass or nodule under the arm. We have to see first that, and signs and symptoms we are clinically examine the breast examination. And then second one is we are factors relevant the initial clinical assessment, your age and general health, and then the results of earlier and medical test, having any diabetic or hypertension, other than that other disease conditions, calcification on a screening mammogram, or a lump or nodules in the breast during a clinical or self-examination previously. Then diagnostic assessment, now normally we are seeing the physical examination, mammography, ultrasound, breast MRI and biopsies. Breast self-examination, we are seeing here mainly the opportunity for the woman to become familiar with her breast. Monthly exam for the breast and underarm area may discover any changes early and begin at age 20, continue monthly. Menstruating women 5 to 7 days after the beginning of their period. Menopausal women same date each month, and pregnant women same date each month. Take about 20 minutes to examine the breast and perform the breast self-examination at least once a month. Examine all breast tissues. Cancer diagnosis, already we are seeing mammogram, ultrasound and MRI. See, women should have the choice to get an annual mammogram beginning at age 40. Women age 45 to 54 should get the mammogram every year, and women 55 and older should switch to mammogram every 2 years. This type of mammogram is the first one is that digital mammogram, 3-dimensional mammography, or tomosynthesis mammography, contrast mammography. Here the digital mammography, we are seeing the younger women into age of 30-35, we are seeing that. And the 3-dimensional, why it is important? Here we are seeing the calcification are mostly easily recognizing in that deposits of calcium cysts. We can able to recognize any suspicious mass is there, means we have to identify. And the contrast mammography is the ductogram and galactogram. Here we have to less than 1 ml of a radio opaque material we are giving the inserting the IV. Then we will identify where it is the bloody nipple and discharge of the dilated ducts is any abnormality is there. In that contrast mammography we will diagnose. And then see now some pictures, and then on never technology has improved that this is the digital mammography. This is the 3D mammography. This is the lump and area of abnormality calcification. You can able to see the calcification, and in doubtful cases an ultrasonography will clear the picture. And then mammography plus ultrasound can identify cancer in more than 95% patients. Sorry. And this is a disadvantage of the mammography. Radiation exposure is the mainly. Next, CT scan and MRI, why we are using, we can use here internal body structures, and then we are faster the provide the picture the tissues and organs, skeletal structure, and then it is easy to treat the doctors. And then PET CT scan, normally we are seeing this PET CT metastasis where it is the spreading that areas and all, we are easily to identify and pinpoint tissue also we can see in that area. Now coming to the biopsies. Biopsy test is to examine the tissue for disease, help the identify other conditions such as infection and inflammatory and autoimmune disorders. Just because your doctor recommends a biopsy does not mean that you have a cancer. See now, biopsy means what? Biopsy is a procedure that remove a small piece of tissue. The tissue sample taken from the breast is then tested by a pathologist to confirm the presence or absence of a cancer. What are the types of biopsy? Fine needle aspiration biopsy, core needle biopsy, stereostatic core biopsy, ultrasound guided core biopsy, vacuum assisted biopsy. Then surgically we are seeing excisional biopsy, incisional biopsy, wire needle localized biopsy may be guided by a mammogram, ultrasound or MRI. See some pictures in the fine needle aspiration. We will take the gauge 24 and 25 gauge needle, and then you have to that lump side, that collection of the fluid we have to aspirate and send to the pathology lab. And core needle biopsy, we have to take the gauge is the 14, and then in this larger sample with that it is a hollow needle, you can pick up the some needle and all, and then tissue you have to send to the pathology lab. Then coming to the stereostatic breast biopsy, this is normally the patient see lie prone position on the table. The breast is suspended through an opening in the table. Have you seen this pictures? And compressed between two X-ray plates using digital mammography. And then the sample are located with computer to pinpointed the exact location of the breast. And then local anesthesia is injected into the entire site on the breast. A core needle is inserted and the sample of the tissue collected, the sample sent to the pathology, and after procedure post biopsy image taken to the mammogram. Ultrasound guided core biopsy. This is also similar to the stereostatic core biopsy. It is ultrasound guided. Computer coordination, does not use the radiation. It is faster and less expenditure. And MRI guided core biopsy, it is a radiological technologist, and breast is too small to be felt, but it is visible on MRI. Vacuum assisted biopsy, here what is the main importance? See, you are seeing the 4 pictures in that, the position, vacuum and cut and remove. Only one time only we are inserting the needle, and we will take the multiple samples we are taking. See here already wire needle localization. See, localization means what? Not palpable mass or suspicious calcium deposits detected on mammography, all ultrasound, MRI. It requires the excision biopsy. The radiologist is insert a long thin wire through a needle which is inserted into the area using a X-ray or ultrasound. Why it is that the wire is remain in place after needle is withdrawn, taken to the OT operation theatre. The surgeon is follow the wire to the tip, excision the tumor. See, what is the excision and incision? Excision means a complete pathological assessment. It is a palpable breast mass, entire mass margin of surrounding tissue removed. This type of biopsy, lumpectomy, it is a frozen section analysis of the specimen may be performed at the time of biopsy. And then incisional biopsy means surgically removed a portion of a mass to confirm diagnosis. Special studies like ER, PR and means estrogen and estrogen receptor and then progesterone and HER2. This is the normally hormonal studies. They are doing the complete excision of the area breast. Diagnostic of the triple negative breast cancer, normally we have to see this. What are the triple negative breast cancer? Lymph node analysis, estrogen and progesterone receptor status, cell proliferation indices, HER2 marker and genetic assays. See, now you can see here axillary and lymph node analysis. Now you can see here that sentinel lymph node biopsy, a radio-opaque isotope or blue dye injected affected breast. If that sentinel lymph node is a negative, no further surgery. You will say this positive is there, axillary lymph node. Dissection will be 12 to 20 lymph nodes we are removing. Tumor size, now tumor size already here aggressive will be there, more morphologically disorganized and they are more aggressive. Now we have to see the estrogen receptor and progesterone receptor differences we are seeing here, mainly poorly differentiate the histologically, high incident and nucleoid abnormal, high or low, DNA content will be there, mostly the negative tumor having a more aggressiveness we are seeing. Now cell proliferation, already Rajeshwari is discussed regarding the cell, how the synthesis will be there. Now in this synthesis, yes, synthesis is the percentage of tumor cell in the synthesis, yes. The cell proliferation indices are not routinely performed as a part of the breast cancer pathology evaluation in this. Now, genomic assay is that normally the genomic assay is to determine the HER2, which is a prognostic indicator over the expression of this receptor associated with the aggressive the tumor growth, a great risk of the recurrence, poorer the prognosis in the breast cancer. 10 to 20% of the patient with the breast cancer mostly express this analysis, and then in this what we have to see means the gene are present or absent, overly active or not active, then only we have to see the chemotherapy or hormone therapy we are going to give it. Then next two tests is there. One is one of those tests are called immunohistochemical staining assay test. This test is clearly confirm the HER2 is a positive or negative. Another test is called fish Florence insight hydration. This test is normally cancer cell test is a negative for all three receptors. The cancer is called triple negative. Breast cancer, we have to see this fish analysis blood test. In this only we will identify the woman is getting a triple negative breast cancer or not. See, this is the method tissue they are taking and processing. They are dissection the tissue and then they are keeping that, and then they are staining. They are keeping in the microscope. Then they will see the how that progesterone and estrogen and then otherwise HER2 staining will be there. Now stages of the breast cancer. Now T for tumor size, N for lymph node involvement, M for metastasis. Now stage 1 is we are seeing tumor size less than 2, It is a no metastasis, no nodal involvement. Stage 2 is the tumor is more than 2 to 5, and then stage 3 is here what happened, axillary lymph node will be involvement is there. Stage 3 here more tumor size is more than 5 centimeters, and then here normally we are seeing that internal memory nodes, and then inflammatory carcinoma will be takes place. Stage 4 here the tumor size will be increasing, and lymph nodes also increasing that inflammation, and it leads to the metastasis. Other parts it will be growing. Pathophysiology of breast cancer. Now we will see for this. Survival rate, 0 stage 100% survival will be there, and then first stage 1 98% survival rate, and stage 2 88% survival rate, and stage 3 52% survival rate, and stage 4 16% survival rate will be there. The biology difference with the TNBC, it is normally grow and spread more quickly than other type of breast cancer. Because of this, the triple negative breast cancer is considered to be a more aggressive than other forms of the breast cancer. How to treat the triple negative breast cancer? The triple negative breast cancer often present in an aggressive manner within an advanced stage at a diagnosis and propensity for the development of distant metastasis. What is the definition about this? Conventionally, a breast cancer that does not express the estrogen receptor, progesterone receptor, and HER2 accounts for approximately 20% of the breast cancer. It will be incident of the rate is African American and Hispanic and premenopausal women, and those with BRCA1 mutation persons is getting for this triple negative breast cancer. The evaluation in this breast cancer is the estrogen receptor, progesterone receptor, human epidermal growth factor. HER2 means human epidermal growth factor 2. And see, now metastasis time we have to evaluation this diagnosis. Complete blood count and platelet count, alkaline phosphate, liver functional test, chest x-ray, bone scan, CT scan of chest, abdomen, pelvis, and MRI, and PET-CT scan we are doing. Triple negative treatment protocol is the conventional approach. Another one is novel target approach. This conventional approach, surgical and radiotherapy we are doing. Here lumpectomy, mastectomy followed by the radiation. Chemotherapy already discussed here, taxane and anthracycline and cyclophosphamide, 5-fluorouracil and methotrexate and abiraterone, and then paclitaxel and platinum salts and carboplatin and cisplatin. And then here target therapy we are seeing here PRP inhibitors, and then immunotherapies, and then antibody drugs we are using in this. Cancer treatment option is the surgical, chemotherapy and radiation. Normally chemotherapy combination we are giving for the triple negative, as well as the HER2 is the positive or negative. Target therapy we are giving, target therapy plus chemotherapy also we are giving. Next generation target therapy and immunotherapy we are giving. Now we have to discuss the what is neoadjuvant therapy. Neoadjuvant therapy means when drug therapy is given before surgery, it is called neoadjuvant therapy. Often used to shrink the size of the tumor enough to make the surgical removal possible, to allow for breast conserving surgery. Adjuvant therapy means drug therapy after surgery is called adjuvant therapy, to decrease the rate of recurrence and increase the length of survival. Those who are hormone receptor negative with a larger or more aggressive tumor risk for recurrent or metastatic disease. Benefit of the drug therapy is a complex process. Now we have to see this neoadjuvant versus the adjuvant therapy, different the treatment setting. Now we have to see the very big tissue. First, what we have to do, neoadjuvant CT to reduce the tumor size. Then first chemotherapy we will give. After that, it is reducing the tumor size. Then surgical intervention they will do. They will remove the tumor. Then again they have to do for the hormonal therapy or further treatment will be takes place. Here also that is a neoadjuvant. Adjuvant means here what they will do, they have to do for the after surgical intervention. Then again we have to do for the chemotherapy or radiation therapy. Okay. This is the multidisciplinary this thing, and surgical therapy, breast conservation surgery, mastectomy, total mastectomy, and then sentinel lymph node biopsy and axillary lymph node mastectomy. Mastectomy is a simple node, simple mastectomy, modified radical mastectomy. Another one is radical mastectomy. In that nipple sparing mastectomy we are doing. Then seeing the lumpectomy, it is a simple mastectomy. This is the total modified radical mastectomy, means total mastectomy we are removing of the breast and associate the lymph nodes also, removing this total mastectomy, modified radical mastectomy. And after surgery or 1 year we will see the mammoplasty also doing. Breast reconstruction and skin sparing mastectomy also there. Then surgery, this is the conserving surgery. First we have to see that we have to give for the radiation, then followed by the surgery. Then this is the adjuvant and chemotherapy to reduce the chance of the cancer, and targeted drugs is the olaparib we are giving. And then oral chemo drugs also we are giving, that is the capecitabine. And then after surgery, the adjuvant treatment reduce the chance of the cancer coming back. Target therapy also we are recommending. And fourth, triple negative breast cancer we are seeing here, most probably the chemo drugs might be used alone or in a combination, like cisplatin, carboplatin, and target drugs are the PRP inhibitors are giving. And then immunotherapy and surgical and radiation may also be option. Radiation therapy one of the option. External radiation, brachytherapy, and palliative radiation we are giving. External beam radiation, brachytherapy, internal radiation therapy, and proton beam therapy we are giving. Next, systemic therapy, chemotherapy, hormone therapy, immunotherapy, target therapy. This chemotherapy and need not to be explained more than that. 3 to 6 months we are giving this, and then patient better status chemotherapy may be given for the rest of the patient file. See here 3 cycles is there. It is a combination medication we are giving, cyclophosphamide and then methotrexate and 5-fluoroxyl we are giving. And second cycle is the cyclophosphamide with or without additional paclitaxel, docetaxel we are giving. And then third cycle it is ebirubicin we are giving. Now side effects, bone marrow anemia and cognitive changes and memory loss, and then attention will be the hair follicle aphasia will be seeing. Immunotherapy normally we are triple negative breast cancer, chemotherapy, and sometime immunotherapy also recommended, mainly treatment. Target therapy we are giving for the olaparib, talzoparib. Next is the metastatic breast cancer. If the cancer has spread to the part of the body other than the breast and then other parts of the body, it is called the nursing assessment. We have to see that all symptoms, whatever it is, a subjective data and objective data, we have to see from the patients. and then diagnostic acute pain related to the tumor and compress on the nerve ending, anxiety related to the diagnosis of a breast cancer, anticipatory grieving related to loss and possible or impending death, disturbed sleep pattern related to pain and anxiety, disturbed body image related to loss of a body part, sexual dysfunction related to body image or self-esteem. Here, radiation therapy already discusses this all things, and no need to be explained again. And the patient education, what we have to recommend the patient education. The patient is going home and then empty the drain and receptacle twice a day and record the amount on a flow sheet and take this information along when keeping the doctor's appointment. Sponge bath, avoid the caffeinated foods and review that pain medication. Teach the precautions and request to know blood pressures and or blood samples from the affected area. Do not carry the baggage and handbags or luggage, and protect the hand or arm from the burns and the stick and the cuts, and report swelling, pain or heat in the affected arm and immediately. When to see the doctor? If the your self-examination, any lump or the breast can be sign of the cancer. A lump or a testicle means you have to see that. Early diagnosis means high curable rate and better survival rate. See steps to ensure early detection of the cancer. To prevention this, eat healthy, to avoid the junk food, and then you have to be maintain a healthy weight and add exercise into your routine, and limit the alcohol intake, limit menopausal hormone use, and breastfeed if you can. And then 50% of cancer can be prevented by eat well and maintain the weight and BMI rate, exercise well, and then build awareness and dismiss the myths. Pay attention to symptoms, ensure timely diagnosis, stay positive for treatment, have a healthy lifestyle. Thank you.
Thank you, ma'am, for your intuitive presentation. It was very subjective and informative. So our next speaker is Mrs. Ranganaiki L, Professor, SGRD, College of Nursing.
Mrs. Ranganaiki L, Professor Medical Surgical Nursing at SGRD College of Nursing. She has done her UG and PG from DRMGR Educational and Research Institute, University in Chennai, Tamil Nadu. She has also done MSc Psychology from Tamil Nadu Open University, Chennai. She has total 20 years of experience, from which 15-year experience after PG. She has presented papers in various national and international conferences. She is a research guide to PG and UG students. She has published articles in various journals. She is a member of ONI and NRSOI. She is examiner for PG and UG students.
माइक एडजस्ट करके जाओ ना कर देना very good evening to all our dignitaries and our principal ma'am and all faculty members and my dear students. So now the topic of presentation is reconstructive surgery in breast cancer patient. Breast cancer and other main types of gynecological cancers are cervical, ovarian, uterine, vaginal, and vulvar cancers. So, what is the reconstructive surgeries? It is the surgery done to reshape or rebuild the site or body part previously undergone the surgeries. But in case of the breast reconstructive surgeries, so the breast is reshapen or rebuilt by using the implants or otherwise using the tissue plaque. In final stage of the breast reconstructions, nipple and areola is reconstructed in the reconstructed breast. The breast reconstruction procedures, it will give the psychological feeling to the patient who is having the emotional distress of having the treatment for the cancer and the surgery procedures. So it also, this surgical procedure of reconstruction of the breast is very safe to the elderly persons with breast cancer. The breast reconstructions can be done immediately and also in delayed manners. Immediate breast reconstruction is done at the time of the mastectomy surgeries. So it has advantages of avoiding the multiple surgeries and hospitalizations. It gives better cosmetic results. So decrease the risk of social and emotional difficulties of having the breast cancer treatment. So it is very cost effective to the patient. It is a preferred choice by the patient and most of the surgeons. It restores the breast without increasing the breast cancer recurrence rate. The disadvantage is longer hospitalization and the recovery time than the mastectomy alone, and also the more scarring it is there than mastectomy alone. Delayed breast reconstructions, advantages and disadvantages are, so it allows the additional cancer therapy like radiations, and it gives the more time for the patients for going the options for further reconstruction surgeries. So disadvantages, so it requires additional surgery, hospitalization, and it is having the further recovery time. Or on surgical site, it leads to difficulty in reconstructions in future life. So it is giving the less cosmetic result after the breast reconstruction. There are two types of breast reconstructions, that is breast tissue expander and implant procedures. It is most commonly used method, and also tissue flap transfer procedure also used most commonly nowadays. So that the tissue flap transfer procedure, it is also called as the autologous tissue breast reconstructions. In this, the own patient tissues from other body is used to reconstruct the breast after the breast cancer mastectomy surgery. Tissue expander and implants. So in this, the tissue expander is placed initially. So the surgically created packets after the mastectomy. So ideally under the pectoralis muscles. So initially during the surgery, the packet is instilled with the saline or the silicons for little expansions, and weekly it is inflated with the salines for 6 to 8 weeks. So until gaining of the ideal size of the breast packet per implant. So it can be done as a delayed and immediate or permanent and temporary purpose. So this is the picture showing the breast implant. So when the patient undergone the breast expander and the breast implants, so patient will be having the pain at the surgical site and also the loss of sensation in the arm, and assess the surgical site for any complications, and apply dressing and supportive bra at the constructed breast. Do not get dressing wet for 48 to 28 hours. This should be informed to the patient, and the patient can take the full shower after 48 hours of removal of the drain. The patient can do the normal activities after the each tissue expansion procedures, that is weekly performed. Patient should avoid the strenuous activities for 6 weeks after the surgery. So in the implants, once the ideal size of the the packet, it is achieved in the reconstructed breast. The implant is placed. So the implant, it can be used for the permanent purpose and also in temporary purpose. It can be used alone or it can be used along with the flap tissue surgeries. So this is the silicone implant. The picture is showing the silicone implant. So according to FDA, the women with a silicone implant undergo the periodic MRI screening to detect the silent rupture of implants. Possible complications: infections, seroma, hematoma, formation of the blood clots at the surgical site, in blood vessels of reconstructed breast and also in the extremities, changes in the nipple and breast sensations, implant leak or rupture may take place, and also the expulsion of the implant through the skin in reconstructed breast, the contracture which will take place around the implanted skin of reconstructed breast, then the rare anaplastic large cell lymphoma which will take place. So coming to the second reconstructive surgery of the breast, that is the tissue flap surgeries. So here already I told one tissue is used to reconstruct the breast of patients. So advantages: it gives the more natural look for the breast tissues, maybe more natural breast shapes after using the implants. Coming to the disadvantages, it needs the multiple surgeries, longer hospitalizations, and also the surgical site core is higher. This is the example of the tissue flaps, that is pedicle flap and also free flaps. These two common flaps used in breast reconstruction surgeries. The most commonly used flap is the flap from the abdominal walls. So in pedicle flap, that is the skin, tissues, fat and the muscles with intact blood vessel is removed from the donor site and that is mobilized to the breast for reconstructions. Pre-flap surgeries, here the microsurgery is used to reconnect the blood vessels in the area of the breast, but here the blood vessels and tissues and the skin, fat and sometimes muscles may be detached from the donor site and then it is attached. Commonly used donor site for the pre-flap breast reconstructions. Most commonly used one is abdominal wall and also the back muscles, buttocks muscles, and also the deep inferior epigastric posterior flap and the superficial inferior epigastric artery flap. The flaps and taken from the thigh and buttocks, it is most commonly used for using the free flap in breast reconstruction surgery. This is the picture of deep inferior epigastric perforator free flap. The complication of tissue flap breast reconstruction surgeries, it carries the same complications what I told in the implant and expanders, but the fat tissue necrosis or the flap necrosis which will take place when the blood clot developed in the blood vessels of reconstructed breast. Nipple reconstructions, the nipple reconstructions they will use by using the skin graft. The graft can be taken from the groin, axilla or other nipple to create the new nipples. So here they need the 3D nipple and areola tattoo. Tattoo means you know that it is coloring. So the coloring of the nipple and areola they will do in this for giving the natural colors. So here first the nipple is reconstructed and later they will go for the areola reconstructions. The breast conserving surgeries. So here the breast lift surgery they will be using. So it is used to raise the breast for reshaping the breast. Breast reduction mammoplasty also done in after the mastectomy patients in cancers. The breast augmentations, it enlarges the breast by placing the implant. The implant surgery already we have seen. So preoperative managements, it is common, all preoperative managements it will be carried here also, but the detailed educations and written demonstrations and guidelines should be given to the patient as well as the family members, and explore the feelings and distress and advise the patient and family members to ventilate their feelings. So these are all the preoperative interventions. Post-operative care, all the critical interventions should be carried out during the immediate post-operative period after the breast reconstruction surgeries. So monitoring hemodynamic status, vital signs and SpO2 monitoring, maintain the respiratory patterns and hydration status, maintain fluid balance and maintain intake and output chart. So assess the surgical site, both donor and the reconstructed site for any complications like bruising, discoloration, swelling, hematoma formations, any seroma or excoriations. So, and also the changes in the temperatures. Assess the level of pain and administer the analgesics. Usually non-narcotic and narcotic analgesics can be administered here. And the patient should be placed in semi-fowless positions and the arm should be elevated with the using the pillow. So take care of the surgical drain and care of the CVP catheters and also the IV line should be kept patency. Take care of the Polish catheter and care should be provided to the catheter site. So provide the skin care, mouth care and the change the positions frequently to avoid the skin complications. So flap follow-up care, it is much important in the breast reconstruction surgeries, especially in the flap tissue transplant surgery patient. So monitor the flap for every 15 minutes. So in post-recovery rooms and also in the ICU and hourly in the first 48 hours and every 4 hours for the next 48 hours. Evaluate the flap area for any abnormalities like signs and symptoms of infections. So next, normal flap color should be assessed. It should be reported. The pink color is the normal color. If any other colors, it should be noted to the surgeons. Assess capillary refill. Post-operative exercise is much important here. So it should be started in the recovery rooms. Flexion extension of the fingers in the surgical side can be done. Arm and shoulder exercise should be instituted in later period to prevent the contractures, improve the circulations and to improve the venous drainage. So the pain will be very severe to the patients. It will cause the frustrations and the depressions. So we have to give the pain medications 30 minutes before starting the exercises. Patient will gain the full range of motions within the 4 to 6 weeks of properly performing the exercises. Patient should be kept warm with the blanket. So there is a probe to monitor the flap temperatures. So if the probe showing the 2 to 3 centigrade less than body temperature means it should be reported. Advise the patient to report any abnormalities if they felt during the post-operative period. So monitor the post-operative complications like pulmonary embolisms or DVT, UTI, surgical site infections, etc. Be aware of the cultural and spiritual values of the patient. So arm lymphedema, it is much important in this. So in management of the arm lymphedema, so massage technique used to mobilize the subcutaneously accumulated fluid. So compression bandaging and intermittent pneumatic compression sleeves can be used that improve the circulations and improve the venous drainage. So during walking, patient should be use the fitted compressive sleeve. So arm should be elevated with arm levels when they sit. So the diuretics and other isometric exercise can be performed to improve the venous drainage. So patient will have the psychological distress. So it should be given importance to the patient as well as the patient relatives. If you identify any psychological distress symptoms, immediately patient should be given the psychological support and the referrals should be done if it is acute to the mental health care providers. Help the patient to meet the psychological need, provide the environment for expression of their full range of feelings. So help her to identify the resources of support and strength, such as allowing patient to communicate with the spiritual leaders, community leaders, family members and friends. So improving the patient coping strength by using the other available resources, promote communications, effective communications. The next, ambulation and home care emphasis, that is referral services to home care, day care and palliative care settings. Reconstructive surgeries in cervical cancers. After surgical cancer radical resections, So the adhesions will be removed between the vaginal stump and the rectums as well as the bladder. It improves the quality of cervical cancer patients after the cervical surgery. Vaginoplasty with the peritoneal flap is most commonly used surgical constructive procedures for the cervical cancers. Vulvar reconstructions after the vulvectomy in the vulvar cancers, it will remove a large area of the skin from vulva and requiring skin graft from other parts of the body to cover the wound in the vulvectomy areas. So these are all the references. Thank you.
Thank you, ma'am, for sharing factual details with us. It is a wonderful presentation. So I would like to call Mrs. Shilpa Bhosle, TMH Mumbai, as our next speaker.
She done her PG in Medical Surgical Oncology Nursing from College of Nursing, Tata Memorial Center, Mumbai. She working as permanent staff nurse in SIRJ.J group of hospital, Mumbai. She delivers speech on male sexual dysfunction in urological cancer at TMH on April 2022. She participated in 4th Asian Oncology Nursing Society Conference and participated in workshop on public health. She is a member of ONI, TNAI. She published case report ganglioma of urinary bladder in India Journal of Oncology Nursing. She conducted research study to assess the effect of pelvic floor muscle strengthening exercise on urinary incontinence in patients with cervical cancer undergoing radiation therapy. Her research study is being selected for e-poster presentation at ESGO at Berlin, Germany.
Good evening, all. Hello. Good evening, all. I am Shilpa Bhosle from Tata Memorial Hospital. We conducted small pilot study on a study to assess the effect of pelvic floor muscle strengthening exercises in patient with cervical cancer undergoing radiation therapy at Tertiary Cancer Center. Investigator Ms. Shilpa Bhosle, Principal Investigator Mrs. Pratibha Jagdish, Associate Professor, College of Nursing, TMH, Co-Principal Investigator Dr. Lavanya Naidu, Associate Professor, Radiation Oncology, TMH, Dr. Supriya Chopra, Associate Professor, Radiation Oncology, TMH, Dr. Anuradha Daptardar, Office In Charge, Physiotherapy Department, TMH. Introduction. Please listen. Topic. Cervical cancer is one of the most common dead-risk disease of women. It accounts for 16% for a total cervical cancer cases occurring globally. According to GlobeCam, in 2020, an estimate 5,70,000 women were diagnosed with cervical cancer worldwide. About 3,11,000 women died from the disease. Urinary incontinence is one of the most common health problems confronting in a patient with cervical cancer. One of the vital treatment for a cervical cancer is a radiation therapy, that is external beam radiation therapy and intracavity radiation therapy. Radiation therapy have a greater effect on a pelvic floor, such as actinic effect. It shows major symptoms of urinary incontinence, that is 4 to 76%. During the cancer treatment, atrophy and length shortening may be occur in a pelvic floor muscle. The pelvic floor muscle strengthening exercise
is benefited in treating the urinary incontinence in patients with cervical cancer, and it is an economical intervention. Need for the study: urinary incontinence is the one of the most common health problem. Urinary incontinence leads to reduce quality of life and cause social isolation and restriction lifestyle. Radiation therapy is also aggravate in a urinary incontinence in women. Pelvic floor muscle strengthening exercise, it helps to prevent and control urinary incontinence by strengthening and tightening pelvic floor muscle and vaginal muscle. It helps to improve quality of life and independence of daily living. It is a evidence of pelvic floor muscle strengthening exercise to prevent urinary incontinence. It is an international recommendation. No study available employing pelvic floor muscle strengthening exercise intervention in a patient with cervical cancer with radiation therapy at a tertiary cancer center. Objective of our study: to analyze the effect of pelvic floor muscle strengthening exercises on a prevention of urinary incontinence in patient with cervical cancer undergoing radiation therapy at a tertiary cancer center. Our secondary objective: to find the incidence of urinary incontinence with regards to clinical data at the time of diagnosis and a plan of radiation therapy. Then our third objective: to find the association between urinary incontinence and clinical data. Hypothesis of our study: there will be null hypothesis. There will be no significant difference in reduction of urinary incontinence in patients with cervical cancer undergoing radiation therapy post pelvic floor muscle strengthening exercises. And research hypothesis: there will be a significant difference in reduction of urinary incontinence in patients with cervical cancer undergoing radiation therapy after pelvic floor muscle strengthening. Research methodology: our research approach was quantitative research. Research design: we used experimental research design. Research setting: our research conducted in general and private gynec OPD of Tata Memorial Hospital, Mumbai. We selected population patient with cervical cancer, planned radiation therapy according to National Cancer Grid guideline. Total dose plan was 5 weeks with external beam radiation plus 2 weeks brachytherapy. External beam radiation, that is 40 to 50 grays in 4 to 5 weeks, combined with brachytherapy application, with together delivered dose equivalent 80 grays to point A, with injection cisplatin 40 mg per meter square with appropriate hydration weekly during the external radiation. Sample: we taken sample from cervical cancer patient who underwent radiation therapy. We screened 2,600 population. From that, we selected 45 sample. Sampling technique: we used convenient sampling technique. Inclusion criteria of our study: age more than 18 years and age less than 65 years participants with the cervical cancer. Then second, who had radiation therapy as per National Cancer Grid guideline. And third, receiving concurrent therapy. Fourth one is who were able to perform pelvic floor muscle strengthening exercise. Then exclusion criteria of our study: cervical cancer with stage 3C and stage 4 because it involved the bladder. Then second one, cervical cancer involving urinary bladder. Third one, who had undergone surgery of a female reproductive organ. Fourth one, patient who were mentally unsound. Then data collection tool: we used ICIQ UI short form, that is International Consultation on Urinary Incontinence Questionnaire, urinary incontinence short form. This is the subjective tool. It consists of quantitative, frequency, as well as quality of life questionnaires. Also, we use the objective tool, that is perineometer. A perineometer is a Kegel perineometer or a vaginal manometer. It is an instrument for measuring the strength of voluntary contraction of pelvic floor muscle. We got institutional ethical approval letter from February 24th, 2021. Then we got Clinical Trial Registry of India approval
on a 30th March 2021. After that, we started our research. Our intervention was pelvic floor muscle strengthening exercise. First, we demonstrated to the participant exercises. Also, we shown the models and given a pamphlet to the participant. It consists of Kegel exercises as well as squeeze and release exercise. That exercise we given in sitting position, sleeping position and lateral position. Third one, pelvic floor inner thigh ball squeeze exercise. And fourth one is a lower trunk rotation, that is lying on hip rotation. I will give this pamphlet. Then next. Data collection process. After CTRI or IEC permission, we started data collection. After getting the fund from the track, data collection was started from 5 April 2021 to 27 August 2021. Participant information sheet was provided to the participant in English, Hindi and Marathi language. Participants were given sufficient time to make decision regarding the participation. Then we taken informed written consent from a participant. Then pre-assessment done with the case record form, ICIQ UI SF tool and objective tool, that is perineometer assessment we did. Then after the intervention on pelvic floor muscle strengthening exercises was given to the participant at the Gynaec OPD for a 12 weeks we given. Then post-assessment intervention we did on 8th week as well as 12th week with the help of ICIQ SF tool and perineometer. The result and discussion. Distribution of subject according to their demographic data. This bar chart shows that maximum 77.8% participant having age group of 41 to 62 years. Then qualification level, that is education level of participant. Maximum 64.4% participant have completed basic incomplete education. Then distribution of subject according to their clinical data. 100% participant were multiparous women. Then BMI of a participant, maximum 56% participant have a normal BMI. Then 18% participants was overweight. Then mode of delivery of participants, 95.6% participants had normal vaginal delivery and 4.4% participants had LSCS. Then comorbidities of participants, 28.9% participants were suffering from the constipation as well as 13.3% participants suffered from a diabetic mellitus. The stage of the disease of a participant, 53% participants were having 3B stage of cervical cancer, 40% participants had 2B stage of cervical cancer, 5% participants have 1A stage of cervical cancer, and 2% participants had 2A stage of cervical cancer. Then analysis effect of pelvic floor muscle strengthening exercise on a prevention of urinary incontinence. Distribution of pre-test and post-test ICIQ SF score on a pelvic floor muscle strength. According to this table, average frequency of urinary incontinence pre-test mean was 2.88. On 8th week after the intervention, 8 week average frequency of urinary incontinence was 2.6%, 2.6. Then on 12th week, that is 1.88. That p-value is statistically significant. Then amount of urinary incontinence on pre-test mean was 3.30%, 30. Then on 8 week 2.84, on 12 week 2.23. The p-value is statistically significant. Then impact of urinary incontinence on a quality of life.
Pre-test mean was 6.37, on 8th week 5.93, or on 12th week 4.74, and p-value statistically significant. Then distribution of a pre-test and post-test on perinometer score on pelvic floor muscle strengthening exercises. On pre-test pelvic floor muscle strengthening mean was 21.63, on after intervention 8 week 22.33, on 12 week 23.49. According ANOVA test, p-value is statistically significant. Means after giving pelvic floor muscle strengthening exercises, the urinary incontinence is decreased, and that is statistically significant. Then correlation between pelvic floor muscle strengthening strength on perinometer and urinary incontinence. There is a significant correlation between pelvic floor muscle strength and urinary incontinence. Because of we are giving pelvic floor muscle strengthening, urinary incontinence is decreased. Then analysis of incidence of urinary incontinence with regards to clinical data. The 66.67% participant was in mild urinary incontinence. Then association between urinary incontinence and demographic data. There is no association between age of participant and a urinary incontinence. Also, there is no significant relation between education level and the urinary incontinence. Same as there is no significant relationship between or association between parity and mode of the delivery. Now we'll see association between urinary incontinence with regards to stage of disease. Then conclusion of our study, pelvic floor muscle strengthening exercise statistically significant, improved contractibility of pelvic floor muscle, and it is effective for preventing and alleviating urinary incontinence, which improve the quality of life of a patient patient with cervical cancer undergoing radiation therapy. Patient quality of life and comfort is important nursing, and the finding of this study suggests that pelvic floor muscle strengthening exercises could effectively prevent and reduce urinary incontinence in patients with cervical cancer undergoing radiation therapy. Simple nursing intervention in reducing pelvic urinary incontinence and strengthening of pelvic muscle floor can be clinically effective and cost effective. Also, it helps to improve the quality of life of the patient with a cervical cancer undergoing radiation therapy. Recommendation of our study, good clinical practice guideline can be prepared to pertain care of cervical cancer client undergoing radiation therapy, establishing a standard protocol for the management of urinary incontinence by performing pelvic floor muscle strengthening exercise in patient with cervical cancer undergoing radiation therapy. Pelvic floor muscle strengthening exercise should be added to routine care, and publishing the booklet improve the knowledge and skill among the nurses. And these are the references. Thank you so much to ONEI, also this hospital, as well as our principal investigator. Thank you so much.
Thank you so much, ma'am, for making this session even more special with your great presentation. Next, I would like to call Mrs. Reena Nayyar, Treasurer, ONAI, ANS, TMH, Mumbai.
She has done MSc Oncology Nursing from Homi Bhabha, a National Institute, Deemed University. She has done research on problems faced by young adult cancer survivors and conduct workshop on nursing research. She has presented poster at international level in Dublin, Ireland. She has attended various courses. She is working as assistant nursing superintendent at Tata Memorial Hospital. She had worked as staff nurse at Oncology Department at Tata Memorial Center and at a Bombay Hospital and Medical Research Center.
A very warm good evening to all of you all. And I know it's the last session and all of you all are bored, isn't it? So I'll go very fast. Before that, only few people are there. So just we will do a quick exercise. All of you all get up on your seats. Stand up. Sit down. Once again, stand up and sit down. Yeah. Thank you so much. So I think all of you all are awake, back to the session. So first of all, I would like to thank the organizers of ONI and the College of Nursing of Sri Ramdas University for giving me this opportunity. Today we will be dealing with, my topic is on development and understanding of cervical cancer. So to begin with, I'm sharing a paper cutting with you all, which says that it is a 2018 paper cutting of Times of India, which says that socioeconomic inequalities is a major cause of rapid rise in cancer cases in India. And you can see the number of cases which have been listed, in which cervical cancer is 97,000 cases of cervical cancer are detected. Okay, new cases of cancer 1.16 million, and deaths due to cancer, this is overall cancers, 7,84,800. So in that, amongst that, cervical cancer which were diagnosed is 97,000. Okay, now the global cancer burden is 5 lakh women are diagnosed each year, out of which 2,70,000 deaths per year. More than 1 million cases of cervical cancer cases are detected each year. Out of 1 out of 4 women who die due to cervical cancer in the world is an Indian. Okay, so it is alarming for us to know that in India we have so many cervical cancer cases which can be prevented. That is the reason why we are conducting lectures, so that people are more aware about the preventive methods and it can be percolated in the society, so that we can save many women from contracting this disease. So the cervical cancer disease burden in India. India has a population of 4,36,000,000 women aged between 15 years and older, who are at risk of developing cervical cancer. India accounts for 1/4 of cervical cases and deaths worldwide. 1,22,844 new cases are found in India, out of which second common cause of which is cervical cancer is the second cause of female cancer, and second most female cancer of the woman between aged 15 and 44. Now approximately 185 women die every day, in which 8 women die every year and a woman dies every 8 minutes. So it is an alarming thing which we should be knowing. So what is cervical cancer? Coming to the main topic, what is cervical cancer? Cancer which affects the mouth of the uterus. I hope all of you all know that cancer is where the uterus ends and the vagina starts. It is the mouth of the uterus. So to define, all of us are seeing what is the definition of cancer since morning. Just it is the same with the cervical cancer also. And now a small, just a refresher of anatomy. The cervix is the narrow lowest portion of the woman's uterus. The cervix connects the main body of the uterus to the vagina. As I had told that cervix is the mouth of the uterus. So it is the part which connects the vagina to the uterus. Okay, it is in between. So you all can see here, this is the cervix. Okay, you all can see that over there. Okay. So the cervix is divided into 2 parts, that is endocervix and the ectocervix. Endocervix is lined with the columnar epithelium, and ectocervix, which is outside, that is formed by squamous cells. And here, this is very important, that is a transformation zone where most of the cervical cancers are found, like the cells are detected over here. This is a transformation zone. It is also called as the squamo-columnar junction. Okay, here the cells in the endocervix is of columnar cells and the ectocervix is squamous cells. But here when there is a not see the arrow. See this green part, no, sorry. This green part is where the transformation from the columnar to the squamous cell takes place. During that time only there are many changes, and if the person is infected with HPV virus and all, that time there is changes in the cell which can be converted to cervical cancers. Okay, this transformation zone is very important, which is in green color. So what are the causes of cervical cancer? Mainly it is infection with HPV. As in the previous head and neck session also we have seen that HPV is one of the common causes of oral cancers. Similarly for cervical also HPV is one of the most common causes. But one thing we should know, that most of the time HPV infection disappears without treatment. So it is not necessary all those who are infected with HPV will be having cervical cancer. Sometimes it will get automatically resolved. However, HPV stays in the cells for years, and in some women eventually it causes cervical cancer. So there are many types of HPV viruses, but which type are most commonly which causes the cervical cancers are HPV 16 and HPV 18. So what are the risk factors? As we have already seen, what are the risk factor? Main risk factor, human papilloma virus. Then people who have initiated in sexual activity before the age of 15, that is early initiation of sexual activity. Then infection to herpes, having multiple full-term pregnancy, having multiple sexual partners, taking oral contraceptive for many years, smoking, exposure to diethyl salbustrol, and these are some of the reasons which can lead to cervical cancer. Now, what are the signs and symptoms? Now, usually it is pain in the pelvis, lack of appetite, unexplained weight loss, fatigue, heavy vaginal bleeding, pain in the back and legs, bleeding during pelvic examination, or bleeding during sexual intercourse, blood-tinged vaginal discharge with a strong odor. People with cervical discharge, their discharge will be having a very foul smell. Okay, these are some of the signs and symptoms which the person will be suffering from. These are same thing. Then to pathophysiology, if the patient is infected with HPV virus, usually it clears in few years, or if the person is having a low immunity, it may persist, and the persistence may lead to progression. Persistence may lead to progression and may go to high grade CIN, or then which may be followed by, which may go to carcinoma. The incubation period may be till 15 years. So after the HPV infection, it may take around 15 years for the women to be diagnosed as case of CA cervix or CIN. Okay, CIN is not cervical cancer. We will see that in detail. Okay. So how do we diagnose? How do we investigate? What are the investigations done? The investigation done, a pelvic examination is usually done, then pap smear we do, and in the pap smear we will see the changes, that is low grade SIL and high grade SIL. This is same, this we will explain later. That is cervical intraepithelial neoplasia. Here you can see the diagram. CIN1 only slide, there is dysplasia is there. In the CIN2 a little more, and CIN3 it is more dysplasia is there. But one thing we have to remember here is CIN3 is not carcinoma. It is not going to, this can be still be repaired. Okay, but once the CIN3 is going further, the cells are being more damaged, then it is going into the other parts, then it will become carcinoma. Okay, here you can see CIN1, CIN2, CIN3, and in the CIN, I think the down part you can, after CIN3 you are not able to see, but here it is extending, the cells are getting extended forward, okay, more towards inside. So then how do we, other diagnosis tests are VIA and VILI, that is VILI and VIA. That is, VIA is acetic acid, that is white vinegar is used, and VILI is Lugol's iodine is used. This procedure is very simple, and it is done on the community basis, also. Okay, here we are applying in the vinegar swab to the cervix and look for change in the color, that is acetic acid. Okay, VIA. In that, how do we know which it is negative or positive? There are aceto-white area is not present, that is negative, and if it is aceto-white area is present, then it is positive. Okay, and here when we are doing with Lugol's iodine, because of the presence of glycogen in the cells, it will be brownish in color, whereas the cancer cell will not have the glycogen in it and it will become yellowish color. And Willi is done mostly when the VI is positive. Okay, when the test is positive with acetic acid, then we will do with the Lugol's iodine to confirm it. Okay, then other tests to confirm is colposcopy, endocervical biopsy and cone biopsy. This is a colposcopy in which the colposcope helps to visualize and the biopsy can be done. Then this is the cervical biopsy, and the other tests are usual tests what we are doing for cancer. I am not telling in detail. Then the types of cervical cancer, some squamous cell carcinoma, adenocarcinoma and mixed carcinoma. Now the staging, as in all cancers, the staging is similar only, but little bit, that is stage 0 carcinoma in situ, intraepithelial carcinoma, stage 1 carcinoma confined to the cervix, stage 2 carcinoma extended beyond the cervix and not to the pelvic wall, and stage 3 carcinoma extended to the pelvic wall, stage 4 carcinoma extended beyond the true pelvis. Okay, this is how the staging is done. Then what are the treatment options? Usually most of the cancer has same treatment options. What are they? Surgery, chemotherapy, radiotherapy and immunotherapy. Okay. So in the treatment for surgery, we have ablative surgery, that is cryotherapy, and carbon dioxide CO2 laser beam. So in cryotherapy we will use minus degree temperatures, and we will the probe is kept in the cervical region to ablate the cells which are not cells which are positive, and they after for few days the patient will be having vaginal discharge which is yellowish in color, whereas CO2 laser beam is also similarly used in which the heating is done with the laser beam, and thus the cells are being reduced. Okay, the treatment is done. The other surgery, the conization is done. This is a cold cone biopsy is done and taken in the conical fashion. The fashion, the surgery is the part which is affected is removed, and this is loop electrosurgical excision. It's a loop type, and they will remove the cervix which is affected. Okay, cervical part which is affected. Then hysterectomy, there are different types of hysterectomy according to the stage. The hysterectomy is done. Then a radical trachelectomy, in this surgery, this is done for patients who want to conceive. So here the only cervix is removed, and the band is placed which plays a role of the cervix, so that if the woman wants to conceive, she can also conceive. Okay. Then accentration, whichever part is affected, everything is removed, and the other thing if the urinary bladder is affected, then we have to place a ileostomy. Okay, the radiation therapy, again with the recent advances, the different types of radiotherapy is being used, like IMRT, IGRT, and in so that can be used in teletherapy. So conformal therapy is given only to the part affected. We can give maximum radiation so that the other areas are not being affected. The other is we are using brachytherapy, which is used in cervical cancer, and there are different applicators that are being used to provide maximum radiation to the part which is affected, and hereby protecting the other organs. Now, I'm not reading all those because I know all of you all are bored and sitting just because you all have to sit. Okay. Okay, then a medical treatment, we chemotherapy is paclitaxel plus cisplatin plus paclitaxel plus bevacizumab is given. Then cisplatin plus radiation therapy. We have seen in the previous lectures, which is the combination therapy, that is cisplatin plus radiation therapy. So cisplatin here is working as a radiosensitizer. So here the part is the cervix is being radiosensitized, and 5 days in a week they are giving radiation, and once they are giving cisplatin. Okay. Then here we have seen I am showing you a study which was conducted in Mangalore city. Here they have tried to find out the knowledge of the people. Here they have conducted the study among the nurses, and when they have conducted in other people, the knowledge among the people of the community related to cervical cancer is very less. So we have to promote that knowledge. Okay, so the most exciting development in the field of cervical cancer is the introduction of HPV vaccination, which can protect many of the women from contracting this HPV virus, which is highly effective and safe. So efficacy of the vaccine, HPV is induced lesions in cervical cancer, it is 98% protection. And the doses are for vaccination from 9 to 45 years, 3 doses, that is 0, 2 and 6 months are recommended, and it is well tolerated and favorably has a safety profile. So, can cervical cancer be prevented? Yes. By how can we prevent? By giving education, screening and vaccination. If you are not aware about vaccination, how you will take? So, we have to promote by giving education, and we have to promote people to have more and more screening camps so that we can identify it in an early stage and it can be treated. So, 3 simple steps is vaccinate, pap smear and HPV test. So, womb to tomb vaccinating women. So, the best prevention is early detection, because cervical cancer can be early detected and cured. Okay, so screening is very important in the case of cervical cancer. So, from the age of 30, screening should be started and till 60 years and can be continued. So, to summarize what all we have seen the global burden, what are the different signs and symptoms, what are the different treatment modalities, what are the surgeries done, and what is CIN? We saw what is CIN? Yes or no? Okay. So that's all. All of y'all should know that January is considered as the Cervical Cancer Awareness Month. So y'all can conduct some programs for it so that y'all make the community aware about it. Okay. Thank you so much for patient listening.
Thank you so much, ma'am, for being part of this symposium.
Now I would like to request Dr. Sushma Saini, Associate Professor 9 PGIMER, Chandigarh, and Dr. Manpreet Kaur, Professor cum Vice Principal SGRD College of Nursing, to honor our chairpersons, Dr. Raman Kalia, Principal Saraswati Institute of Nursing, Roopnagar, Dr. Raman Kalia, Principal Saraswati Institute of Nursing, Roopnagar, and Dr. Parvez Saini, Principal SGRD College of Nursing, Valla. I would like to request our chairpersons, Dr. Raman Kalia and Dr. Parvez Saini, ma'am, to honor our resource persons for this session. First is Mrs. Shrivani Kandola, NS, Indo-American Cancer Hospital, Hyderabad. Mrs. Ranganaiki, Professor, SGRD College of Nursing. Mrs. Shilpa Bhosle, TMH, Mumbai. Mrs. Shilpa Bhosle, TMH, Mumbai. And Mrs. Reena Nayyar, Treasurer, ONAI, ANS, TMH, Mumbai. I would like to thank you, our guest speakers, for enlightening us with their knowledge. Today's session was full of knowledge and interesting things. I thank you from bottom of my heart. Also, I want to express my heartfelt gratitude to all the guests and students present here. So this is the ending of session of day 1. Thank you.